One Health as additional director at National Center for Disease Control, that is NCDC. And I think I have worked with most of you, which is our own discipline, as well as veterinary sector, climate, environment sector. So it has been a very enriching experience. And of course, prevention and control of zoonosis is a challenge. So when I started my career in 2000, and that time, when we were doing this, it was then called, more popularly known as intersectoral coordination between various sectors, and nobody understood this concept. And it was mostly on the interpersonal basis. We used to call Indian Veterinary, from NCDC, call Indian Veterinary Institute, IVRI, or HSADL Bhopal then, or Ministry of Agriculture, some of the colleagues in ICR and the ministry, interpersonal. It started with interpersonal relationship when we needed help from them. And we always realized that in some points, in some ways, in some disciplines, veterinary sector was much advanced than the human sector. So there was need to collaborate. There was need to take help and for prevention and control of zoonotic diseases. From interpersonal, since we were talking to the ministry, various institute, it became inter-institutional. Then it became interministerial. And now, we understand One Health is a collaborative, multi-sectoral, transdisciplinary approach, to work at local level first, then at national level, then in regional level, and then it goes to global levels. So we are at least I'm so happy to see that we are at national level, at least we are doing something, and what is our goal for One Health? So it is optimal health outcomes that recognize interconnection between people, animals, plants, and their shared environment. So all together, it was initially, WHO took initiative of the tripartite, that is human, animal, and plants. I think we are now in a stage, at least to, if we are sort of making a policy, we are at policy stage, because there is a program for intersectoral coordination for prevention and control of zoonotic diseases. We should think of shifting to quadripartite, which includes animal health, human health, plant health, and environmental health. So with that in mind today, and with rich experience that I see of the various speakers in the inaugural session, I think it is time that I note down things to see what each one of you have to say. We know about One Health, but are we implementing it? Are we there where we should be? Now, that is the question, how to reach there. At least now we are sensitized to it, but this thing would be how to implement, how to reach there, how to, meet the global targets or set our own targets. India is self-sufficient. It is a continent itself. We have to set our targets and to see how we can implement One Health approach. And I would be very keen to listen to all the speakers here, stalwarts here, to tell us, to guide, to formulate some guidance from this this workshop, this conference, that we can give to Government of India as to how to effectively implement One Health approach. I won't call it approach. I think it's a philosophy. We have to get into that mode of philosophy, that we have to work for that. Unless it comes from our heart, we will not be able to attempt it fully, dedicatedly, and sincerely. So I want to note down those points that come from all of you stalwarts to give us directions as to how to take it forward. With those few words, I would like to invite Dr. Jugal Kishore, who is also the organizer, to give his remarks. Dr. Jugal Kishore.
Dr. Jugal Kishore has not joined as yet, so
okay.
You kindly continue.
So, okay, I think we will get his remarks subsequently, but it is absolute honor to invite Dr. Sunny Kaul, who is recipient of 2 European prizes and is currently director of lung division of Harefield Hospital at United Kingdom. His research interests include management of resistant ICU infections, vasoplegia, ECMO, weaning and non-invasive ventilation, delirium, and acute respiratory failure, COPD, comorbidity optimizations, and he's been member of several guiding writing groups and committees for Department of Health, British Thoracic Society, and Royal College of Physicians. He has qualified from University of Birmingham in 1995 with distinction. He has had his postgraduate training from Oxford, Leicester, and London, including PhD from King's. I welcome you, Dr. Sunny Kaul, and we are very eager to hear to you as to what is your thought about One Health and intersectoral coordination for prevention and control of zoonotic diseases. Over to you, sir.
Namaskar and good morning, everybody. Absolute privilege to be presenting to you this morning. It's a very murky morning in London. I think in India it's a much better weather, and thank God for it. At least some place has good weather in this world. Dr. Malaji, am I allowed to share the slides?
Yes, please. Yes, please. We are waiting for that.
Okay. Host disabled participant sharing. I'm unable to do this, I'm afraid. The host has not allowed me to share the slides. How do I get around that?
Dr. Kakru or Imtiaz, can we help him, please? Please enable him.
इम्तियाज डॉक्टर संदीप कोल को ये कर दो ना, शेयर करने का परमिशन.
ओके जस्ट मिनट.
इम्तियाज,
यस कर रहा हूं मैं.
सबको ऑन ही रख दो, बंद मत करो आज. वेलकम डॉक्टर कमलेश उपाध्याय. Just 1 minute, sir.
No problem.
Just for everyone, this is being streamed live also on the Zoom, YouTube. हो गया?
यस हो गया. प्लीज डू इट.
सबको ऑन कर दो जितने भी तुम्हारे पास लिस्ट है. डॉक्टर सनी, काइंडली स्टार्ट.
Thank you. I'm just waiting to see where this is. 1 second, sir.
Yes, it has started appearing.
Can everybody see my screen? Is that okay? Are the slides up, Dr. Malaji?
Yes, sir. Yes.
Yes, the slide, you can put them in slideshow mode. Is that possible?
I will. Is that
yeah,
okay?
That's perfect. That's perfect.
Okay. Once again, thank you very much for the opportunity to share some thoughts and ideas this morning and to deliver this incredible person's memorial lecture. Post-COVID syndrome is the title, and it's responding to the long-term effects of COVID. And I'm really giving a personal perspective here. Just to outlay the first 30 seconds is my experience in COVID is both in the hospital as well as in the acute phase as well as in the chronic phase. We're talking level 3 ICU, we're talking HDU, we are talking ward, we're talking home acute, and then we're talking post-COVID, and we're talking long COVID, whether ICU, hospital, or home survivor. And I'd like to just say that this is the focus of this talk is not just one sector. It is all patients, it is all relatives, it is all professionals from all disciplines. So, you know, everybody here. Very quickly, I will define it from our perspective, from where we work in England, as to what the definition is, what the long-term effects of COVID-19 are. Mainly, I'll focus on lung, but as you said, it's One Health. So I'm looking at the whole body, and then developing care for long COVID, the people, the processes, the infrastructure. I think an important caveat is, of course, evidence base is still emerging. So one has to be aware of the evolving and changing dynamic nature of this situation. And at the end, if I may, we will share a few, again, personal lessons and strategies that hopefully will prevent future large-scale mortality and morbidity. So quickly into it, and I promise to keep to time, Dr. Malaji, and please keep me in time if I stray by you know, any time at all. Acute COVID is the first 4 weeks. Ongoing symptomatic COVID is 4 to 12 weeks. And of course, post-COVID syndrome, as it's often called, is beyond 12 weeks, and where we don't have an alternative diagnosis. This is, of course, man-made. And of course, you know, this is not necessarily, you know, stuck in stone. Looking to COVID from a lung effect, I picked 3 here. You have interstitial lung disease, you have pulmonary hypertension, and you, of course, have small airways disease. Lung fibrosis, in a nutshell, as you know, is this declining lung function, is this worsening symptoms of quality of life, and increasing fibrosis classically on imaging. And of course, it comes in the context of many conditions, and everybody here will know this. But just to give us a feel for the long-term effects, if we look at other areas that have gone before us, and I think this is an important principle to look at conditions that have gone before us, to use them as a template, then the 15-year follow-up of SARS patients shows that the initial decline recovers over the first 2 years, and then it plateaus. So there's not a full recovery. And if you look at purely the CT or the imaging, about 5% 15 years will still show some interstitial abnormality. MERS is less well followed up, but if you look at this just under 6-week follow-up of 36 patients on a chest X-ray, then about a third of these patients have what is described as lung fibrosis. If you look at ARDS patients who are followed up by the Toronto group at 5 years, then at least about 3/4 of patients had some lung abnormalities. And the main abnormality at 5 years is this reticular pattern followed by ground glass opacification. So these are our forerunners to COVID, and each one of them has shown some abnormality on imaging and indeed functional decline. Look at Wuhan, the 6-month, and I've just cherry-picked some data here. If we look at Wuhan data, 6-month follow-up in severe patients, about a third of them had fibrotic changes on the CT. And bring it to the UK data, which has a different group slightly because it included severe and mild people. And mild was even people who did not require it for more than 24 hours of oxygen therapy at hospital admission. Then 4 weeks post-discharge, about 5% of these patients had interstitial lung disease. So there are many mechanisms for this, and I'm not going to go into that today. But what's really important is that this is, given this observation, the burden of pulmonary fibrosis can be substantial in these patients. These are the patients that have survived, and this burden can be substantial. Another observation is because of maybe the huge community spread, the average age is a little bit older. I think the other thing is to set this into context, that even if you have a small degree of fibrosis, which is residual and non-progressive, in many patients who may have already pre-existing cardiopulmonary conditions or indeed other comorbidities, then this can be significant. And I think it's really important, therefore, that we develop systems of care that involve imaging, lung function, and of course, functional tests to basically diagnose, identify this fibrosis survivor population, ensure that we don't have a second wave of mortality because of this, and deliver appropriate clinical care with studies which are going to help us elucidate the importance of treatments in this area. In our experience, very quickly, ILD occurs in people both at hospital and indeed at home, and I'll show you a couple of slides in a minute. One thing I want to share, and this will go throughout the whole presentation, is that no, the presenting symptoms for people with fibrosis is, of course, breathlessness, fatigue, cough, reduced exercise tolerance, and this is common. This is a CT scan from one of our home survivors who came in for myocardial infarction many years later, many weeks later, but you can see the damage here is extensive. And the pulmonary artery is enlarged at 33 millimeters. If I make a comparison to an ARDS patient who had multiple ground glass opacification, bilateral consolidation, then 3 months later, you're left with this ground glass and opacification and reticular changes. An example here, the PA was not enlarged. So it doesn't matter whether you're at home or you've had a nasty in the hospital, these effects can occur anywhere. And the gas transfer is about 52%, which leads me on to looking at lung function. Lung function in patients after ARDS, again, I'm looking at things that have gone before us. It's variable. Obstructive pattern, anywhere between 6 and 43%, restrictive pattern between 50 and 58%. And of course, restrictive pattern could be the fibrosis, could be neuromuscular weakness. The single most functional variable which is compromised in all studies is the gas transfer diffusing capacity. And after ARDS, it's roughly around 2/3, and it increases after 1 year to about 3/4 of the predicted value, and then it stays there. It doesn't actually seem to come up. Again, in our experience, this is reduced. 6-minute walk test, fantastic global physical function test. You can do it anywhere. It can be done by anywhere. And this, of course, incorporates cardiac, lung, neuromuscular, hematology, the whole shebang. So this is very, very helpful test. And in first year after ICU discharge, it goes from 49 to about 3/4 of predicted. And of course, it then stays there. Now, whether the inability to exercise is due to breathlessness or muscle factors, people don't know. It's multifactorial. And there is no major correlation between imaging and symptoms and lung function and the 6-minute walk. However, even if spirometry indicates a good recovery within 6 months, the diffusion capacity and 6-minute walk test remain reduced for at least 5 years. Pulmonary hypertension, as you know, can lead to right-sided heart failure, and COVID has not only can cause it through pulmonary fibrosis, but also through chronic thromboembolic hypertension. Just to set this in context, I've just set the definition there if anybody wants to remind themselves, but in context is that if you have pulmonary thromboembolic disease, thrombosis is rife during COVID, it isn't just the critically ill patients. It is, of course, the people at home as well, who are isolated, who did not come into hospital, who fought off the illness, have developed PE. And in our experience, CTPA missed many of these people, and you require more sensitive tests, EEG, for example, perfusion tests, to try and detect these patients. So there needs to be an increased awareness for this. Why am I worried about it? Because if we look at data that has gone before us in people with pulmonary thromboembolic disease in the past, the incidence of chronic thromboembolic pulmonary hypertension is anywhere between 0.4 to 6, so call it a median 3.4%. This is a big number. And of course, this can lead to right heart failure and of course the consequences. So what do the UK experts say on this when we talk to imaging people? They say, listen, this has the potential to become a public health problem, and that lung perfusion imaging should be embedded in routine post-COVID-19 follow-up pathways. Imaging specialists should be involved early in these pathways, and then you can tailor the expertise and the resources. and nuclear medicine should be supported to adapt and manage risks to provide appropriate services for COVID-19 survivors. And so I think this is an important element that we shouldn't forget. Investigations for right heart failure for PE, you know what they are. They're all in front of you. What I want to share with you is common theme. The presenting symptoms are breathlessness, fatigue, reduced exercise tolerance. Again, it's very similar to the ILD presentation. The third one that I'm going to share with you today is small airways disease. And small airways disease has been defined, as you know, affecting airway narrowing, inflammation, obliteration, in addition to mucus plugging of airways which are less than 2 millimeters in diameter, arising from the 4th to the 13th generation. What do you need for this? You need HRCT and lung function. Again, common theme coming through here. If you just look at one study, then it's very clear that this is probably the commonest feature that we detect on CT scanning patients. And of course, it often responds to inhaled medication, often used in airways disease, such as asthma or COPD. Again, the presenting symptoms are breathlessness, cough, fatigue, reduced exercise tolerance. One thing that unites many of these conditions is the intervention of pulmonary rehabilitation. This, of course, provides comprehensive care. It's delivered across the multidisciplinary team. It involves exercise, education, and behavioral modification. And the idea is to improve not just the physical, but the psychological status, which I hope resonates with the idea of One Health. It improves not only the symptoms, but the functionability and the quality of life. And of course, it's not just in people who have reversible disease, but in people who have irreversible changes in lung structure. Post-COVID-19, there is data emerging, but we already have data in COPD, pneumonia, ILD, SARS, etc. We simply have to not reinvent the wheel. We simply have to adapt and apply this to this situation. Other organ systems. Let me just take the heart briefly. Arrhythmias, myocardial injury, high mortality, risk factors are in front of you. We know them all. We need to look for these conditions. But what's interesting is people develop myocarditis with COVID. And you can't diagnose myocarditis with echo. Echo is not helpful. BNP.
All of you are requested to mute yourself, please. Kindly mute yourself.
Everybody okay?
Kindly continue, sir.
Yes, just to say, myocarditis will present with fatigue, breathlessness. It is, again, difficult to differentiate this purely on clinical grounds. Echo is not helpful in many cases. BNP is not helpful. You need, in this case, for instance, CMR with gadolinium. So specific tests will be helpful. There are a whole number of different organ systems that are involved. And and clearly I'm not going to trouble you with all of them today. But what I do want to say is that, musculoskeletal is well recognized. People are prone to weakness and physical impairment. There is the whole idea of...
That's what I'm saying. And no link is coming, nothing like, maybe the yesterday's link will be okay. When I call them,
there are gastrointestinal, hepatic, dermatological, and rheumatological.
I can plan to make. Then I told them to tell me where my interview is. In which
kindly mute yourself. We are not able to hear Dr. Kaul. Kindly mute yourself. Dr. Devajit, please mute yourself. Dr. Kaul, please continue.
Okay. So there are many systems that are involved, and we need to be aware that this affects both psychologically as well as physiologically the whole body, and therefore everybody has a part to play. What are the issues? The issues are that this is a group of patients, of many patients across the world, who are experiencing many symptoms for many weeks afterwards. And what we see in the hospital is purely a tip of the iceberg. These are exhibiting symptoms across many organ systems, which are highly individualized presentations from patient to patient, and therefore compartmentalizing them can be a challenge. The symptoms, and I think hopefully I've given a taste of that, are non-specific, and at the point of presentation cannot be differentiated. And to give you one example from one group, very respected group here, in the first wave, 47,000 people were discharged from hospital. And in the first 140 days in the Leicester area, there was a 12% mortality and 29% readmission rate. Therefore, there are new diagnoses to be made, and therefore we need to think about this very carefully. In our service, again, it is no different to what everybody else has seen. These are the presenting features of what comes to us in our service. And what are the diagnoses that we make? We've discussed some of them, but there's a whole range and many more. And as I mentioned, the symptoms are undifferentiated. It is difficult to extract them purely by clinical means. So what I believe our collective aim should be, our One Health aim should be, is to make these diagnoses, provide personalized, high quality care. And of course, you will therefore have an impact on survival and quality of life. If you believe the mantra, and I think many of us do, that early diagnosis leads to early intervention, which leads to better patient outcome, then the way forward is structured systematic evaluation and holistic management with a combined whole MDT approach. This will reduce people having to go to hospitals. And of course, it will allow us to accumulate data, and therefore we can think about the future and engage in research. Sharing our experience and understanding from our colleagues and indeed our patients and the relatives is all part of education. In the UK, one of our barriers is that we're restricted to only long COVID centres. I think specialist centres have an important part to play in this. But very importantly, for the patients, there is great confusion as to where you refer, because A, of the symptom diversity, and 2, of the diagnostic diversity. Do you refer it to the cardiologist? Do you go to the neurologist? Do you go to the dermatologist? Do you go to the chest physician? Where do you go with this? Because it is undifferentiated at the point of referral. So my view is, let's open it up. Let us evaluate the patient systematically in an outpatient, inpatient setting, whatever it is in their favor. Physicians are trained. They have fantastic general internal medicine skills. This involves all of us. The multidisciplinary team has full stakeholder ownership. And that means not just medical, but of course, allied health professionals, the physio, the occupational therapist, the speech and language therapist, the psychologist, the nutritionist, the podiatrist, and so on. And of course, physical rehabilitation, which has phenomenal effects on the psychological aspects of life, is not just about the hospital. It's about carrying it through the whole continuum of care and tailoring it to the patient at various stages of their recovery. Non-medicalizing it is as important as early identification and treatment of medical issues. I think that's very important. We talked about learning from previous areas, MERS, SARS, etc., but learning from PICS, post-intensive care syndrome. This has been around for at least 10 years. We should be able to take a lot of those approaches and transfer them directly. I think importantly, the effect on relatives and carers should be assessed and looked at. The relationship between primary, secondary, tertiary care, it has never been so important. And apart from the usual metrics of morbidity and mortality, I think it's also important to look at people's financial metrics of relative satisfaction, of the effect on healthcare utilization, to provide a more global One Health picture. So with that in mind, I'm just going to share, if I may, a few, if you like, observations in terms of strategy to prevent future long-term mortality and morbidity. And these are personal perspective that I have accumulated over the acute period, and I've got from many colleagues have shared in this. So it is not just me on this one. I split it into what worked well and what I think we could do better. The human spirit, I think that was amazing. I think people came across the world, irrespective of background, and we need to harness this strength proactively, because what really manifests for me was the care. And it was not just in the everyday language that changed. You know, the word stay safe was never a big thing before. It became a normal part of our jargon, but actually the way that people went above and beyond to look after each other and look after, you know, the professionals looking after each other. The theme of well-being became grew in prominence in the UK for sure, and I would like to think across the world to some extent. I've never seen the power of technology at a greater level. I mean, how it connected everybody was just simply awesome. And this isn't just in terms of professional, this is in terms of patients to patients, of relatives to patients, resource utilization, and through the whole process of delivering care and just being with each other. You know, technology was remarkable here. Collaboration and team working, cross-discipline. I think Dr. Malaji just said just now, cross-discipline, local, regional, national, and international level, whether it was testing, whether it was tracking, whether it was treating, whether it was following up, there was a lot of collaboration required. Could I think it could be done better? I think so. I think if we have learned from this, we could do this better in a more structured fashion. What I thought went well in terms of research, a lot of the red tape in the UK particularly, we have a lot of, you know, there's a lot of bureaucracy to get studies off the ground, to get medicines approved. And I think that was fast-tracked, and I think much to be applauded. I can't thank the various platforms. This is one of them that allows us to interact, irrespective of time zone, irrespective of people's busy days, and all of us here have taken time to be together today. This is only possible because of our will to commit to education, but also the human spirit and the technology all come together. And a special word on vaccination, which I believe has worked extremely well across the world in its many guises. What could we do better? Well, there's a lot of mixed messages and a lot of dogma flying around the world. As beautiful as technology is, it's scary. In WhatsApp gets things around quicker than talks and scientific literature. And so one has to be aware that there was a lot of fear of litigation. I mean, in the UK, you'll be aware of that, in the US and so on, but I think it's around the world, of getting it wrong on a personal level, of letting people down, of losing one's own life, and of course, losing loved ones. So supporting each other, and this whole concept now of compassionate leadership is a really important one. We need to build resilience into these high pressure, high octane environments. This will avoid the burnout, and of course, will reduce compassion fatigue. And that is very important as One Health going forward, how we deliver that as a profession, and indeed as society. People work, it's difficult. When you're working in your own environment, you carry on doing what you've always done. And therefore the communication and spreading the learning is so important. Isolation is such a massive challenge. People don't want to talk to people because they're busy, but it's really important to ensure that we stay connected. The messaging, one feature I think that came from many talks that I'd visited, or I had the pleasure of listening to, is that in countries, irrespective of their GDP, etc., countries where the messaging, public health messaging, politician messaging, clinicians, scientist messaging, where it was consistent, those countries on the whole did better. And I think it's a big point in many ways. It's important to involve the experts. I think maybe India did this very well. I don't think the UK did this as well. Many people will agree, for instance, that COVID is the respiratory, and of course, when you're very unwell, a critical care illness. And there are some respiratory critical care physicians out there. They were not at the helm of decision-making in the UK. It was different group of people, immunologists and so on. Shared learning. One thing I learned very early is that there's a lot of transferable skills. If you, for instance, look at the University of San Francisco, California, San Francisco, the professor of HIV became an expert at COVID. There were so many frameworks which they could simply adapt rather than have to reinvent. And of course, this saves time as well as effort. So here's a few suggestions. I would let the science and the experts lead on the decision making. So what to do. And I would enable the politicians to implement how to do it rather than the other way around. Governments just don't move quick enough, and we need more nimble systems. What do we learn? Maybe there should be a separate system, different fund that comes into play when the pandemic button is pushed. Importantly, a multi-system approach. This isn't one organ. This is everybody. This is not just one body. This is about everyone who's involved, from patient to healthcare professional to relatives. And therefore, it's not just about the number of people. It's about the quality and the key skills that are required to improve the efficiency, but also deliver care with compassion. So in summary, and I think, Dr. Malaji, I hope I've kept to time. Apologies if I've overstepped in any way.
No, absolutely fine. Absolutely fine. Please continue.
In summary, many people around the world are recovering or have recovered from COVID-19. Some organs, especially the lungs, but not exclusively, have long-term impairment. And that is irrespective of whether they had a mild illness, a moderate or a severe illness. And there are many organ systems that are involved. The heart, the brain, the neurological system, the skin, the liver, the rheumatology, psychology, psychiatry. There's a whole, cluster of organ systems involved, and they all make the body. And at the time of presentation or referral, these symptoms are non-specific, and the structured systematic approach to rule in, rule out important treatable conditions, I think is crucial to this whole process of how we deliver care. Depending on what condition you diagnose, the treatment approach is completely different. And yet the presentation can be the same. And to give an example, we have a lot of patients who undergo exercise, pulmonary rehab, get a personal trainer, but your exercise formula, your exercise prescription for somebody who has myocarditis is completely different to the person who has pulmonary fibrosis or has small airway disease or muscle weakness. And unless we make that diagnosis, this could actually be dangerous. Metrics, the metrics that we are conventionally used to, we shouldn't lose. Mortality, quality of life, lung function, all that should be kept. But I think we need to look into, in more detail, utilization of healthcare resources. People going back to work. If they're going back to work, in what capacity? Same number of hours, same earning levels? Is someone else taking it on board? The patient, as well as the family satisfaction, the effect on carers. I think this gives a more representative and accurate picture of the effect on the community and obviously on the globe as a whole. Learning from our experience, I think, is really important, whether we look at the SARS data, the MERS data, the ARDS data, HIV practice, whatever it happens to be, we can import all that learning. And this enables us to live and work in a more safer future going forward, because we can actually improve on our experience. And a very big punch out for compassionate leadership. People are exhausted. They have worked beyond hours. They have witnessed all kinds of horrific experiences, and the time for compassionate leadership and building resilience so we can continue to deliver high quality care, I think, is crucial. And on that note, again, I'd like to thank you all for the opportunity of spending this very valuable time and sharing some, what I hope are helpful observations and thoughts and ideas. Happy to answer any questions, Dr. Malaji.
Thank you, Dr. Kaul. It was wonderful, wonderful memorial lecture, Dr. Sk Agrawal, who was, promoted One Health, as well as did a lot of workshops on COVID-19. He reached to masses, and you very, very aptly, summarized your experience of post-COVID in UK, and we relate to it because COVID, was one thing which promoted One Health coordination, but as you beautifully brought out, that it is also interdisciplinary disease. You have to, as you brought out beautifully, a various spectrum of diseases post-COVID, various disciplines that need to get involved. Your experience of the lesson learned, what was good, what could have been better. I think we totally relate to that, and it was wonderful opening lecture for this conference. I thank you so much for sparing your valuable time and giving this Dr. K.K. Agrawal Memorial Lecture to us. I will open it for just one or two questions. If there are any, kindly raise your hand if you have any question. Otherwise, you can jot down your questions. Dr. Kaul, you'll be here with us for some more time.
If you forgive me, I have to go to work, if I may. But
yes. So if you have any questions, kindly raise your hand so that I can address the question to Dr. Kaul. If there are no questions, then we would thank him for sparing his valuable time amongst us and giving us his perspective on COVID-19.
Madam, can I have a small comment?
Yes, please go ahead, Dr. Agrawal.
I am Dr. Shurveer Singh.
Dr. Shurveer Singh. Okay, I can see another hand also. So Dr. Shurveer Singh, please go ahead.
Yeah, sir, actually, I have also followed this COVID outbreak or the pandemic since beginning until now. So my observation is that countries where using this pasteurized milk and milk products long before us, because we are also now after it, and in our metros it is being used as in the Western countries. So their immunity is compromised because there are many infections. They are going from milk to human being. It is same in human also, like tuberculosis from mother goes to children. Similarly, there are many such infections, especially I'm talking with respect to para-TB, which is incurable both in animals and human beings. So it is traveling from milk because it is not killed during pasteurization, the bacilli. And then it is growing within the immune cells. So that is having direct relation with this, the high mortality we experience in the Western countries as compared to India, and especially in rural India. Thank you so much, sir.
You have any comments, Dr. Kaul, on this?
I think, Dr. Shurveer Singh, I think it's a valuable observation. Unless one tests the hypothesis, first you have to come up with the hypothesis, and you have. Then it's worth, I think, delving into what happened and why it happened. And I think, this has merit, but I'm not aware of anybody who's tested it so far. And I think it's definitely worth thinking about.
Circumstantial evidences, they prove when we see overall this globally, the pandemic as well as the use of milk and milk products pasteurized, which is more. That is how.
I'm noting it down.
You can relate some.
I'm noting it down.
Yeah, thank you. Thank you, Dr. Shurveer and Dr. Kaul for that. And I invite Dr. Sanjay Kumar Agrawal, who's raised his hand. Dr. Agrawal, can you please come up with your comment or a question?
Thanks, Dr. Sunny, for excellent lecture. I have only one question. What is approach of a diagnosis of a long lung COVID in a asymptomatic patient? During follow-up, if the patient is asymptomatic from a respiratory point of view, do we still need to investigate for a long lung COVID?
The quick answer is no. That's the short answer. But the deeper question, Dr. Saab, is when somebody says they're asymptomatic, are they really asymptomatic? Or is it because people are just doing less because they're confined to base, if you see what I'm saying? And I think isolation and, trying not to spread the disease, infection control, has often meant that we are confined to certain areas and we do less, we're deconditioned. So yes, you're absolutely right. I probably wouldn't be saying that asymptomatic disease should be investigated. However, an accurate record of what the person's performance is, I think, is important. And Now people are getting outside. Now people are interacting again. Now people are trying to increase their functional ability. At that point, we should find out where there really was a difference. We have a, you know, in England, we say if somebody has compromised lung or heart or exercise performance, they go from having a big dog to a small dog. And then after having a small dog, they don't buy the dog at all. And they then, rather than walk up the hill, they take the bus. And of course, they then get a cab. So it may be they're able to achieve the same thing and not appear to be symptomatic until it's a bit later on. So it's about testing for them, I think, in a non-invasive way, but just being aware that people perhaps have become less functional than they used to.
Thank you so much for that response. And Dr. Agrawal, thank you for that question. And Dr. Kaul, if you permit me, I want to ask you your experience. I'm a microbiologist and I'm a COVID-19 nodal person here for the lab. And, there were a lot of, when this long COVID started, we were given a lot of samples for autoimmune disorders because it was not clear as to what it is. And I have a complete profile for autoimmune disorders. We do line immunoassay, we do immunofluorescence, and we do ELISA, double-stranded DNA, and other things. But everything else would be negative, but fluorescence would show up vague fluorescence. What do you have any experience? And we could never diagnose what it was. But it was very difficult to give autoimmune ANA negative with that kind of fluorescence, but we could not identify any particular pattern in it. So you have any experience on that?
So I have the same as you. We have patients who come with fatigue, come with breathlessness. They have other conditions. We do the autoimmune, if you like, diagnosis, or we give the screen, and it comes as positive with ANA. And in our experience, I'm just watching these people. I'm watching them. They don't necessarily have full-blown, etc. Now, smaller group, a group of those, in particular, there's two that are in my head. They both had pericarditis, and they responded well to colchicine, etc., etc., etc. So that was great in those two people. I think one of them we actually aspirated, and we found the ANA in the pericardial fluid as well. But that is a very subgroup of a larger group, which it looks like that this might be a paraphenomena, and hopefully will get important. While I've got you, Dr. Malaji, on the phone, on the screen, microbiologists, we also saw a huge change in our ICU flora. I'd be keen to know what other people's examples were. We saw Klebsiella double and so on, Pseudomonas, etc., multi-resistant. And in fact, we're presenting some work on that. But we saw the whole thing from pre and post 1 year to the next, a comparison, say 2019 with 2020. Also, just before March, April, May in 2020, we looked at January and February. There's a difference before and after, and there's a difference year on year. I would love to know, does this change back again? What happens? And your thoughts would be very helpful on this, what your experience is.
Absolutely. These were some of the, observations and surprises for us too. Initially when it started, the first wave, suddenly, the infections decreased because of overdoing things, isolating the patient, hand sanitization, infection prevention control practices, everything. So everything went, and few admissions. You see, the denominator was very small because it was only COVID patient first wave. Second wave was a surprise because ICUs were overfull, people were scared, there was fear, there was, getting off the hook when IPC conditions, because our residents had to work for 8 hours continuously standing, so 8 to 10 hours continuously till somebody replaced them in ICUs. That time, our flora changed. We saw resistant Klebsiella, resistant Pseudomonas, Acinetobacter baumannii, many other species, which, with new diagnostic techniques, we could see many other species. And now again, it continues because ICUs now are full functional. So they're different patients, but the flora is still the resistant one, because probably use of lot of antibiotics that went in. Now, it is so difficult to bring back clinicians to the same antibiotic policy that we were following in earlier. They're so tuned to jumping to higher antibiotics, or COVID or no COVID, patient has landed in the ICU. So that is our challenge. Even we are monitoring that, but this is my observation till now. So let's hope that it reverses back, at least to, it was already high, this thing resistance, but we hope that it goes back. And I think the use of antibiotics should be streamlined. We should be less fearful of using the routine antibiotics and not over enthusiastically using the high end antibiotics, but that's causing a problem. I think this is my view, with whatever I can think of without looking at my data as of now. Yes.
And we noticed across the country, obviously, especially first wave, but also second wave, there wasn't that many samples. I mean, I'm bronchoscopy, so we did, but people were sick. And of course, it was difficult to take lower airway samples when people were so unwell and on, very high pressures of ventilation, etc. Were you inundated with samples? I know my microbiology colleagues love samples. So whenever they look at me, they go, have you got a sample? Was it forthcoming, or do you think it was a lot of empirical treatment, or was it purely because of long-term ventilation? I mean,
no, our sample size reduced because bronchoscopy for some time was stopped.
Okay.
So we were not doing any bronchoscopies for a long time. It started now with long COVID and not non-resolving things with no answers to the clinical presentation. The bronchoscopy started again. Yeah. So we stopped bronchoscopy for a long time.
Got you. So it was empirical treatment and long-term
Yes.
patients probably, and that influenced the antimicrobial policy.
Yes, absolutely. I agree. So thank you so much. And we are all set for the next presentation. Dr. Kaul, want to thank you really from bottom of my heart. Very good.
Dr. Mala, one question I would like to ask, Dr. Kaul, just a small question,
Yes, please go ahead.
I am General Venkatesh, just retired as a DGRVS, about an year back, had the longest tenure as a DGRVS for 3 years, head of service, commanding the 3 trial services as far as veterinary concerns were concerned. My question, Dr. Kaul, was a very articulated one, which you have said, and it was quite impressive, as far as the summary and everything else, the last came up, basically for the general people, besides the normal doctors, what you had said. My question is that in England, do you have in the station health organizations probably an incorporation of agriculturists also, veterinarians also, or evolutionary, ecologists also, or as they call it as, people, who are looking at, your nature, the naturalists also, because that is where probably, the spillovers of the diseases are coming in from. And in India, we are probably discovering that now, though we had that, about 5,000 years back, as far as, the Yajurveda was concerned, we forgot that, that I'll come to you later. But can you tell us something about your setup, as far as One Health organizations are concerned, especially in England, so as, we can also pick up a few leaves from there.
No, I think, Dr. Saab, I think we're behind. I think, and this is my plea to everybody in the UK, is to pick up on this. I think nature has answers to these problems, and we haven't gone there. If anything, I think we've neglected it. We've stayed with the microscope, and we stayed with the lab, and we stayed with our science, if you like. But I think nature is very important, and there's a lot of answers there, as you say, whether you go back into the Vedas, etc. But there's a lot of answers there, and I think we need to dig deep. It is one thing for certain: this condition is not going to go away. Once it has developed an animal reservoir, 29 species of animal have a reservoir of COVID, as I understand it today. It affects the minks in Denmark. It affects the dogs in cats and the hamsters in Hong Kong and in China. Therefore, it is everywhere. And therefore, getting rid of it will be difficult. If we do not involve the veterinary colleagues, the ecologists, then we are not going to find a solution to this on our own, for sure.
Because summing up, 75% of the diseases are coming from wildlife animals, sir, and in the last 30 years, statistics is very vivid and rampant onto that, Every year we have had these kind of microbes, surfing in, like a medusa head, whether it's a bacteria or it's a virus, every year one. So that is probably, we have been tampering, especially with the habitat at every now and then. That is what this thing is.
Thank you so much. Thank you, both of you. And we'll let you go, Dr. Kaul, and hope to see you again sometime. Thank you so much. And it's an honor and pleasure to invite the next speaker, who's our chief guest speaker for the day, Dr. M.L. Madan, Padma Shri awardee. He was former chairman, Livestock, Subgroup Haryana Farmers Commission, chairman, National Biotech Task Force in Animal Sciences, DBT, Government of India, New Delhi. He was the president, Society of Animal Physiologists of India, General Secretary, National Academic Agriculture Sciences, New Delhi. He was Vice Chancellor of Deen Dayal Upadhyay University of Veterinary Sciences, Mathura, UP, Vice Chancellor of Punjab Deshmukh Agriculture University, Akola, Maharashtra, Deputy Director General, Animal Sciences, ICAR, New Delhi, and Project Director, Embryo Biotech, and Joint Director, NDRI, ICAR, Haryana. So he has so many feathers in his cap, and it is an honor and pleasure to invite Dr. M.L. Madan. Over to you, sir. Dr. Madan, please. Dr. Madan, are you there?
Kindly unmute, please. Dr. Madan, kindly unmute yourself. अपने को unmute कीजिए, please.
I hope now I am audible to everyone.
Yes, yes.
Yes, sir. Welcome, Dr. Madan. Good to see you. And over to you, sir.
Good morning to you all, and my great pleasure to be associated with this Millennium India Education Foundation, for which I have been associated with several of their past activities. And today at the 12th National Conference for One Health, we are having the theme of intersectional cooperation for zoonotic diseases and the public health of importance. And for that, we have got the pandemic in focus. And it was a pleasure to be listening to the previous speaker and also the long discussion which we had afterwards on the various aspects of this. In fact, that where you left is where I am going to take off. That what he said was in terms of the fact that we are talking of disease which is infecting and spreading over in the human population. But when we are talking, addressing ourselves to One Health, we have to understand that we are talking of not only of human health, we are talking of animal, plant, man, environment, interrelationships, and the overall health which is involved. And that's why the word has come in One Health. I think it's now for the last 12 years that the concern has been expressed all over the world, that believing that about 67% of all the infections and diseases which come into the human population have got to one place or the other, an origin from animal source. So therefore, the question is that can we really tackle the problem of health without tackling the problem of addressing ourselves to the requirements and the needs of mortality, morbidity, and the effects of diseases into the animals, which subsequently come over into the human beings. I remember that the COVID period was a very dark period in our time, that we could say that it was the worst of times, and it was also the best of times for some who knew how to stay at home. It was in the age of this wisdom, it was foolishness which was befitting us all. In this epoch of belief, there was an incredibility which was going on to all of us. And we were rather in darkness in the lights which are around us in terms of knowledge and thought. And not lost, but the least of them, that we were in despair. That we were in despair because we did not know where to go and how to go. We have come a long way during the last 2.5 years, but the shadow is still over us. Now, the shadow is not only concerning for the human population. But as every day passes off, that we have got reports coming in from isolated laboratories, which we are talking of wild animals or pet animals, or animals that which are connected with what we call exotic animals, that the disease taking its shape and size. The size has not been large so far, but the shape has been considerable and noticeable. We have been also talking about that what did this COVID do with respect to the animal world? Well, fortunately, that our domestic animals and the animals around us, which we work all the time, were not greatly affected and did not have the symptoms by which that they will get alarming into the population. So knowing and recording that these animal symptoms, for example, when we're talking of the virus coming in into the poultry, and immediately that it was a havoc created in the human population also. But herein that there was COVID had great influences, and I must bring it to the notice of all that we were affected because of the fact that the livestock is the one which keeps the human population going. At least in India, that we know that it is the livestock which is responsible for the livelihood of about 67% of our population. And it was this 67% of the population which on one hand was affected with COVIDs, and on the other hand, that the livestock COVID scenario was that the markets got closed, the availability of the transport of materials and goods, both in terms of feed and in terms of the products which come out of them, the milk and the meat, was disrupted. There was also that this veterinary services, there was disruption in them. There was also the differences in the demand and supply side. And in other words, what we can see that animal diseases were not being properly monitored at that time. And we were always under the risk of the diseases spreading over to the other animals, which are not communicated with the COVID itself, but the diseases which are prevalent and endemic into this area. Fortunately, this did not happen. This happened rather only in limited areas and in specified locations. Of course, the processing there was more important. That is where the slaughterhouses got closed. There was labor disruptions. There was reduced animal supplies, and there was poor monitoring of food and food hygiene. And therefore, that the concepts came up more vigorously in our country also, here in India, about this One Health. And the consortium was thought to be launched, about which people were talking. But what's the crux of this consortium? The consortium in one world is we must be able to understand the human health, the animal health, the wildlife, to minimize the damage caused by the international and national, or those even that who are the local neighborhoods. A large number of institutions have been put together in what we say in interpersonal interactions. And we see that, as a matter of fact, leadership has been given to one of the animal science institutes in the country. And the One Health Consortium consists of All India Institute of Medical Sciences, Delhi, the AIIMS, Jodhpur, Indian Veterinary Research Institute at Bareilly. Then we have got the Veterinary University at Ludhiana. We have the Veterinary University at Chennai, that Veterinary University at Nagpur, Assam Agricultural University, and various veterinary universities, ICAR, ICMR, and with other agencies. But when I was perusing that what is coming on ground with respect to these aspects, I'm still to see that we have a long way to go. Firstly, that the concern about One Health. When we are talking in this country, One Health being addressed by whom? I think this is the first thing we should understand. that health is an delegation with Indian Council of Medical Research. And we have got the health sector, which is functioning independently and of its own. Then we have got the Indian Council of Agricultural Research, which is having the health sector, and Indian Veterinary Council, which is having the veterinary sector to take care of it, and they're functioning of their own. There is no collateral functioning. There is no interspecific functioning. So under these specific terms, that the word One Health does not speak for itself. We have often tried that this One Health should come from the educational field first. We should start from the education, from the medical and veterinary education. At this point of time, we do not have any interaction between a medicine student in veterinary and medicine student in human health. Yes, there are chapters which a medical graduate is dealing with about the zoonotic diseases, and there is a chapter in the animal side where the students are reading about zoonotic diseases, but they are in isolation to each other. There is no collaboration and collateration. And I would believe that in the years to come, if this One Health has to succeed as far as the livestock is concerned, we need an intense interaction. We need a common educational program. We need a common course program and interactions at the field level so that these programs can be given shape to. Now, let us see that what are the challenges which this One Health program is having for the sector, for the animal sector. Firstly, we're talking of the livestock is the one which is with the poorer section of the populations. And there is also the lack of education to the extent in which we think that our counterparts are in there. So therefore, this there is what we say a disparity in terms of education and in terms of sanitary concerns. There is also what we say that cheaper animals are often less healthy. And we have to bring in this concept of health in livestock also. As a matter of fact, that as I was listening to the last presentation, I would emphasize over in here that the word disease has a different meaning today than it was a few years ago. And healthy person is not supposed to be diseased, but he is not also healthy. A healthy person is to be described not only that he does not have disease, but he is interacting with his physiological systems in an equilibrium along with his environment and along with the society. That's what we call as true health, and that's One Health. And therefore, that this meaning becomes very important of the professional divide which we have at present. And there is what we talk of unhealthy livestock amongst us. And at the same time, we have got a lesser penetration of animal health supervision over into the animal health system. We have got another challenges in terms of the unhygienic slaughter, which is going on all over in the country. There needs to be a regulated slaughtering of animals and also monitoring of the meat which is produced in this. The monitoring of the markets, the food markets, the vegetable markets, the fruit markets, vegetable markets, meat markets, all these markets which come under the common agricultural concept, they need to be monitored. And also we need to exercise ourselves to assess how the presence of insects and other vermin are affecting the total animal health. The rats and the fleas become part of this. We have not addressed ourselves to this. I was wondering whether we are talking about the welfare of animals and welfare of human beings when we see that we are at crossroads to each other. I think it's very important to identify that when we talk of animal welfare, we to say that there should be no cruelty to the animals. And in the process, no cruelty to animals, we have got lakhs and lakhs of dogs in the country at present. And one of the largest disease, having the greatest morbidity, and at the same time having the greatest economic loss to the country at present, zoonotic disease, is rabies. So how do we challenge this? If we are talking of human welfare, then we have to see that we must get the rabies out of this country, which is a zoonotic disease. And if I would talk of the animal welfare, we say that the animals should not be touched with. So where are we? So there has to be, similarly, another disease, the brucellosis, anthrax. These are the diseases which are supposed to be communicable as zoonotic diseases. And we need to have an effective control and effective programs to go into these diseases. I need also to say that for the future, that as far as the challenges are concerned, the first and the foremost challenge I would like to be answered is through education. It is not education in numbers, but it is an education in quality. And in education in terms of associated role of the different branches which are supposed to be interacting and supposed to be concerned with One Health. COVID gave us an excellent example through which we knew that how important it is to be interdependent. COVID also taught us that under very dreadful circumstances, that how have we to meet the challenge. But we have not yet taken up the challenge which we talk of the method of disease controlling and developing of disease control centers. In human health, we have at present a concentrated effort in order to go towards having a few laboratories which are specialized in this. But on the livestock health, because we have to be very prepared for future. The challenge in the future is that we should not be sleepy in the same fashion as we were previously. Therefore, one of the challenges is that we should have a systemic, structured, and diagnostic systems in place, which is not a small thing. It's a very large thing. With a 558 million animal population in this country, that it is really a great challenge. But this challenge has to be met if we want that the One Health program has to supervene. We need also that to see that where we could do the best in terms of our community medicine. Community medicine is not an issue for us as of today, but in the days to come, this community medicine will become more and more important, where the role of a veterinarian and the role of the human health sector will be very important. Therefore, there should be an intensive information exchange. So that is another challenge, that how do we bring about and data collation, data collaboration, and information exchange. Finally, what are we needing to go and do for tomorrow? That tomorrow is a day when we see that there is an agricultural transformation. Tomorrow, we don't see the same picture of agricultural production as we see today. Because of the demand on livestock products, there is a more and more intensification of livestock, and there is less and less of use of crop sciences. And this is going to go towards a situation where there will be much emphasis going on to the livestock production. But that has another environmental challenge. So that environmental challenge which we told is in terms of the feed and food. To answer these feed and food situations in the year 2050, what is being thought of today, what is the challenge being done today into the science, is that we have to have alternate foods, alternate milk, alternate feeds for animals. And therefore the challenge is greater. That if today we are talking of a product coming from an animal which is safe, tomorrow we have to talk of hundreds of thousands of laboratories which will be producing artificial milk, which will be producing artificial meat. So therefore, the monitoring for our diseases will become much more difficult and much more, enterprising. And it is there that we have to see for ourselves. With these words, I have great pleasure to be associated with this group here, and always the Millennium Indian Educational Foundation has been doing a very creditable job in bringing about these topical issues in front of the diaspora, not only within the country, but outside, and therefore helping in churning out the knowledge. And I hope that in this process, we'll be building up a better tomorrow for ourselves, both for animals as well as for human populations. Thank you very much.
Thank you, sir. We are really honored and privileged to have Chief Guest address from you. Thank you for sharing the words of wisdom with us. And each point has been well noted, be it the quality education, both in veterinary and medicine sector, or systemic structured and diagnostic laboratories being in place, importance of community medicine, interaction between them, data collection, collation, and then action to on that data collection and collation, and feed and food situations, challenges for those. So each point, is kind of eye-opening to take this One Health approach forward. Thank you so much for that address, sir, and we are honored to have you here with us today. Thank you.
Thank you very much.
So with that, we'll move on to our next guest speaker, who is Dr. Sk Chopra. He is eminent cardiologist at international repute with 42 years of experience as a consultant cardiologist at Medanta Mulchand Heart Institute. He's the chairman, World Wellness Foundation, World Heart Academy, country head, American Heart Association. He was national president of Cardiology Society of India and Indian Academy of Echocardio.
वो अभी ये 3 लोग अभी ज्वाइन नहीं कर रहे हैं, वो भी राउंड पे चला गया, ही विल कम लेटर. डॉक्टर चोपड़ा, डॉक्टर प्रतीम और डॉक्टर इंद्रजीत. तो आप डॉक्टर एसके अग्रवाल जो नेक्स्ट है उनको ला.
Sorry for that interruption, and I believe Dr. Sk Chopra had to leave. That's what I was informed by the organizers. So I think we will move on to Dr. Sk Agrawal, who is our next guest speaker. And Dr. Sk Agrawal is HOD Nephrology, Department of AIIMS, New Delhi, and he's one of the renowned kidney transplant doctors in the country. Countless locals have placed immense trust in practitioners over the years. And so he's a very, very popular person. He has been a good academician, a teacher for both undergraduate and postgraduate students, very hardworking, painstaking, and has done a wonderful job. Let's hear it from Dr. Sk Agrawal. Dr. Sk Agrawal, please.
Good morning. At the outset, I must thanks the organizer and Dr. Kakru to invite me on this. Initially, I was really, what I use after listening to chief guest talk, Dr. Madan. He has actually shown so many challenges of handling One Health in our society, that I was really thinking when he was speaking that how these challenges will be met considering the way the society is working. But that is also true that unless we start at some stage, we will never succeed in conquering those challenges. I was thinking that we know so little about zoonotic diseases and cooperation between the different fields involving such diseases, that we ultimately are contributing in One Health in a very, very small way. I can only share the experience of kidney disease patient during COVID pandemic. Just to give you idea that how can a single disease can affect a specialty in such a big way. You see, the chronic kidney disease, which is one of the major public health problem and one of the group of diseases in nephrology, after the elderly and diabetic, chronic kidney disease was the third commonest risk factor for COVID infection. And once we analyzed the data of admitted patient of COVID in All India Institute of Medical Sciences, the chronic kidney disease was the third common cause of increasing the mortality in these patients. Another figure is that COVID patient, 30% COVID patient has got some degree of a acute kidney injury, and the patient who has got acute kidney injury has got much more higher mortality as compared to patient who doesn't develop acute kidney injury. And the group of patient COVID who develop acute kidney injury, approximately 10% of patient goes into chronic kidney disease and increases the burden of chronic kidney disease in the society. And these patients ultimately require dialysis and transplantation. So you can understand the magnitude of effect of COVID in nephrology. From a social and a organizational perspective, and the fear of the disease has affected so much in these patients that, to give you idea, that a large number of the hospital actually stopped doing dialysis on patient who has got suspected COVID or has got proven COVID infection. And it really make so much hue and cry of organizing the dialysis of the patient who need it by the government in the community. And the patient who were having infection, not only because of the risk of mortality, and also because of the shortage of the manpower, which was more involved in managing COVID patient, the renal transplant was totally stopped across the country for more than a year or so. And the patient who were requiring renal transplant, actually a large number of patients die on maintenance dialysis just because they couldn't be transplanted in time. And still COVID, this in spite of 2.5 years, we still has, it's not disappeared. We still get a admitted patient waiting for the transplant, getting a positive infection, and the transplants are being cancelled. And we are still not very clear how to handle transplant patient before the transplant is done and after the transplant is done if they have got COVID infection. So this is in nutshell our experience of nephrology in relation to one of the pandemic and zoonotic disease. I will say that One Health and involving various sectors in managing the health is really so much important, and we are really missing that. You see, initially the primary health physician, say this, if you say some 50, 60 years back, primary health physicians were managing and they were having a wider knowledge of all the diseases, including zoonotic. But with the specialization and super specialization, we have become so much narrow in our experience and expertise that we are forgetting a broad-based approach. So just to give you in the end that even Government of India has made a program of one nation, one dialysis, because the dialysis across the country is so much different in spite of having national program, Prime Minister national program of dialysis. Still we have got wide difference across the country. So it's recently launched program One Nation, One Dialysis is very similar to this One Health for the country. With these few words, I will again thanks for organizer to involving me in such a wonderful meeting, which gives you a very wide perception how the health of the nation can be managed. Thank you again for the invitation.
Thank you, sir. Thank you so much, sir. And good to hear from clinicians also, how it is perceived and how it can be taken forward. So thank you so much for your address, sir. I now invite Dr. Kamlesh Upadhyay, currently serving as professor and head of the Department Medicine, BJ Medical College and Civil Hospital, Ahmedabad. And he's been involved in diagnosis and containment of Crimean-Congo hemorrhagic fever in the country in Gujarat. And also he's been on our panels, various panels. Dr. Kamlesh Upadhyay, can you please give us your thoughts on One Health?
Ji, namaskar.
Namaskar, sir. Namaskar. So good to see you.
Pratasmara mirudhi sanspuridatma tattvam Satchit sukham paramahan sadgatim turiyam Yaswapna jagara susuptamavaiti nityam Tad brahma nishkalamaham nacha bhut sangha. वन हेल्थ के सब ऋषि लोगों को मेरा प्रातः वंदन प्रातः स्मरण. I'm really thank Dr. Kakru, Chabra ma'am and all dignitaries present in this 12th Zoonotic Conference. 12 साल का एक कॉन्फ्रेंस का एक सर्कल, एक तप आज खत्म होता है. तो I sincerely thank and वंदन करता हूं ककरू साहब को. Time has come to think again and again. One thing is sure, COVID, the best teacher award goes to COVID-19. That is sure. Because it has taught us many things. During lockdown time, I have seen our Additional Chief Secretary Health in a major room. But other ACS who were free, we had ACS policy making, we had ACS purchase, we had ACS ventilator, ACS remdesivir, I have seen. So it has made the boundaryless management of the state. And we had a direct opportunity to talk to the IAS stateway. Otherwise, it's really a tough time to deal with them. One more thing is a symbiosis. The organisms have a more, their understanding is more as compared to what we have a human, as a human doctor, veterinary doctor, and then we have all of our egos and whatnot. And organisms have a symbiosis. When there is a COVID, the vector-borne disease, we don't know where it was gone. It was not under reporting. It was not that it was there, it was not reported. No, there is some understanding among the organisms, and that's why Madam rightly mentioned the whole antibiotic flora got changed. So they take advantage to kill the human, to change the behavior of the human, and the ICU flora gets changed. So we have to learn from the organisms that we have to practice symbiosis, at least among our veterinary friends, environmental friends, and human doctors, rightly mentioned. As I mentioned, the top of 12 Zoonotic Conference is now, it's the last conference in that cycle. Another 12 cycle, we must have a newer vision. And that too, we must have some newer topics to discuss, like law, zoonosis, and what changes are required. I've been, as a state physician, I was involved in the invention of the first bird flu outbreak in 2006. And in this span of almost 17, 18 years, there are almost more than 110 outbreak of bird flu in the whole country. And still, the culling bird is the same mechanism. Even for the rare birds, can we observe for 14 days or not? And answer is, there is law says you have to cull them. Time has come to form a separate committee for the law and zoonosis and what changes are required to take the our health policy further. On 5th, 6th and 7th May 2022, across the country, the health minister, health secretary, health commissioner, and MD NHM from each state, 4 persons minimum came to Gujarat, and we had a conference for the 3 days at Statue of Unity. And as a chairman of the documenting the whole 3-day seminar, I wrote a 50-page document on the further policy. Independence 75 is going on. At the when there'll be 100 years of independence, what will be a roadmap of the health policies in 25 years? That was discussed. I was lucky enough to be a party of that that whole 3 days workshop. Meetings were there. The reality is that the last word was that Indian way of health management does not complete without the word service to humanity. Now we'll add here service to One Health. All of us, those who are already working for last so many years, time has come to wake up, to involve more people. All medical colleges, the Madan sir has rightly mentioned, we have to sit with the LMC, we have to sit with veterinary councils, and there should be there should be other than conferences, there should be active groups which can suggest government on zoonosis and law, zoonosis and medical education, zoonosis and veterinary education. The time has to come, form committees and to work in this way. Last but not least, since I am posted additionally as a IB member to AIMS Batinda, I had opportunity to meet and see the One Health University, Ludhiana. I visited there. I spent the whole day there, and I've learned. I was literally very much happy that at least in the 4th state, to begin with, there should be a One Health University in every corner of. Its time has come to increase the number of One Health University in the country. I strongly feel. And one more thing is that just like environmental factor is less touched, even in our 12 conferences we see the environmental component is touched this time in a more appropriate manner. Time has come to elaborate more on that. I strongly feel pesticides level in the mother's milk, we have to think as a environmental factor, use of pesticides and oncogenicity. We should think and focus on more also. And last word is there are many arguments when people are working on that, whether they're the man-made disaster or not. India being a vast country, we must have a some way of mechanism to be developed at the national level also, that any lab, any person, scientist involved in the unethical practices or behavior, we must them in the radar, so that at least India is full of possibilities, and we should हम विश्वास सभी का करें पर अंधविश्वास सभी का ना करें, ये बात भी देखने की बात जरूर लगती है. Thank you very much for giving me opportunity. I think I'm in time, and again मैं सबको नमस्कार करता हूँ. Thank you very much.
Thank you so much, sir. Thank you. Pleasure hearing you, and points well noted. You know, these are some of the areas we need to touch also. Thank you so much. Next, I would like to invite Lieutenant General Dr. P.R. Venkatesh. General Venkatesh is a 3rd generation veterinarian. What a proud thing to say, in his family after his father and maternal grandfather. Wow. He is the only veterinarian who has been conferred with both Paramveer Sena Vashisht Medal and Sena Medal for his outstanding career in Indian Army. He has shouldered responsibility of teaching, training, research, man management, veterinary care of all animals, etc. in most varied and challenging environments. With his ingenuity in the field of animal behavior research, he has successfully introduced the concept of training of COVID detection and narcotic detection in dogs in the army. He has also introduced training of Indian breed of dogs for military purposes and training raptors for intercepting drones. Wow. So we welcome you, sir, and we want to listen from you, Dr. Venkatesh, your words of wisdom, and then we close the inaugural session. Over to you, Dr. Venkatesh.
Thank you, Dr. Mala Chabra, for the invigorating introduction. I'm very obliged for that. Thank you, Dr. Uday Kakru, to bring me here and to give me some time at least to put forth our views also as far as COVID battle is concerned. And interesting to note, it was quite articulate as far as, Dr. Sani and Dr. Madan's, this thing was there, erudition was there. Dr. Madan hit the nail on the head at every stage, and he did a complete SWOT analysis, as they say, the strength, the weaknesses, and the opportunities and the threats, he valued all of them. And as far as this multilateral and multiple kind of an approach towards, this coordination and cooperation of COVID is concerned, which we had faced from 2019, which probably raised its merits ahead then, has probably taken an awareness, the world by storm, and with a lot of loss in economy as well as a lot of loss in lives also, precious lives also. And this fight, for emerging and re-emerging diseases, through this One Health concept is a very beautiful thought and a beautiful idea whose time has come now, which is very important. And as they say that, the world had that kind of a scenario, and we woke up from that. Earlier times, like I mentioned it to Dr. Sunny also, in the passing phase, that, we had, our Vedas, the Artha Veda. And, in the Artha Veda, we had, kind of a thing in which, they had considered all the 5 elements at that point of time, the earth, water, fire, ether, and air. And then they used to talk about, the Pashus, and the Pashams, the men, the Pashus, the animals, and the agriculture in those times. So it was a holistic approach in those times, when they considered that as far as health was concerned. And they started that, with Vasudeva Kutumbakam, the whole world is a family. That is how, we inherited that kind of a One Health concept, from that side. Everyone should prosper. Sarve Sukhino Bhavantu, Sarve Santu Niramaya. And consequently, we have come down, in 2004, I think, there was a slight awareness as far as, this One Health concept was concerned. Am I audible, please, Am I audible?
Yes. 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 Yes.
Thank you, sir. Thank you, distinguished people. So what happened was this One Health concept, started, gaining its roots in 2004. And probably at that point of time, the awareness started that what it was and how to go about it at various periods of time. One world, one health. And then in 17 and 18, we took cognizance of it, as far as our motherland was concerned. And in last year, somewhere in October also, we ratified those movements. One Health concept, what has happened is that, we have started encroaching upon various fields. And like, Dr. Madan correctly pointed out, education is a vital cog in the wheel, which is required in these times. And whether in veterinary science, we should have a part of wildlife animal teaching, which has been incorporated just about 1 decade back, I think, not before that, when we passed out at that point of time, it was just being introduced, at that point of time, wildlife and zoo animals, kind of a thing. And we were aware for the first time then. I'm talking of, way back in 79. And similarly, in medical fields also, but the various lab subjects, as far as microbiology is concerned, bacteriology is concerned, virology is concerned, veterinarians have slightly an edge over the medical field because, they get into these research fields much more in larger numbers. And availability, resource availability is much more there. So that can also be incorporated in the educational field. What has happened is that in the habitat control, earlier the bridge was starting, from the human field, the human health, directly to the wildlife health, and in between we had the domestic animals, which started, encroaching the human health as well as the domestic health into the wildlife health. And the habitat got exchanged, there was water pollution, there was environmental pollution, there was, your heavy, like, Madam brought it out very beautifully, Dr. Mala, that, the antibiotic resistance, the assault, as far as of insecticides and pesticides and agro industries were concerned, these are the things, which led to this, mutating of these viruses, They are more lethal as compared to the bacteria vis-a-vis, though Dr. Madan did point out about, tuberculosis, and Dr. Shuri Singh pointed out about paratuberculosis and rabies also. So rabies, Ebola, and then we have Nipah viruses, they started emerging, bringing up their, medusa heads, at various points of time. And these, besides, your avian flus and, the bird flus, and then the swine, African swine sickness, which has recently also emerged, that also is coming up again and again in various mutated forms. These mutations are occurring because, with the change of host also and the change of structures and shapes also of theirs, And similarly, these problems will keep on recurring probably if we don't integrate ourselves, as far as One Health concept is concerned, which is a beautiful forum, what we have pointed out now. I thank the organizers, especially the organizers of, your Millennium India Foundation, Mahavir Medical Foundation, SAIT Medical College, Mumbai, and GLA University, Mathura, to at least to bring us all to under one platform to find out, what really One Health is. And from there, we get down into the recently 2 states who have been, given as pilot projects, as far as, your Uttarakhand is concerned, somewhere in April this year, and as well as, about last week, we had Karnataka, coming up, in a big way, as far as, this project was concerned, the One Health pilot project was concerned. Now that verticals probably, which were, performing in silos or in boxes, like, Dr. Madan pointed out, is seeing a convergence now. Earlier there was not only divergence, so they were in parallel to each other, and they were working in their own compartments. Now, at least, we have this kind of a convergence now in One Health concept, where, we are realizing that, 75% of the diseases, are emerging from wildlife or domestic animals, back into the human stream. And similarly, like I pointed out in the passing earlier, that, every year, one disease, either a bacterial or a viral, raises its head, and erupts itself, for the last 30 years. That is what we have been facing. And if we don't include, besides our human health and the animal health and agricultural health, one greatest health is the environmental health, which was also pointed out, by Dr. Mala. That environmental health has to take cognizance of, and that also includes ecology also and evolution also. So those factors have to be included, per se, and we have to bring out all experts in various fields. That is how this, Bangalore pilot project has taken into shape, wherein internationally, like, Dr. I think, Dr. We had that British officer, medical officer, Dr. I'm forgetting his name, I'm sorry. The one who had spoken earlier, Dr. Call. He had pointed out those very beautifully. Internationally, there is a regional, there's a national, global thing issue, there is a regional issue, then there is a domestic and a local issue. And in the international issue, the 4 organizations, they have started, probably combining together and gelling together and sitting across the table over a cup of coffee kind of a thing, as the balance goes. The World Health Organization for the human health, the Food and Agricultural Organization for the agricultural health, and the third most important is OIE, Organization of International Epizooticus, that is animal health, which is taking into cognizance the zoonotic diseases, and then the UN Community Committee on this environment, which is very equally important. These 4 factors, if they can combine together, which has been considered now in Bangalore, will see the light of the day in due course of time, in which, we don't have to fight a battle every time, like a firefighting, we can always anticipate that, and do a lot of prevention and cures, and locally identify those problems and fill it off, like Dr. Madan brought it out, the slaughters, the FCCI regulations and all those kinds of things, he brought it out, beautifully he brought it out, and he had summed it up very well. So if this can be implemented, and there were 6 states, probably which were identified, and on logistics and on operational basis and non-operational basis, these 2 states have been identified, in which Uttarakhand took a lead, and then Karnataka has taken the second step now, which was introduced about a week back. And if you bring that, there are 4 pointers, as far as implementation is concerned, which is very vital. And the 4 pointers are surveillance and exchange of knowledge, which is very important amongst these verticals, which have to converge now, That is very important during any outbreak of epizootic outbreak, whether it is endemic or it is pandemic or epizootic, infectious, non-infectious, they have to merge together, which is very important. The same question I asked, Dr. Call, as far as the British scenario was concerned in health organizations there, Here we are working in silos for a very long time. We have to stop that. So at least this creation of a new department called as, the Department of Animal Husbandry, Dairying and Fisheries has taken that lead, of starting these pilot projects there. This is very important. Dr. Chaudhary took that lead. And these leads are very vital. And, these are the things which I will have solutions in the long run. When you consider veterinarians, especially in this kind of a field, what will happen is they're good at this kind of microbial research or this thing. In the very presentation of today itself, we have plethora of veterinarians who are either bacteriologists or a microbiologist. We have Dr. Shurveer Singh, who has got illustrious exposure to paratuberculosis, probably one of the very rare ones in India who has done Johnny's disease. Others do it in other fields. So this breakdown is required as the first pointer, surveillance. And then after the surveillance has to come a response. How are you responding to it? The second pointer in a SWOT analysis. And after the response, we have to see, what is the risk involved and what are the remedial measures, suggested. And lastly, the research entailed, what all has gone, what is going to happen, and what is anticipated in the future. Like, Dr. Mala came out, I was quite surprised when she took me with a bang, when she said that we had trained those dogs. It is my army with the support of the veterinary corps, as well as, the complete Indian army at that point of time, when we had our back against a wall. We had 3-4 steps we did. I'm talking of, as a veterinarian. When I was a DGRVS, we started RT-PCR at Meerut. We have a ISO certified lab at Meerut, which is called as Central Military Veterinary Laboratory at Meerut CAT. We started the RT-PCR to help out COVID patients under the help of, collaboration of, the King George's Medical College, Uttar Pradesh, Lucknow. veterinarians started doing the RT-PCRs, for COVID patients, in 19 to a dozen lines, we did that. Overnight, we are burning the candle. We are burning the candle from both the ends at that point of time. Second point we did was, we started training dogs, we deployed them all around, as far as COVID detection dogs were concerned, the help which COVID detection dogs can do is, reduce your reaction time as far as hospitalization time is concerned. If they can sniff and identify a person who's positive or negative, at least, you discard him, you don't put him in quarantine. He's not incarcerated and, probably hospitalized. And then, you have to take basically the symptoms in cognizance, They're very efficient, these dogs, And first time responders they are, they will tell you positive or negative. And, you can take the next step from there. Third thing we did was we incorporated a team of veterinarians, army veterinarians at various places. 4 places we placed them, based them. Delhi, Bihar, Calcutta, and I think Jaipur at that point. Udhampur, I'm sorry. Udhampur, we placed them there to help out the medical field people, in tandem during the COVID time, and we found success there, And when the DRDO started this hospital, Sardar Vallabhbhai Patel 500-bed hospital in Delhi here, we incorporated veterinarians there also in tandem under the supervision of the medical scientists here. And that was very successful at that point of time. When Sardar Vallabhbhai Patel Hospital was established by the DRDO in consultation with the Indian Army. And we incorporated veterinarians there also. So they realize that now probably that emergence is taking place, that, the realization that veterinarians can also contribute very significantly, because with a major chunk of these diseases coming from there only, either from wildlife animals or from domestic animals.
Dr.
Whether it's a bat coming in with the COVID.
Please,
Sorry?
Kindly wind up, please. We are running behind time.
Okay, ma'am. So these are very important issues which I'm wanting to say that, and at the end, I would like to again, thank this Millennium Foundation for giving me some time, at 5 minutes time. I think I overshot the 5 minutes time,
Doesn't matter, sir. It's pleasure hearing you.
And thank you, and Godspeed. Let us all break our head together, sit over a coffee, and solve these problems. Thank you.
Thank you so much. Thank you. Very heartwarming. Thank you so much, Dr. Venkatesh. And with that, I will wind up this inaugural session. What a brainstorming it was. And
any questions, ma'am? Any questions for me?
We'll get back to you, sir, with the questions, because next speakers for the next sessions are waiting in queue and they have to leave. Okay. So probably we'll get back to you for if there are any questions from the house. We have your email ID, so we will definitely get back to you. Thank you for that wonderful thoughts that you shared. And I would like to wind up this inaugural session and thank each one of you for a wonderful, wonderful deliberation. And it was a very apt inaugural session. And, to end, I want to say that we are living in a world where an average 3 new pathogens have appeared almost every year since 1980, and 75% of them being viruses, and that of zoonotic in origin. And this is, millennium of working together, not in silos. And there is a One Health program. How do we envisage that? Is first we come together and strengthen our surveillance both in animal sector and human sector.
Very true.
So we pick up things. When we have data, we will know what outbreaks are going to occur, what is occurring in anthrax in animals. If it is happening, it can be prevented in animals by IEC. So we do the surveillance, pick up those points. Then if there is an outbreak, do a joint outbreak investigation. And to learn all this, we should have joint capacity building, training courses together with medical and veterinary people to understand the epidemiology, prevention and control of zoonotic diseases. So this will involve labs as well as public health people. Then share resources. Like CMVL Merit and the lab in the Hisar are our Glanders lab for human detection also. So share resources. Rabies is done in most of the lab, both animal and human sectors. So we have resources. Let's share them and strengthen our systems. And last would be the behavioral change in society. For that, we have to create material for community awareness, and that should be done jointly. So these are some of the pillars that we have to work on. Surveillance, outbreak investigation, capacity building together, sharing of resources, whatever we have, BSL-3 labs, like Dr. Venkatesh said, Even veterinary labs took the onus of doing the RT-PCR. The test is the same whether you do it in animals or human beings. So let's tap those resources. There are more BSL-3 laboratories in animal sector than human sector, you know, and the first BSL-4 laboratory was in animal sector. It came up later in human sector. And we shared those resources. Let's strengthen this efforts and take One Health to a new platform. Each of us have a role to play. You know, it may be a drop in ocean, but that drop, you know, makes the ocean. So let's go forward with that. And I hand it over. Thank everybody, all the speakers, all the eminent persons present here who shared their thoughts and made this inaugural session absolutely very interesting. Over to the organizers, please.
Thank you, Dr. Mala. You have taken a very patient 1.5 hours inaugural session. And I hope everyone has enjoyed it, because we had a diversity of views and diversity of people and from different backgrounds. So now, although we are running behind the schedule, we'll try to catch up and finish in quick time. We have with us Dr. P.K. Uppal, who will be chairing this session, and I will request Dr. Jugal Kishore to co-chair, because Dr. P.K. Uppal will be leaving to Delhi for some time after introducing Professor Vijay Chaudhary, and we have Dr. Reema Roy. There are only 2 speakers here, and after that we will have a 10 minutes break, because there is a long session. So over to Dr. Uppal. Kindly take the session. And Dr. Jugal Kishore, he is a professor and director of community medicine and our co-organizer as well. He was missed in the morning, but we'll be hearing him in the last session regarding the constants that he'll be speaking about. So I had just, Dr. Arora, he had called me. I welcome you. I directed him that he should sit with you and be physically present, because he hadn't received the information that it has been transformed into digital only. So Dr. Uppal, please start the session. Dr. Uppal, अपने को unmute कीजिए please. Yes. आप unmute कीजिए अपने आप को, Dr. Uppal. हाँ, हो गए.
Good afternoon. It's a great honor to be with you this afternoon. We have eminent speakers in the morning, and we had interaction of excellence related to One Health program, which is a great efforts done by Millennium. We have heard about interpersonal relationship, intersectoral relationship, and above all multi-sectoral, and above all we think of global thoughts and global views. And we had wonderful views from various speakers in the morning. Well, I welcome you all and initiate the discussions afternoon. And we have 2 distinguished speakers right now in this session. One will be on role of antibodies in the diagnosis and treatment of diseases. In a very beautiful word given, antibodies, ek naam, anek kaam. This will be delivered by Professor Vidya Chaudhary, Center for Innovation in Infectious Diseases, Research, Education and Training, University of Delhi. And second speaker is on monkeypox, an emerging threat for public health globally, Dr. Reema Roy, scientist, National Institute of Virology, Pune. Both these lectures are of great relevance and importance under One Health program, and we all know well that antibodies have been playing vital roles since centuries and playing a vital role in the prevention and cure of diseases. And even today we talk of monoclonal antibodies and other factors which plays a vital role in this system. Above all, emerging monkeypox, which has been a great challenge to all of us, which recently also reported in India from Ghaziabad, but still the virus confirmation is still to come. Globally, it has taken a heavy infection in various parts of the world and especially in European Union. So may I request the first speaker, who is an eminent, well-known and of great relevance, Dr. Professor Vidya Chaudhary, please.
Thank you, Professor Uppal. I'm so grateful to you that you introduced all the antibodies. So I wanted to speak 2 lines, but you have already highlighted the importance of the antibodies. So actually, I have put everything in my presentation for you, everyone to listen to. So I'll start with the uploading of the presentation. So I think I can share the screen. Let me start.
Vidya, share screen करवा दो सबको.
Already done.
Yeah.
ठीक.
I thank Dr. Uday Kaku for the invitation to deliver a talk today in the 12th National Conference on One Health Initiative, organized by Millennium India Education Foundation, New Delhi, in collaboration with other organizations. In the next 20 minutes, I will try to justify the title of my talk, Antibodies, Ek Naam, Anek Kaam, along with examples of utility of antibodies in the diagnosis and treatment of diseases. I am associated with Center of Innovation, Infectious Disease Research, Education and Training, CIDRET, at the University of Delhi, which was established under Ordinance 50 May, carrying out different activities in the field of infectious diseases. Besides,
Sir, speak close to mic. Sir, please speak from close to mic.
Hands-on courses. The details can be found on its website. Its success has led Delhi.
डॉक्टर साहब आप अपनी माइक यूज कीजिए. इसकी recording is not audible.
The seat at the University of Delhi, which I look after. This presentation has been prepared with the help of Professor Gita Gupta and Dr. Vaishali.
I'll have a presentation without
It
narration.
is not audible.
Sir, you are not audible, sir. You are
It's not audible.
Yes. You please mic अपना थोड़ा ठीक करिए सर.
Constitute
Dr. Vidya Chaudhary.
the protective mechanism.
एक माइक कम कीजिए. एक माइक बंद कीजिए.
Immune system. It is to recognize and eliminate pathogens, other disease-causing elements, and the study by
आप अपनी
It's not audible at all.
अपनी presentation का audio बंद कीजिए.
आपका तो कुछ सुनाई नहीं दे रहा सर. आपकी आवाज ही नहीं आ रही.
Dr. Uday.
The voice is echoing.
Dr. Kakru.
Yes, please.
Could you request somebody to chair the session because I have another meeting going on?
Dr. Jugal Kishore is there. Co-chair.
So I shall try to come if possible.
Yes, please.
I have to.
Yes,
Dr. Jugal Kishore, kindly.
Okay, I'm here.
Thank you very much. Nice of you, good of you.
Thank you, sir.
I don't know where the disturbance.
डॉक्टर चौधरी आप दोबारा ये कीजिए, प्रेजेंट मतलब शेयर कीजिए स्क्रीन को और वॉइस अपनी यूज कीजिए.
No, I've been doing this for during COVID time. It works very well. But somewhere, it is not from my side. But doesn't matter because Indian time we must have to start.
It's not audible at all.
No. Presentation. Are you able?
Sir, your voice is resonating. The voice is, getting back to us, twice over.
या तो आपको सर रिकनेक्ट करना पड़ेगा.
That's what I'm doing. That's.
As I think Dr. Sir, जब तक वो आ जाते हैं तो let the Dr. Rima do the lecture. जब तक he comes back. Yeah, he has come back. आया
उनमें डॉक्टर साहब वो ज्वाइन कर चुके हैं.
हाँ ज्वाइन कर दे.
नहीं मैं अभी एक कुछ में कॉन्फ्रेंस में.
Dr. Vijay sir, kindly share your screen. Dr. Vijay sir, first of all, unmute your mic.
Please unmute your mic.
आप अपनी एक मिनट को अनम्यूट कीजिए.
Yes sir, continue.
आपका स्क्रीन आ गया.
Let's see whether you can hear us.
I thank that Dr. Kaku for the invitation in the 12th National Conference on Health Issues
Hear us?
organized by Media Education in collaboration with the
डॉक्टर साहब आप एक काम कीजिए, आप अपना प्रेजेंटेशन मेरे को व्हाट्सएप कीजिए.
of my talk. Antibodies.
आप मेरे को व्हाट्सएप कीजिए अपना, तो फिर मैं यहाँ से रन करूंगा एंड यू कैन स्पीक ऑन इट. टिल दैट टाइम डॉक्टर जुगल किशोर काइंडली इनवाइट डॉक्टर रिमस टू स्टार्ट.
Okay, okay. Yeah, Dr. Rima is here.
It's really good to hear from you, Jugal. I hope you and your loved
Yeah,
ones
she
are
is here.
So, Dr. Rima, it's my I'm really happy to look at your biodata, and I think you will do justice to the topic. You are scientist C medical in ICMR, National Institute of Virology. You are a medical graduate from Nasik, and from there you did the MD community medicine, then DNB also. Very good. And then you have many diploma and certificate courses in hospital health management and health insurance also. Health Research Foundation, design and interpretation of clinical trial and principle and practice of clinical research. So you have very good experience. You have also worked in as assistant professor in Mumbai. And so I think your experience and your academic caliber, and you have number of research papers and research work. I really look forward your presentation. Please.
Thank
Dr.
you,
Rima.
sir.
Yeah.
Thank you so much, sir. It is in great pleasure here to be here because all are my senior faculties here. And I wish good afternoon to everyone. And I thank Dr. Kembhavi sir and Dr. Kakru sir for inviting me for the presentation. I'm sharing the screen. Is the presentation visible, sir? Full screen mode?
Yes.
Yeah. So good afternoon again. Now everyone is discussing about the monkeypox. Yes, it is an emerging threat to the public health right now. But, we will discuss in because of 20 minutes, a short time has been provided. I'll try to wrap up in detail about the monkeypox. So what is a monkeypox currently? Monkeypox, as we all know, is a zoonotic disease. But remember, monkeypox is a misnomer. It has just not been transmitted through the contact with monkey, but yes, with many other reservoirs, which I will be covering. It was a disease which was primarily been found in Africa around the tropical rainforest. Now we have seen the importation of the cases in the many other countries which are not known to be endemic. Like first, it has started to be in UK this year. It has also been observed that focal outbreaks has been reported amongst the close contacts of MSM group. So why we need preparedness? What is a need for India? Just to brief about some genome of this monkeypox. Monkeypox belongs to the same family of smallpox, that is orthopox virus genus, belonging to the family Poxviridae. It is a DNA virus and it has a huge genome, 190 kb. Just remember, in the figure which I have shown here is a red part. This red part is a centrally conserved region for all the orthopox viruses. But then what is the difference in this monkeypox? If you see the end point, the inverted terminal repeat. In this inverted terminal repeat, we have 4 open reading frames of monkeypox, which is not seen in the smallpox. And it also has a VACV homologue, that is vaccinia virus-like homologue, which is responsible for the host determination and pathogenesis of this virus. Initially, the monkeypox has been reported, first case in 1917 Democratic Republic of Congo. If you see here the orange color denotes the locally acquired infection, and this purple color, it denotes the imported cases. So even in Africa, there are imported cases been reported. Total 11 countries in Africa reports monkeypox every year. So what is the scenario right now? This monkeypox is not being seen just this year, but if you see the importation of case has already been seen in USA, it is not because of human traveler. If you see, in 2003, 6 countries of USA has reported monkeypox. How they have reported? They have their small mammals were transported from Ghana and they are kept with the prairie dogs in USA. Then these dogs been given to 6 countries, and then there is transmission of zoonotic disease from dogs to human that lead to a focal outbreaks in these 6 countries in 2003. So not only travelers coming from these endemic countries, but even the animals which get imported can carry the infection and can lead to zoonotic transmission. Not in 2003 it was reported, then in 2021, both in July and November, then in May 2022 also this year it was reported. Israel and Singapore also reported the imported cases, and now we have seen in UK, now even in Australia, the cases were reported. So every year from 2018, 19, 21, 22, every year monkeypox has been reported from UK. But this year, if you see, as of 27th June, more than 3,400 laboratory confirmed cases are reported and 1 death from the 50 countries of WHO region where it was known to be endemic. That means a non-endemic countries, 50 countries have reported the monkeypox. That is the challenge for our India because of the travel. We can also have an imported case anytime, and then we need to have preparedness and vigilance. In India, till date, there are no confirmed monkeypox cases. We have received 14 samples of suspected monkeypox. Most of the samples are positive either for chickenpox or for hand, foot, and mouth disease. The sir has talked about the Ghaziabad case. It was positive for chickenpox. It is not a monkeypox case. So why this reemergence has been seen? Primarily due to we are encroaching the forest because of huge deforestation, the civil unrest and poverty, the climate change, and yes, the experts also says because we had an eradication of smallpox in 1980, the vaccination has ceases. The smallpox vaccine tend to prevent the monkeypox and it gives protection up to 80%. That is also one of the reasons. Now, who has been protective, if I say, from 1980 to 2020, if I consider for 40 years, so those who are above 40 years or 45 years might be slightly more protected for monkeypox compared to any other generation. So we have more contact with animals. Because of civil unrest and population displacement, people are forced to take the alternate source of food, including the wild animals, squirrels, and rodents. This is not only the reason for the spread of monkeypox in African area, but also the other zoonotic diseases like Ebola, Marburg. So we need, and now everyone knows about the sequences and its importance because of the COVID. COVID has made us learn most of the things. So now, just like Omicron, which is circulating in our country, in the monkeypox also have two genomes, the West African clade and the Central African clade. The Central African clade is also known as the Congo Basin because it is seen in Congo area primarily in West Africa, in Central Africa. So what is the difference between these two clades? Why we are differentiating the monkeypox and trying to understand the genome? Because the case fatality rate is significantly lower when the cases or the patients gets infected with West African clade. It is only up to 6%. But till date, it is only up to 1 to 2%. Only few times it has been reported up to 6%. The Central African clade has shown to have higher mortality and severity, and mortality is up to 11%. And infectiousness, if I talk, infectiousness in case of R0 or the secondary transmission, which we can say, it is very limited. That is only 1 to 2 generation with the West African clade, but it's up to 7, and even 10th generation has been reported with the Central African clade. So it is very important to understand which clade is right now being circulating in these outbreaks, which we are seeing in the 50 countries. So recently, just a month back, Europe, in which the primary outbreak has been happened, they have released the phylogenetic analysis, and they have reported, if you see here the blue color everywhere, and there is one orange color or yellow color at below, all this blue color denotes the West African clade. So we are now relieved. The West African clade has been found to be circulating in the current country's outbreak, and hence we have not seen mortality till date. Only one confirmed case of monkeypox mortality has been reported till date. So which are the other reservoirs of infection? Apart from the Scooty Mangabe monkey, which we say as a monkeypox reservoir, there are other reservoirs, including rope squirrel, African dormouse, and Gambian pouch rat. These animals play a very significant role. They carry the infection, they continue the enzootic cycle, and then a zoonotic transmission happens to the human, and then human to human transmission. So what are the modes of transmission? The primary infection is from animal to human, either with contact with the animals or contact with the contaminated animal products, including the blood or the meat. And then once a human gets infected, then there is human to human transmission, primarily through respiratory droplets, the lesion fluids, the body fluids, and the fomites, which are created because of the beddings and the linens used by these patients. Apart from this, mother to fetus, that is vertical transmission, is also been reported of monkeypox. So if I consider, because it being a DNA virus, a surrogate pox virus, that means on the environment, the virus which is there, the studies have shown that it can stay till 1 to 56 days, depending upon the temperature and the room humidity. And because of its high environment stability and more resistant to normal environmental conditions, the fomite plays a very active role for the transmission of monkeypox. So these are the few case definition. The suspected case I'll brief here because we are a non-endemic country. A non-endemic country where a person of any age, it may be a pediatric or an adult, present with headache, acute fever, lymphadenopathy is the pathognomic sign for the monkeypox of fever with rash. The swollen lymph nodes, either cervical or inguinal, has been reported in 97 to 98% cases of monkeypox with myalgia, backache, and with no other clinical features of DDs. Why I'm focusing here no other clinical feature? Because right now, whatever sample NIV Pune is receiving, either they are turning into chickenpox or into herpes simplex or some into enterovirus. So it is very important to clinically differentiate the monkeypox, the chickenpox, and other DDs of this infection, which causes similar presentation. I will be discussing few in details about it. So what is the clinical epidemiology of monkeypox? With the incubation period of 5 to 21 days, Initial 4 days is a febrile stage when the person is having a fever, followed by a 2 to 4 weeks of rash stage. The rash goes in stages but in sequential manner. First macule, papule, vesicle, pustule, and then crust or scab. Unlike what we see in chickenpox, where all these stages of the rashes can appear together. So this is one of the differentiating finding with chickenpox and the monkeypox, as well as the lymphadenopathy, which is the sign for the monkeypox. And then from after 4 weeks, when there is a scab which falls off. So patient tend to be infective till the scab falls off, because scabs have highest number of DNA also similar to the fluid, which we can see. And then there is a recovery stage, which also can take weeks depending upon the severity of the infection. So the primary differential diagnosis of monkeypox is the chickenpox and measles, which has already been known in our country and which have a similar month of presentation. The April-May is the season where we get the highest chickenpox cases reported from our country. Now, monkeypox has also been reported during the same season. There is no seasonality as such for monkeypox, but yes, it has also been shown in all the countries during April, May, June, and in November, December. This is the same time when chickenpox also been reported. So if you see the differential diagnosis here, the lymphadenopathy is present in monkeypox while it is not seen in chickenpox. If you see here, palms and soles are not that much involved in chickenpox, but monkeypox doesn't spare palms and soles. Palms and soles are also having significant lesions. The other differential diagnoses are disseminated herpes, herpes zoster, herpes simplex, chancroid, secondary syphilis, bacterial skin infection. Why I'm informing these DDs? Because we are getting samples even with bulle-like lesion, bacterial lesion, burns. All these cases has been referred to us as suspected monkeypox. We need to understand clinically that these cases could also be the other differential diagnosis like hand-foot-mouth disease, infectious mononucleosis, molluscum contagiosum, lymph granuloma venerum, scabies. One of the scabies case was also referred to us as the end stage of monkeypox because of the scabs and scarring the lesions have, and the rickettsial pox. If you see the lesion of the monkeypox, it has similarly like pock-like lesion what we see in smallpox. Right? In chickenpox, the denseness of the lesion is more. It's primarily okay. This lesion, if you see this picture, there is lesions more on the face, less on the trunk, but no, the trunk is also not spared that much, but the lesion starts primarily from face. Monkeypox. In chickenpox, it also starts from face, but it is distributed equally, but palms and soles are rarely involved in chickenpox. So if we discuss about some type of lesion here, it is almost 0.5 to 1 centimeter in size, in diameter. It could be from few to several thousands of lesions on the body. It starts from the face and extends to the palms and soles, even involving the oral mucous membrane, conjunctiva, cornea, and genitalia. So what is the complications for the and the long-term sequelae for the monkeypox? So because if lesion can happen in the corneal or the cornea or the conjunctiva, it can lead to corneal infection, conjunctival infection, and then vision loss. The skin lesion can coalesce, can lead to secondary bacterial infection like cellulitis, abscess, pyomyositis, necrotizing soft tissue infections. The infection can lead to pneumonia, acute respiratory distress syndrome. All these cases has been reported from Africa. Because of the oral ulcer, patient tend not to take the food and water, leading to severe dehydration. There is secondary bacterial infection in body leading to sepsis, shock. Even encephalitis has been reported from monkeypox. And of course, poor pregnancy outcome because of the vertical transmission. And deaths has been commonly observed with the Congo clade of the monkeypox. The long-term sequelae is the pock marks. These pock marks are the permanent pock marks similar to the monkeypox, so smallpox. Unlike chickenpox, because these lesions primarily involve the dermis of the skin, it leads to the pock marks. Scarring could be there, or could be loss of pigmentation, blindness, and the mental illness, which we have also seen in COVID because of the stigma, fear. Here, because of the scarring of the body, the stress and depression is also one of the most common mental illness been reported because of this monkeypox. So the high risk group, which is defined by WHO, is pregnant women, children, immunocompromised patients, and poorly controlled HIV/AIDS, like people living with HIV/AIDS having poorly controlled CD4 counts or not on ART are the high risk group. If the people living with HIV/AIDS is well controlled, good CD4 counts are not included under high risk group. So what are the complications in pregnancy because of this monkeypox? There are few published literature about the 4 pregnant women infected with monkeypox. One has delivered a healthy baby, so we have not seen any congenital monkeypox infection or any other lesion in the baby. 2 had early miscarriage. There is early abortion, spontaneous abortion when the mother was infected, and 1 fetal death when there was a stillborn birth, and the newborn was having a diffuse rash, which is virologically confirmed with monkeypox. So the outcome of pregnancy is very poor. It could be death of the fetus or a spontaneous abortion. So pregnancy is known to be a high risk group of this monkeypox. So there are known treatment, the tecovirimat, the brincidofovir, and cidofovir. These are the 3 drugs, antiviral drugs, which has already been known and been used for the treatment of the monkeypox. We all know that we use cidofovir for the CMV, that is CMV retinitis. This analog is also brincidofovir, which is used. This brincidofovir is US FDA and European agency approved drug for treatment of monkeypox. Tecovirimat is also European agency approved drug for the treatment of monkeypox. Just to explain, these drugs can be used in normal patients who has a severity of lesions of the monkeypox, but the data is not available for the use of these antivirals in pregnancy, in breastfeeding, even as a prophylaxis when some healthcare gets infected. So the data is right now not available with any of the researchers or the scientific community. There is one more analog, NIOCH14, which is a chemically synthesized analog of tecovirimat, which is all the trial has been going on for this drug to see the efficacy. The preclinical trials on monkeys has been successful for this drug. So the thing which I've explained, using pregnancy, the PP and breastfeeding, the data is not been available. Brincidofovir has already been known to cause embryotoxicity, and hence it has not been used in pregnancy. So which risk group is this virus? Like we initially, because any exotic pathogen when it comes to our country, we label it as a BSL-4 pathogen, right? Here, this is also an exotic pathogen, but what is a better known with this pathogen? If I say it is a risk group 3, how I can label it as a risk group 3? I'll go a bit forward. Why I label monkeypox as a risk group 3? Because in risk group 3, any of the risk groups I define under 3 headings. First, how much individual risk that pathogen tend to have, how much community risk that pathogen has, what is the outcome, and do we have any effective treatment or preventive measures. So if I consider Ebola, for example, a high individual risk is there for Ebola and high community transmission. No drugs, few of the vaccine has now been studied for Ebola, right? So it is under risk group 4. But for monkeypox, though the individual risk is very high, but the local community risk is low. Why? Because it is seen only amongst the close contacts. It does have a serious outcome, but in very few cases, and death is also in very limited. And we do have a treatment, tecovirimat and brincidofovir available with us, and we have a vaccine available, that is Jenios. It is a live attenuated modified Vaccinia Ankara vaccine, that is a smallpox vaccine, The studies has been done that it is protective against monkeypox up to 80 to 85%. And it is also US FDA approved. But the issue is this vaccine is not readily available to our country. Hence, considering all these factors, the monkeypox virus right now is risk group 3 in the non-endemic area. Because our country is a non-endemic country, we consider this virus as a risk group 3. Hence, we would require it to be handled only in a high containment facilities by the trained staff. So for collection of the samples, we will be using the same PPEs, personal protective equipment, which we have used for COVID-19. Either coveralls, the gowns, the head cap, N95 mask. We can use the goggle or the face shield and the double pair of gloves. The same PPE which we have used for COVID-19 following the WHO protocol. So what are the clinical samples which we really need to test? So to confirm or to rule out the monkeypox. Because lesion is the primarily thing which differentiate the monkeypox and other infections of fever with rash. The lesion samples are the most important samples to be diagnosed and tested. So lesion, we collect lesion roof with the help of a scalpel, sterile scalpel or plastic scalpel, lesion fluid, lesion scraping using swab, and the lesion crust. So all these samples need to be collected in plain tube, not in any virus medium, only in plain tube. So if I am collecting some lesion fluid or any lesion roof, lesion scraping, lesion crust, it is advisable that the lesion samples, I have mentioned star marks here. That means the lesion samples need to be collected from multiple sites because it might happen some of the lesions do not have replicating DNA of the virus. So if we collect only from a single site, we might miss the diagnosis. Hence, it is important to collect multiple samples and from the multiple sites of the lesion. Apart from this, we have seen positivity in the nasopharyngeal and oropharyngeal swab, the blood, that is serum, and the EDTA and the urine sample. All these have shown positivity in the monkeypox. Why is it is also important to collect these samples? Because in our country, we have seen many other pathogens to be referred to us. Like some of the samples are positive for chickenpox. So in chickenpox also, all the samples are positive when we test. So it is very important to send all the samples so that we can find any other differential diagnosis as well. Please note here, like unlike in COVID-19, in which we collect the nasal swab and oral pharyngeal swab in VTM, here we collect in plain tube. We suggest plain tube because this VTM, virus transport medium, might inhibit the DNA and we might get inappropriate results. Hence, we suggest the samples to be collected in plain tube. In recovery phase, the samples collected are serum and the urine. Please note, all the samples are collected in plain tube and nasopharyngeal and oropharyngeal swab should be collected in plain tube as well. So this is how we collect the samples. We sanitize the site of the sample using the alcohol prep. We remove the roof. We do the scraping of the base. We collect in different containers. We collect the fluids. We collect the crust. And also we have then put it in a separate screw cap plastic container, which is a plain tubes. This is already been mentioned under the national guidelines of the monkeypox, which is prepared by Ministry of Health and Family Welfare. The primary site for the treatment, for the diagnosis is the BSL-4 facility, that is maximum containment facility of NIV Pune, where the sample has to be routed through IDSP. And the contact details is already been mentioned. The primary contact is Dr. Pragya, who is our group leader, and mine, which is a secondary contact, has already been mentioned under the national guidelines for the monkeypox. So the diagnosis is primarily through the polymerase chain reaction. Real-time PCR is available with us. The serology, that is IgM and IgG testing, is not advisable because of the cross-reactivity. Orthopox is a whole group which contains cowpox, camelpox, buffalopox, and monkeypox, some vaccinia and variola as well. So these, because of the conservative region which I have shown previously, the antibodies cross-react. Hence, we do not indulge into testing with serology. the primary diagnosis is through the real-time PCR. So first we test with the real-time PCR of orthopox. Why we test with orthopox? Because in our country, we have also reported buffalo pox and cowpox. Hence, we also rule out this lesion. And if it is positive for this orthopox, then we selectively test for the monkeypox. And if it is positive, then we report as a monkeypox positive. If it is negative for orthopox and monkeypox, then we test for other differential diagnosis. Virus isolation and sequencing platform is also available for identification and clinical characterization of the samples. So what we have learned here so far? This virus belongs to orthopox family, a genus belonging to Poxviridae family. It's a DNA virus, zoonotic disease, already been known endemic in 11 countries. Importation is reported almost in 50 non-endemic countries. It is a risk group 3 to be handled in high containment lab. Right now, all samples has to be referred to NIV Pune, that is BSL-4 lab. The samples collected are the lesion samples, all the lesion samples from different sites. The nasopharyngeal, oropharyngeal swabs, all samples in the plain tube. The serum, EDT and urine. Use the desired PPE to handle the cases, and transportation of samples should be always in triple packaging and in dry ice. If you contact us, we will be coordinating for everything, whatever is required. So vigilance and preparedness is key to detect and contain the monkeypox outbreak. So these are the reference guidelines which is available freely online for the monkeypox, and this is our national guideline also for the monkeypox. So thank you. We have to bring hope and smile with the help, with coordination and early detection. Thank you.
Dr. Jugal, sir.
Yeah, very good presentation. Wonderful. You have covered almost everything. And you have also shown that how India is also at risk and how we have to be prepared for it. And working in, ICMR Pune Institute, you have a lot of responsibility of diagnosis and also guiding the, ministry and also the country. So very good presentation.
Sir, I have a small question, Sir Jugal, sir, please. Can I?
Please.
Well discussed, Dr. Rima, well researched, it's a very appreciable, whatever you have, endeavored to say. I have only two very small questions, Dr. Rima. Am I audible to you?
Yes, sir, yes.
One is that, being a pox virus, probably, is that the region of this emergence of this particular malady? Because, the chicken pox and the smallpox viruses have been discontinued for a very long time, abroad, Is that the reason for its re-emergence? One. And secondly, is there a probability of this virus particularly getting back into a different host, with a mutation? Has some study been carried out onto that, So as it infects a different sets of animals and different sets of hosts also. What I'm looking at is the COVID point of view.
Yes. Thank you, sir, for this question. I'll answer the first question. First of all, chickenpox belongs to herpes group, sir. And the smallpox, buffalo pox, camel pox, that belongs to Poxviridae, that is orthopox family. But yes, WHO has done some studies and they have shown that because of the we have reduced now there, as per we do not have vaccination for smallpox from 1980. Because of this, the people who are right now getting infected are only the younger population. Because smallpox vaccine could play some protective role against the monkeypox. And yes, it is also been shown that the antibodies shows protection against monkeypox. And right now the Genos vaccine is also a smallpox vaccine which has been currently used for the monkeypox. It is true, sir, because of this reduction in the, or we do not have a smallpox vaccination in place. That could be one of the reason for reemergence. But yes, Africa is known to have a very close contact with these wild animals. So the jumping from one host to another host is well known for this kind of area where not even the monkeypox but other zoonotic diseases have also been reported close in these tropical rainforest areas. There are some studies to understand the mutations of these viruses and different clades compared to COVID, what we see. But there is these viruses have a very conserved genome, sir. because this DNA virus being a DNA virus, much difference in the host has not been seen. But yes, the studies are lacking right now, and it need to be further studied.
Thank you, Rima. Thank you.
There's one question.
Yeah, can I ask a question, Dr. Rima? There are lots of queries that are coming about the people who are being vaccinated against the smallpox, whether there is any test available to measure the immune response in the terms of antibodies or neutralization antibodies. Is there a way we can assure them they're being protected by means of some titer being available?
Yes, ma'am. For understanding the neutralization titer, we need to have the virus with us, first thing. And this is a pathogen for which, for any virus, we should have the true positive case with us. No, none of the country is ready to share the viruses, if you ask, because it is a select agent. So till we have the virus with us, the neutralization assays are not possible. We can have a pseudo-virus neutralization assays with us, but it is not justifiable. But yes, if we do have an antibody test for a complete orthopox, which can detect the smallpox antibodies as well.
There is one more question. In one of the presentations from NIV, it was being shared. Last year from Pune, one of the students who accidentally got pricked while working on one of the cultures from virus, and tecovirimat was very difficult, or the vaccine to make it available in India was difficult. So is that the case right now also?
No, madam, I am not sure if NIV has been told about that. Someone has got infected with monkeypox. We have never had
a culture prick. Dr. Priya must have been shared this in one of her presentation.
Okay, she might have told not about that.
The second thing is immune prophylaxis is being available. Any immune prophylaxis? Because
there is a vaccinia immune globulin which is presently available, but it is not been found effective, and the trials have not been completed to justify it to be used widely. There is a vaccinia immunoglobulin which is right now present.
Thanks a lot. Thanks.
Okay, thank you. Thank you very much.
Thank you.
Now we can ask Dr. Vijay Kumar Chaudhary to complete his presentation.
Okay.
Dr. Vijay Kumar Chaudhary.
So I've removed the narration. So let me share the screen, and I hope it works, and I'll give the presentation. Let me share the screen.
Just screen share allow करो.
ठीक है. Please continue, sir.
Yeah, continue.
So actually, I've been listening to all the talks since morning, and the presentation, how much is related to the topic. But one thing is very sure, that it requires diagnosis and treatment, and antibodies are going to play a very important role. Professor Uppal introduced that how important antibodies could be. So without going into that detail, I thank Dr. Uday Kakru for this invitation to deliver a talk today. The 12th National Conference on which is being organized by Millennium India Education Foundation in collaboration with many other organizations. In the next 20 minutes, I will try to justify the title of my talk, Antibodies, Ek Naam, Anek Kaam, and along with examples of their utility in diagnosis and treatment of disease, our own work. I'm associated with the Center for Innovation in Infectious Disease Research, Education and Training, CIDRE, at the University of Delhi, after getting student at the University of Delhi as a professor. And this center was specifically established several years under Ordinance 15A of the Delhi University for carrying out different activities in the field of infectious diseases. However, research, the center, one of the important activities of the center is to improve training through hands-on courses. The details can be found on its website, which is listed as sidrate.ac.in. And its success of offering hands-on courses for last 7-8 years has been Delhi School of Skill Enhancement and Entrepreneurship Development at University of Delhi, which is going to start its activities very soon. Antibodies are highly specific, naturally evolved molecules and constitute one arm of the protective immunity, the immune system, to recognize and eliminate pathogens and other disease-causing elements. So they happen naturally. And then by understanding the structure and function of antibodies, these antibodies have been put to a variety of applications, such as in diagnostics and therapeutics. Antibodies that are produced naturally in our body are of different shapes and sizes, and then they can have different specificities and different functions. Therefore, they have one name, but they can do multiple functions. The concept of these molecules came from a German scientist, Emil Behring, as molecules found in the cell-free component, that is plasma of the blood, recovered from the patient who encountered an infection. For example, he showed that one could protect a guinea pig from ravages of diphtheria merely by injecting cell-free material of blood from another guinea pig who had disease and recovered of the diphtheria disease. However, at the same time, this substance obtained from the diphtheria recovered animal did not protect the guinea pig from tetanus. This implies that the protection was highly specific. The molecule was named antibody, and Behring's amazing discovery of curative power of blood led to the first effective treatment of diphtheria and tetanus, and he was awarded the first Nobel Prize in Physiology Medicine in 1901. This discovery led to serum therapy and was used for the treatment of many disease conditions, including tetanus, diphtheria, rabies, and snake bite, for which many of these treatments are still in existence, at least for snake bite. The plasma recovered from the convalescent COVID-19 patients has been used as an early treatment, very important, early treatment of COVID-19. However, the advent of recombinant human antibodies is poised to replace these kinds of therapy. Behring's work led one of his colleagues, Paul Ehrlich, to conceive that the blood must contain a myriad of antibodies capable of fitting around and blocking the action of foreign substances, the invaders, and which body encounters. However, at that time, it was speculation only, as it was not known as to how one's body could produce thousands of types of antibodies with different specificities, which was proved later that how thousands of types of antibodies are produced in our body. Because of this importance, and many seminal contributions on antibody research were recognized by Nobel Prizes in different years. Many of them are listed again. The antibodies became more useful for application with breakthroughs in the production of antibodies in cell culture following the hybridoma technology. And for the first time, immortal hybrid cells producing monoclonal antibodies of desired specificity could be isolated. For this work, Milestone and Kohler were awarded Nobel Prize in 1984. Antibodies produced by each hybridoma have only one specificity. That means they can bind only to the one epitope, and thus an antibody of given specificity can be produced in unlimited quantities and obtained in purified form from these hybrid cells. This PowerPoint shows that the antibodies are generally Y-shaped molecule, having the binding specificity at the tip of the two arms, yellow and mustard colored, while the stem, blue colored, provides the effector function. The specificity is generated by the amino acid sequence of 100 to 115 amino acids, long domains, the variable domains of the heavy chain and variable domains of the light chain. This knowledge that certain number of amino acids are responsible to give a structure to an antibody which gives the specificity, this knowledge has led scientists to design polymerase chain reaction based genomic strategies to clone different antibody genes for expression of antibody molecules in mammalian expression system. Another breakthrough in the antibody research field was the phage display of antibody, a technology which has allowed scientists to select fully human antibodies. The technology of phage display is very versatile, and due to its importance, the scientists George Smith and Greg Winter were awarded the Nobel Prize not too long ago, but in 2018. As shown here, the antibody molecule in scFv format, single chain fragment variable, is displayed on the surface of a bacteriophage M13, while the gene encoding the antibody genes are within the phage. As shown in the bottom panel, specific antibodies are selected through a process of panning, and after 3 to 4 rounds of panning, that is affinity selection, phage displaying specific antibodies can be isolated, and the genes or the variable domains of each of the clone can be converted into full antibodies for further production and characterization. In the same year, 2018, another Nobel Prize was won for therapeutic antibodies. Thus, 2018 may be called antibody year. What a tremendous recognition for antibody research. Antibody molecules find applications in every sphere of life, including therapeutics, diagnostics, and of course, in basic research in life science laboratories. Many of us will be aware of applications of antibodies in Western blot analysis, in ELISAs, in flow cytometry, and in many other applications. And many of us may have used many times again and again. Long time ago, we had produced monoclonal antibodies against proteins of the bacteriophage M13 for their use in phage display research. We published the research, but ensured that a patent be filed. This technology was transferred to a multinational company, Masses Pharmacia, which was bought over by GE Healthcare, who produced and marketed the product between 1998 and 2018 for almost 20 years as a catalog product. Through this, I want to convey that the research should be protected by filing patent, as it generates intellectual property to add to the nation's wealth, and individuals are also benefited. Our lab has produced a host of monoclonal antibodies using that hybridoma technology, and these antibodies have been used for various applications in the development of diagnostic tests for COVID, tuberculosis, and chikungunya, etc. The next slide shows some of our publication and patents on recombinant proteins for the work which I described. Antibodies are used in for developing a variety of diagnosis. Hundreds of types of diagnostic tests are dependent upon monoclonal antibodies. Currently, everybody might have heard of rapid antigen test for COVID. This test is based on the use of antibodies to detect N protein of the SARS-CoV-2. I'm sure other antigen tests could also be developed for other infectious diseases. At UDSC, we have been developing a variety of diagnostic tests for infectious diseases. For this, we produce either recombinant proteins to detect antibodies, or we produce high affinity monoclonal antibodies to detect antigen. Almost 20 years ago, we had produced a test for HIV/AIDS named NIVA-HIV, which detected infection just by using a drop of blood within 2 minutes without the need of any instruments or even electricity. And the results, as seen here, could be read within 2 minutes. And the readout is very similar to what is done in blood grouping test. The agglutination of the RBC in the drop of blood on a glass slide when mixed with an appropriate reagent, which are based on recombinant antibody products, happens due to the presence of antibodies to the HIV. Again, I'm sure it will be difficult to understand because I'm not giving the details. And this NIVA word was coined by one of my students for naked eye visible agglutination assays. And such assays can be developed for detection of antibodies for many other infections as well. Again, the work was published in many papers, but we again ensured that for every of the molecule we developed, we filed patents so that it creates intellectual property for the country. This technology was introduced by to the nation by Honorable Prime Minister of India, Shri Atal Bihari Vajpayee ji at that time. And a couple of years later, the commercial launch was graced by Vice President of India, Shri Kashkan ji. We have also developed a rapid test called TB Confirm to detect presence of M. tuberculosis in growing culture. This immunochromatography test or rapid lateral flow test allows for easy and rapid screening of bacterium of a specimen for confirmation of growth of tuberculosis causing bacterium, Mycobacterium tuberculosis, MTB. This test can be performed with minimal training and provides results in less than 20 minutes. The test is based on the detection of 2 MTB specific antigens, and for this we use pairs of high affinity monoclonal antibodies. It has been evaluated extensively with very high sensitivity and specificity. The test format of TB Confirm is similar to the rapid antigen test for COVID. And this format is known as lateral flow format. Here, the sample of the culture is put at the spot as the sample for the COVID is obtained from the nasopharyngeal or other swabs. And the readout is in the form of lines for positive and negative. This effort has got us means to our group many awards. This recognition encourages us to take up research programs which culminate in innovative process and products. Even Niva HIV, which I described just before, had won the Biotech Award in 2004, which had been constituted by the Department of Biotechnology of the Ministry of Science and Technology, the Government of India. Antibodies in different forms are employed for therapeutic applications. One of the major applications is in cancer therapy, where antibodies have been used in different forms. A modified form of antibody, the immunotoxin, was contributed by my research during my postdoctoral work at NIH many years ago. Although the use of antibodies in therapy started with a mouse monoclonal antibody, however, in current times, through genetic engineering, mouse antibodies have been converted into human-like antibodies. That means they have more of human content so that to avoid immune reaction, and they are safe to give to the patients. At the same time, now it has become possible to produce fully human antibodies so that they are safe to use and do not create immune response. This employs several technologies, including the fast display technology, which I explained little before. The discovery and product developments, there has to be incentive, and they are prompted by the need, utility, and revenue generation. The therapeutic antibody market worldwide is worth over $150 billion as of today and is poised to increase day by day. Many of these antibodies are used in India, which include Herceptin, Avastin, many others, which I'm not listing here. There is a galaxy of medical doctors which may be knowing more than me. During COVID times, there had been a lot of demand for anti-IL-6 antibody for treating COVID patients. Also, recombinant antibodies against SARS-CoV-2, known as cocktail antibodies from Regeneron, was successfully employed for COVID patients. But the emergence of new variant, especially the Omicron variant, has affected the efficacy of such antibodies. However, newer antibody have come up which are effective also against Omicron variant, including Delta and all other variants. Many years back, my research at National Institute of Health, USA, became the basis of recombinant immunotoxins, which are being tried for the treatment of cancer. After that discovery, many years later, almost 20 years later, the discovery paved the way for a drug, pneumotoxin, for the treatment of refractory hairy cell leukemia. This was approved by US FDA in 2018 and is produced by MedImmune. Well, the work carried out at NIH and now also in India has received a lot of recognition, and also the money in the form of handsome royalties. Me and my associate have also earned tens of lakhs of rupees as royalty out of work carried out in India, showing the importance of the work which is being carried out using the antibodies, using the recombinant antibodies. More recently, in the last 7-10 years, we have developed an immunization-free antibody discovery platform, which is being employed for the isolation of antibodies for the treatment of COVID-19. This technology is also being employed for discovering antibodies for the treatment of snake bite. The top panel shows how a phage display human library is created by taking B cells from the naive human donors. We have been able to create a library of nearly 10 billion clones. And once you have this library of 10 billion clones, means equivalent to 10 billion types of antibodies, as shown in the bottom panel and explained earlier, the process of panning can let you select desired antibody of desired specificity, which can be converted into any of these formats, full antibody or the antibody fragment, using the recombinant DNA technology. Again, this effort was recognized through a DBT Biotech Award in 2019, which is the third for our group in for different products. In this, besides me, you can see Professor Amita and Dr. Vaishali, who were involved in developing this work. At present, this antibody discovery platform is being used for selecting antibodies for the treatment of COVID-19 under a large project supported by DBT BioRec. We expect to obtain, or rather we have antibodies which should block the infection of Delta and also the Omicron virus variant of SARS-CoV-2. We have been developing these antibodies, but every 3 months to 6 months, emergence of new variant makes our discovery, I'll not say truly useless, but ineffective. This antibody discovery platform is also being employed for discovering antibodies for the treatment of snake bite, a problem of rural India. We wish to improve this treatment and make it simple and more effective through the use of recombinant antibodies. As it is known to all medical fraternity, at present, antibodies obtained from the horses which have been immunized with sublethal doses of the venom are used for the treatment of snake bite patients. The treatment has been saving lives of the snake bite victims for more than a century all over the world, but has got side effects. We hope that newer antibody cocktail produced by this or other related technologies will have less or no side effects and will be more potent in action. Thus, through DBT BioRec supported program in academia industry collaboration mode, we aspire to harness the full potential of versatile molecules like antibodies and make India self-reliant, Atmanirbhar, for therapeutic antibody discovery, development, and delivery. In the end, the take-home message is to get involved in antibody-based research, as it has multiple possibilities of application and will contribute towards Make in India and Make for the World concept of our Prime Minister. Well, it is time to thank you all for the patience and to show gratitude to mentors, students, associates, and collaborators for contributing in their journey over the last many decades, and to thank the funding agency in believing in our work and fund handsomely. This research is pretty expensive, but we have been getting good support from Indian funding agencies, especially DBT and BioRec. So I thank you once again. Thank you.
Dr. Vijay Chaudhary, it's a wonderful presentation, and you rightly said that your contribution in Atmanirbhar Bharat is really appreciable and recommendable job. You have contributed in the field of antibodies and antivenom
serums hugely. So we are looking forward that how One Health can be benefited from your association, and we are looking forward for your other support also. You have huge understanding and knowledge, so which can help the medical fraternity in management of the patients.
Yes.
So now it is open for discussion, and maybe I think some question can be taken up. We should get the benefit of his excellent understanding of the issues which we have discussed. Anybody want to ask any question?
I think everyone is getting text. So we will have a lunch at 1:30 for 10 minutes, and before that we have another 15-20 minutes. So I will we have a time for one lecture at least. So Dr. If you sum up Dr. Jugal Kishore, then we will ask Dr. Lal Krishna to chair the next session.
Yeah, both the presentations were wonderful, and one has highlighted the monkeypox and detail about monkeypox, and a lot of questions were there. The participation of other researchers indicate that people are concerned about it. Now this is already circulating in many countries, and we worried about India, whether we can have it or how we can prevent it, whether our vaccination of the smallpox is going to prevent us or not, or we require our children to immunize with smallpox, or maybe similar to that. Or maybe I think this is the area where we can develop the vaccine for monkeypox also. Dr. Vijay Chaudhary's contribution to his field and to the nation is he's already in Delhi University and established the center. So his presence here is enriching the our platform, and everybody has listened and learned about what can be done and how you are helping us in medical field. So this is really a wonderful session, and I'm really learned a lot from these two sessions. So Dr. Uday Thakur, please go ahead with the next one.
Thank you. Since our next session is on impact of climate change and environmental zoonotic diseases, Dr. Lal Krishna, former Animal Husbandry Commissioner, Government of India, is with us, and he will be chairing this section. There is one little request from Professor Akash Srivastava. He has to go, he's from IIT Kanpur, so he wanted to have his lecture ahead of Dr. Amita. So Dr. Amita is with us. Dr. Amita, will you have any objection if he takes the lecture first?
Ambika?
Dr. Amita? Anyway, Dr. Lal Krishna kindly resume it. And over to you, Dr. Lal Krishna. Dr. Lal Krishna? Please start it, and after this we will have a lunch break for 10 minutes.
बंद हो गई इसमें.
साउंड आ रही है आपकी? डॉक्टर साहब साउंड आ रही है आपकी? Some network issues.
हेलो
हाँ आ रही है आवाज आप?
हाँ हेलो डॉक्टर काकरो.
हाँ जी आ रही है आवाज.
I'm really thankful to you, sir, because you have given me chance for this to chair the session. But without wasting any time, that we are having 4 speakers in this session. So we invite first speaker.
Dr.
First of all, I want to give some of the introduction of this because this is one of the important area where nowadays it's playing a greater role in the conversion and emergence of the various of the genetic disease. As we know that this increase or decrease in the incidence of vector-borne disease is due to the climate change. And this increased incidence of genetic disease is mostly attributed to fluctuating temperature, causing prolonged period of vegetation growth and broadening habitability. So I think that the speakers would certainly cover the importance of the climate change in response to the various genetic disease which are now emerging due to the vector-borne or some of the aspects are the environmental changes. So may I invite Dr. Amita Agrawal, Head Department of Division Respiratory Disease, SET GS Medical College, KM Hospital, Mumbai.
Thank you, sir. Am I audible?
Yeah,
the screen share. Yeah, screen sharing will be allowed.
Yeah, yes, sir, ma'am. You are allowed. Kindly.
You are unmuted, Dr. Raksa, you are unmuted. Dr. Lalkrishna.
Unmuted. Yeah. So you wanted to have Dr. Srivastav talk first. I have no problem with that. So,
okay.
Or I can start either. I mean, either ways, I'm okay.
Basically, he had requested, I don't know, just give me a minute, let me ask him. No, it was a Professor Abhishek. Let me ask, he's from the IIT, Dr. Srivastava. Dr. Abhishek, are you there? Do you want to deliver a lecture? 10 minutes?
Yes, Dr. Kagru, thanks a lot. Yes, I have another meeting, so it would be great if I can present now.
Dr. Amita has allowed you, accepted your request, so kindly, but stick to 15 minutes, please.
Sure, I will.
You please restrict your presentation for 15 minutes.
Can you allow me the screen share right now? It is showing.
Yeah, you please.
Because now
yes,
I'm
sir,
trying.
you allowed, sir, allowed.
You are allowed.
Okay.
I think it's still showing my screen.
Now I hope you can see my screen now.
Yes, sir.
So thanks again, Dr. Kagru, for inviting me to present the research I'm involved in related to environment, One Health, and zoonotic diseases. Just a brief introduction. I am currently a professor at IIT Kanpur. I did my BTech in civil engineering from IIT Roorkee, then studied and worked in the US and Switzerland, and came back to India 3 years ago in the Department of Civil and Environmental Engineering. My research is on sustainability data analytics. So we analyze environmental, socioeconomic data to quantify the impact that our everyday products which we consume, as well as our everyday activities, how much damage they do to the environment. So my research is on quantifying these aspects. Last year, I was invited by the WHO to be part of one of the One Health panel, of high-level expert panel. So, so I will quickly talk about, like, all of us know how bad the pandemic was, what are the drivers. But recently, through our One Health activities, what can we do? So I will more focus on that direction in this talk. There are a couple of new reports that have come up only 2 months ago. I would like to summarize what actions government, businesses, and individuals can take to prevent such incidences in future. What are their recommendations? Things like that. And for the, I also tell that to my students. If people say, why is environment, why nature is important to somebody like me who is sitting in this room, I always give them this example of Indian vulture. So in 1990s, the veterinary scientists, they developed a injection containing diclofenac, which is given to the cows or buffaloes for inflammations. So this was now a classic case of how once we devise a solution for animal health, how it can have a trade-off or negative impacts on economy, human health, and even our cultural impacts at the national level. So what happened was that in India, the vultures are they eat, they are the scavengers, they eat the dead bodies of the livestock which are put outside the village or cities. So these, once they were eating these livestock bodies which had diclofenac chemical in it, that led to the kidney failure in vulture. So once vulture population went down more than 90% in India. Now what happened was that the other vector carriers like dogs and rats, their population started to increase because now they had more food to scavenge on. And then Indian rabies cases started to increase. Around 35,000 people die every year due to dog deaths in India, dog bites. So, and then the vaccine for rabies, it's also expensive. Government spends millions of dollars on that. So this is a classic case of how once we lack this One Health framework, once we work in silos, once we do not sit together and plan in a comprehensive way, such negative externalities can happen. This is much more evident now after COVID-19, and this has led to the 4 world organizations, so United Nations FAO, Organization for Animal Health, United Nations Environmental Program, and WHO. They invited applications for a multidisciplinary One Health high-level expert panel, which has now 26 international people, scientists from various disciplines, to come up with recommendations for governments on how they can avoid such incidences in future. So the first task that this panel has done is they have published this definition of One Health, because even though the concept is around for a couple of decades, here they have come up with a synthesized and consensus-based definition that we have to mobilize multiple sectors, disciplines, and communities to work together to break the silos, so that the animal health, environmental health, and human health, they go hand in hand. So this is a new report which I want to a little bit summarize today, about how in Southeast Asia, what can we do to prevent future pandemics. So as we know, one of the common feature of this emerging infectious disease is that they have a wildlife origin. And their frequency has been increasing over decades. East and South Asia are already the hotspots of such disease emergence. And the reason is because they have high population density, high livestock production. high level of wildlife use and land use changes, deforestation. So all this leads to human contact with these viruses or disease, and the spillover happens, and then we have these pandemics. And we know that these the impact of these diseases are much higher on the vulnerable groups, and that really threatens all the progress that these countries, lower and middle income countries in South Asia, all the progress which they have been doing for the last couple of decades, that really puts them back many years. So what we need is really a paradigm shift on how we manage and interact with our environment. And once we do it for our own purpose of human health, it has co-benefits. Once we will take environment into account in the planning, in policies, it will bring numerous co-benefits. So India is a signatory to Paris climate deal. So once we care about the environment, we will also achieve our climate goals, our biodiversity conservation goals, and other ecosystem services that the nature provides us. So already from this map, we can see India is one of the most highest risk country where the risk of zoonotic disease emergence from wildlife is really high. Again, the reasons I showed in the previous slide. And what they have found is that through this survey is that these countries in East and South Asia do not have the national systems as of yet fully functional, which are fully able to address emerging infectious diseases from wildlife sources. So what is the need is that they need to increase the institutional capacity to first understand the risk, then expand the monitoring and surveillance systems, and then enable all these veterinaries, people, environmental and human health scientists to work together. So what is the need of the hour here is they have categorized their recommendations into two main categories. First is that mainstreaming wildlife into world health systems. So, and the second is reducing the root causes of EID, which are, they have identified three main root causes, which is first is wildlife trade. Second is our food systems, mainly the livestock items that we are producing and consuming and distributing, and the habitat loss, which is driven by deforestation or other activities. So what happens is that these root causes, they increase the risk, they increase the contact between humans and this virus. And so we really need to manage these three items. So in the next slides, I will show what particular recommendations they have come up with. So for in the category 1, where we want to mainstream the wildlife into the One Health framework, is really include this wildlife risk informed policies, such as once we are planning for land use, once we are forming our biodiversity policies or even ecotourism, we need to take into account that all these have a risk. Once we are putting humans in contact with wildlife, there is a huge risk. So this should be taken into account in these policies. The second is we should really have the clear institution, define the mandates of different institutions, who is responsible for what kind of, for their actions, and develop a dedicated mandate for these institutes to assess and manage the risks from wildlife management. So, and then finally, of course, promote multi-sectoral collaboration. So allow different ministries and professionals to work together, provide such platforms and such kind of webinar that we are hosting and participating in today. These are really So good to see such things coming up, because these allow us to learn from each other, from environmental professionals to veterinary and medical professionals. So this is what exactly this report has recommended. Now, another thing which they are saying is that, of course, we need to identify the regions where there is a high risk. We need to enhance our surveillance capacities. We need to, of course, dedicate annual budget, which can be used for such systems. Finally, these are more long-term recommendations which will help to make the system more resilient. So basically, develop an assessment tool and funding instrument. Again, many people already in this webinar, they have underscored the importance of including such things in our school and college curriculums. Develop new courses which will train our students and generate these young professionals who have this interdisciplinary knowledge on these dimensions. Then coming to the second part of their recommendation, how can we reduce the root causes that cause such diseases? So first of all, they have identified that in the wildlife trade category, not all wildlife have equal risk of generating this disease. There are some mammals such as primate, bats, rodents, and small carnivores, and some birds like waterfowl. They are of greater concern for emerging diseases than reptile, amphibian, or fish. So we need to target these high-risk groups and species. Strong regulations, enforcement, and demand reduction efforts need to be put in place so that the root cause is targeted. The second is what are the high-risk practices? So they've identified that holding, slaughter, and use of live animals throughout the value chain present inherent hazards, even though the risk varies. So we need to introduce safer practices in wildlife trade for source to end use. We need to outreach with communities and wildlife breeders and educate them about which species are higher risk. And we need to generate incentives so that the demand for such products. So responsibility lies with each actor. We can't just put everything on the government. It's individual responsibility. People need to reduce their or change their consumption behaviors. People who are producing them need to be more careful and identify the risk and adapt best practices. The government needs to come up with carrot and stick approach. And the scientists, of course, they need to come up with the underlying mechanisms and information. So only through such integrative efforts we can make progress towards reducing risk to such diseases in future. They are also saying that we should ban the sale of live animals in market settings because that increases the risk of contact. We need to develop legislation capacities and infrastructure that prohibits the hunting, sale, and keeping of bats and primates, especially. The second is after wildlife trade is well managed, we need to come up with good practices in our food systems. So, for example, our food system contain products from wildlife in this East and South Asian region. And sometimes this wildlife can come in contact with livestock. So one of the example at the end of my presentation, I will give about Malaysia, how they put pig production in close contact with the fruit orchards. So the bats were coming to eat the fruits, and that's how this Nipah virus got spilled over in the whole country, because you have put the pig production in close contact with these bats who are the carriers of such virus, and that led to this outbreak of this disease in Malaysia. So we really have to be very careful about such biosecurity things. So what they are saying is that we need to phase out the consumption of wild sourced high risk species, of course, that's bats, rodents, and primates. Over time, we need to provide alternative. So such many communities are reliant on such species for their protein intake. So we need to set up such framework so that they have alternative nutritional sources and they reduce the consumption of wild animal products. Another risk mitigation measures this report from FAO and World Bank have come up with is that we need to ensure mandates and resources are in place. We need to monitor disease and conduct pathogen surveillance through meat inspections at point of sale and also the upstream in the value chain, because even the driver who is the transportation people bringing meat from the jungle to the city or town or village, even they can be the carrier. So it's really from the source to the end, this holistic life cycle approach needs to be taken up and set up. Enhance hygiene and biosecurity measures at critical control points and work with relevant stakeholders to find suitable alternatives. The third major root cause of such emerging disease is habitat degradation and loss. This is wide-scale land conversion and encroachment on wildlife habitat. And this root cause has been identified with in 1/3 of the cases, this was the root cause of the disease outbreak. So what happens is then once we clear the forest, it creates edges where humans, livestock, and wildlife can come in contact with each other and the spillover can happen. So due to population increase in such region like India, human settlements are increasingly coming closer to frontiers of wildlife. We are intensifying our agriculture and livestock production, and even the mining industries or logging industries result in habitat degradation and loss. In Southeast Asia, we are losing around 1.3 million hectare of forest annually since last 20 years now to meet our growing affluent urban population demands. Of course, climate change, what happens is that as the climate is changing, some regions are getting more rain, some regions the temperature is increasing. So the species want to shift to adapt because they are shifting to different regions, and that is increasing the risk that we are coming in contact with them. So climate change may act as a threat multiplier for other drivers. So all the mitigation measures that we want to adopt for climate change, like phasing out fossil fuels, reducing the demand or improving the technology so that we are emitting less CO2 in the atmosphere, these are also will be helpful here. So there is a tight links between climate conditions and species abundance and behavior. So these are also likely to affect the risk, but these risks are really difficult to predict because it's so much variation across species. Now, what can we do over here is, of course, improve our land planning processes. Once we are, so like in environmental engineering, we have a term called environmental impact assessment, which is mandatory once you propose a new project. But in such EIA reports, we are not yet quantifying the risk of such disease. So what they are saying is that now whenever a new road, airport, or any project which is likely to encroach on our wildlife should quantify such risk. What is the risk of disease outbreak due to a new infrastructure development in, let's say, some jungles of Arunachal Pradesh? So these kind of things we need to come up with. Just one more slide after that. We need to integrate disease and environmental impact projection into cost benefit calculations. We need to engage the rangers, hunters, and local communities, ensure our monitoring systems are in place, improve the early warning systems. And finally, even this decade has been declared by the United Nations as a decade of ecosystem restoration. So we have, through our activities, with the single focus on GDP growth, that has led to degradation of our environment. So once we are preserving an ecosystem, once we are planting more trees, once we are preserving these habitats, that has a co-benefit that disease, such a risk of such a disease will also reduce. So our protected area should increase, and that can also help us over here. So this one example I wanted to give what is happening in real life, how Malaysia managed this Nipah virus through One Health approach. It's a classic example of how the bat pig, the disease spilled over from bat to pigs and then pigs to humans. So this required collaboration between forestry, wildlife, veterinary, and human health scientists to sit together and come up with strategies. So this led Malaysia and Thailand to institute a policy of distancing fruit orchards and pig production. So they devoted additional attention and resources to surveillance programs. They identified the areas at high risk of disease spillover, and they went on an outreach campaign with farmers outside of these areas to take alternative livelihoods. So Malaysia has experience and strengthening of their One Health system policies, institute mandates, and information systems around Nipah virus risk can be considered a good practice example with lessons for others in the region. This is the final slide. Another example this report gives is about Bangladesh, who set up a National One Health strategic framework and action plan in 2012. And here a National One Health Secretariat was formed with a rotating chair position among 3 government agencies. So Ministry of Health and Family Affairs, Ministry of Fisheries and Livestock, and Ministry of Environment. So each of these ministry is on a rotating basis chairing this secretariat, and the shared ownership maintains important political will among ministries and promotes awareness and collaboration to address areas of weak capacity. So this example illustrates how better planning, coordination, and collaboration are often affordable and can be achieved without incurring high cost and through political will. So this is it from my side. Thanks a lot again.
Thank you, Dr. Chaudhary. I think it is a overall picture of the climate situations, which is already having the guidelines under the OIE. So, but one should be very thorough in understanding the climatic change which are being taking place and increase.
Doctor, you got muted. आप muted हो गए.
So may I request another speaker, Dr. Athale?
Yes, sir.
Before that, sir, one small query, sir, probably for the biodiversity, which was very insightful what he spoke, sort of Abhishek spoke.
Yeah, that's true, that's true.
And very insightful and very riveting, Abhishek, appreciated, well appreciated, because that is the main crux of the matter, basically, from where the origin of the problems are, emerging out, My question is, could the lack of Mother Nature cause, the next pandemic prophetically? And related to that is, will it be a pandemic war for mainly for compromised diversity, biodiversity, and combat wildlife crime? Do you agree?
Yeah. Because OIE has already drafted the guidelines in making this One Health program with the WHO, so that all the guidelines are already existing at present, because we have already seen the guidelines in OIE, and accordingly this One Health program was formulated.
Sir, I summed it up, with Professor Abhishek, probably with this complete this thing, presentation what he gave, which was very riveting.
Yeah.
My question was, to him that, can the lack of Mother Nature, which we have insulted, continuously and progressively, be a cause for this pandemic, in prophetic terms?
Absolutely, I totally agree with you.
And related to that, Abhishek, is the next point is that, will the compromised biodiversity, what you pointed out, repeatedly, and combating wildlife crime will be the main issues, to settle, before probably face another challenge in front of us, like your Omicron now.
I cannot emphasize enough, Venkatesh, this is really, you're absolutely right. And I 100% agree with you that these are serious things. I mean, everything is interconnected. Once you are insulting the nature, it is going to come back at you. And this was just a trailer. And so my main focus of research within environment is biodiversity conservation, basically. And I think that's even bigger issue than climate change. We are losing species on an hourly basis. Species are going extinct, and the whole nature balance, every species has a function in the ecosystem where it appears. So once you remove one link, the instability is out there, which leads to increased population of some species versus the other, and that process is happening, and we can't emphasize enough to preserve our biodiversity. And here again, I want to emphasize, government cannot do it alone. We as individuals, we need to make informed decisions whenever things we are purchasing, our actions. The responsibility relies with everybody, for businesses who are producing the products, but also consumers like us. We need to look, so, as they say, no pain, no gain. So everybody needs to shoulder some responsibility.
I
agree with you, Dr. Chaudhary.
Time to wake up and spend a coffee for all of us, sir.
Sir, may I have one point, Dr. Lakishan, sir?
Yeah.
Sir, we are talking about this small species of insects and other things which are going out of the system. Here, we are losing our major capital in terms of the breeds of these cows, precious cows, which were given by our forefathers from thousands of years. And we are not able to sustain them in the present system. But my point is that everything is making of a human being. But when we are presenting, we are putting the onus on the high population of animal or something else. And the other thing is that the soil, which is a very important component, and One Health is incomplete without soil health, because it's an interplay of minerals. What is a human body? It's a combination of different elements in a specific or a format which has been designed by our God or whatever nature. So if some elements are going out of the soil, or some are increasing in this quantity and other things, so it is entire gamut of things which is affecting. So that's my point, sir. And it's a human, and Dr. Venkatesh is very right that it has to be now a culpable crime. Whosoever is damaging this mother nature.
Dr. Surbi is saying actually One Health means it involves all factors. Whatever the means factors are there, they are to be come together to support our own profession. Because nutrients availability from the soil, it's coming from the plants, then to human beings, as well as to the animals. So that is playing a greater role also. So that should also come in under the same purview.
We can adopt these resolutions at the end of the conference. So
Thank you, sir.
Next speaker, please.
Thank you.
Sir, you are absolutely right. We are interconnected, interdependent, interrelated.
Yeah, they are totally means all things are interconnected. So we cannot rule out any of the separate entity. We have to see in totality, not separately. So, Dr. Atile.
Yes, sir. Am I audible? I'll be allowed to share the screen.
Yeah. You are audible.
Yeah. So are you able to see my screen?
Not yet.
Not yet.
No. Dr. Lakisha, unmute yourself. इसके बाद Dr. Akash को kindly बुला देना because he has to go somewhere.
Okay.
Okay. Should I start?
Yeah, please start.
So good afternoon. And let me at the outset thank Dr. Thakru, Dr. Kemberry for inviting me here to share our experiences regarding what happens to human health while the impact of climate change and environment is on zoonotic diseases. I would briefly give an overview of the medical point of view, what we do practically in the next 20 minutes. So as this August gathering is aware about impact of climate change on human health, the various factors which are responsible for...
Your screen is...
You are not sharing your screen.
Oh, so probably they have to allow me to share the screen. Will you tell them?
Imtiaz, screen share karao. Imtiaz.
Are they?
Let me check.
Dr. Kapru, please allow the screen sharing.
जब तक आप कीजिए, let me find out where he has gone. Imtiaz.
Madam, वो allowed है शुरू से ही. Madam, kindly do it.
Kindly
start. Yeah.
Yes,
open your presentation first, then share.
I'll have to open again. Okay.
Yeah.
I'll do that. Is it now visible?
अभी नहीं आया.
आया?
नहीं आया.
शेयर करके उसको यस कीजिए, फिर मिनिमाइज योर
करिए, यस करिए फिर.
Just a second. Earlier you were able to see, right? So when I'm saying share the screen, I'm not able to.
Not able to see.
इम्तियाज इनको हेल्प करो. Imtiaz?
I've opened it. I'm able to see my screen.
No.
I have actually mailed it also in case.
Have you mailed it? Okay.
I have mailed it.
I
mailed it to you, sir.
Okay. I'll just find out. आप तब तक शुरू कीजिए, मैं अभी वो कर.
Okay.
अरे तुमने इनका स्क्रीन शेयर नहीं हो रहा, मेरा भी स्क्रीन नहीं शेयर हो रहा. मैं इसका ईमेल से नहीं, उनसे तो नहीं हो रहा, मेरा कर दो. हो गया.
They are letting me share.
Yes.
Yes, ma'am.
But it has gone to.
कीजिए आप शेयर.
I'll be able to share, sir.
अभी आया नहीं.
कीजिए मैडम. दोबारा कीजिए आप. दोबारा कीजिए.
दोबारा कीजिए. Okay, I'll do that.
Yes.
बताइए अभी आया?
नहीं मैम, अभी नहीं आया.
ऐसा हो रहा है. I'm seeing it on my screen, but that's of no use.
आप तब तक ज़बानी कीजिए, मैं डाउनलोड कर रहा हूँ. I'll share that. Then you can continue with that.
Okay. So should I go ahead?
Yes, you go ahead. I'm just sharing in a minute. आप जब तक कीजिए.
Right, right. So what we have been discussing regarding climate change and what has been said so far is the way it is affecting the human beings, and it has been probably in the last decade we are out of the safe zone. All these years we were contemplating that it will be upon us, climate change, and then whether we were prepared for it. But now it is that we are really out of the safe zone, and one aspect of it is seen in the form of emerging zoonotic diseases. So regarding zoonosis, enough has been said since morning, and my initial slides were about what is zoonosis, what is reverse zoonosis. Leaving that aside, I'll come directly to what is the impact on humans. So the impact of humans, if I take a single example of city of Mumbai, which is a coastal city, and what we have faced in the last 2 decades has been floods, has been multiple times, there has been leptospirosis outbreaks, there were enough incidences of vector-borne diseases which were going out of control, and it was our community medicine department which left no stone unturned to get the malaria pandemic epidemic under control. And so as well in COVID, Mumbai did a humongous task to work through the pandemic. So what does it mean for us? Are my slides going to be visible?
I'll be just showing.
Yeah.
Give me a minute.
Yeah. Because my screen is not opening at all, is it?
It doesn't matter. I am just
okay,
sharing.
Okay, sure, sir. So for the want of time, I would continue to tell you what we have been doing in our department. Essentially, our department is of Department of Pulmonary Medicine, and it has a small health survey cell which does community-based work. So we actually go to people whenever there are problems reported related to air pollution or any environment-related issues, and then we on-site conduct the studies. How does it help us? As a physician, when I sit back in the outpatient or indoors, I realize when a patient has developed the problem. But when we go to the community and actually try to see what is happening to the human beings, that's the time we realize what are the root causes which are giving rise to the problem.
Are you able to see now?
Yeah.
Yeah, you're able to see, right?
Which slide now?
Yeah, so now I have been talking randomly. Essentially, this was. Yeah. So who will operate? Should I be saying next?
I will operate. You just say next.
All right, sir. So you are on this. We can go to the next. So this is where the reverse zoonosis. Yeah. So the spillover, we are already aware about it, and the earlier speaker mentioned enough about Nipah, and the zoonosis per se has been discussed very well. Probably I'll give you the flavor of what is being done in Mumbai city, being a coastal city, and where do we go further from there. So coming back to the 8 slides of population density. So yeah. So these pictures you all have seen, and we face it every year. And how does zoonosis connect with this? So essentially, being a pulmonologist, we deal with lungs. Next, please. Lungs are situated internally, are probably one of the most, are the largest external organs, because the onslaught of airborne viruses, airborne dust, fungi, everything is taken by the lungs. The surface area of the lungs is equivalent to half size of the tennis court and is about 140 square meters. And that's why probably the pulmonologist sees it all. Leptospirosis, next please. So next please. Leptospirosis earlier on was probably not recognized in an intensive care unit. We rarely had to treat ARDS way back in 90s. That was a sporadic case which would come in intensive care unit. But over the years, leptospirosis is requiring to be treated in intensive care also. Do we have to think about these practices? We have been talking about people's participation, and probably that is one of the most important things regarding zoonotic diseases also. This picture speaks for itself. Are the animals' normal habitat being maintained by just feeding them roadside? Are we maintaining or doing our duty is really something which needs to be thought. We have learned about rabies outbreak also in the earlier sessions, and so is leptospirosis, because probably these animals are also reservoirs of leptospira. Next, please. So as I said earlier on, we were having probably the asymptomatic infections which got treated and there was no severe disease. Nowadays, what we see is because of the waterlogging, stagnation, even children who are going to play in playgrounds during the rainy season in muddy areas have had the onslaught of leptospirosis, so as it is in rice paddy fields also in the state of Maharashtra. So it does not leave the urban or the rural citizen and affects both. What could we do about it? We need to probably learn from the veterinarians whether we are going to be having vaccination of the animals, and most importantly, probably we as urban citizens need to train ourselves. Mumbai Municipal Corporation has this initiative of training the first responders. What do I mean by that? As Mumbai has been facing frequent floods during the rainy season, this is something which needs to be imbibed for a citizen, that if you have waded through water and develop a new symptom, you should not ignore it. A fever developing after wading through water has to be addressed by the physician. The physician has to be told the history that I have waded through water, because it's a common finding. Whenever it gets flooded, in about 10 to 15 days, we start getting these cases of leptospirosis. I hope this year it should be better and we should not be having the problem. But so far, the experience has been so that it gets flooded and then we have to face the trouble. So what could one do? How does the training matter here? So stay indoors, don't venture into muddy waters. Flooded waters is something which has to be done. And for that, we need to train ourselves for having our offices equipped if we have to stay overnight. So packaged water, packaged food, and the required medicines have to be with people, so as the neighborhood has to be trained for taking care of the elderly and the children back home. So that is personal health preparedness that is to be done as a practical measure while we deal with climate crisis, because these episodes, till we have definitive measures, would be probably, and we will have to undergo this, and that's why these small things help. When I say medicines, a prophylaxis, whether it should be taken if you have waded through water to prevent the diseases, also is a cause of concern. So that is what I mean by personal health preparedness, which comes with climate crisis preparedness along with it. Next, please. Other important aspects in a city of Mumbai have been even the pigeon-related diseases. Since we are at vector-borne, the various types of vectors that one has is the pigeons, when they are infested with fungal infection, they can lead to what is called as extrinsic allergic alveolitis. They can worsen asthma. These are allergic in nature or not really infectious, but nonetheless, they can be incapacitating and can lead to permanent damage of the lungs if not treated in time. This has been published in the Journal of Association of Physicians of India. And from such experiences, we learn whether and how we can modify the environmental factors. What do I mean by this? In Mumbai, you will see many sites which have pigeons, which are at times sites which are historic and cannot be taken away, or the newer sites are developing at nook and corners where, with religious sentiments, with cultural diversity, people are feeding birds. But in Mumbai, the population density is such that birds and human beings are in close proximity, and when they are infected and people are allergic, they can pass on these to human beings, and then one actually gets the onslaught of getting the oxygenation down and interstitial lung diseases are on the rise, namely extrinsic allergic alveolitis, which is related to pigeon infection with fungus. So how do we study this? Next, please. As I mentioned, we actually go in the community with a team of pulmonary physician, social workers, health visitors, and the technicians. To understand what is the problem, we actually carry out a questionnaire study. We give out questionnaires which has symptomatology and check out whether the problem is more than 5% at a given place. If it is found that the respiratory morbidity, which is in the form of respiratory symptoms, is more than 5%, then a cause and effect relationship is tried out. I mean, what are the sources? What are the emission inventories in that area is undertaken with the help of NEERI, that is National Environmental Engineering Institute, and our environment department team at MCGM. Understanding that, we then actually call the people from their houses and do an on-site pulmonary function test. So from here, we gather that what have been the problems, whether there is obstructive disease, whether there is a restrictive disease, and then they are given a choice of coming to KM if they want to, and if they wish to, or they could go to their family physician for getting the ailments corrected. This helps us in actually finding out the cause and effect relationship, and then this report is handed over to the corporation under the environmental status report. So the common areas which have had a problem have been dumping ground sites, have been people living next to the industrial areas, and that's where we find out how the impact of environment is happening on people. So as it is seen in this slide, it is ultimately survival of the fittest, and that's why the urbanization, the mobility of people, ultimately the way we manage ourselves has the health impacts which are seen from time to time. It is our social political response that is leading to the lifestyle changes, the behavioral changes, and how we take our own environment. While we have been managing the home environments, do we look at the office environment also equally diligently? Also the environment in toto, if we take care of that, or we are complacent to that, ultimately is going to decide, as it has been said in the earlier talk also, it's people's participation which is of very great importance. And I would say apart from the participation, it is also the people's preparedness to deal with the climate crisis that we are undergoing will help us build their confidence and maybe then adopt the practices which will ultimately get us better in a better world. Next, please. COVID has probably taught us a lot. As a physician, we have learned what one particular viral disease can do. It has multitude of systemic effects, and then the immunity that it brings down ultimately can have a person catching other infections like tuberculosis, like dengue, and that is what we have been facing in this monsoon season also. And enough has been said about antibiotic resistance also. So one calls it a syndemic, a climate change related changes along with COVID-19 is something which we have undergone. I hope that the lessons that we have learned will allow us to get better and better and come through the crisis, which I feel will be hopefully ending in near future. So next, please. So next slide, please. Yeah. So what do I ask for? So this was the last point was that we have the vaccination program for children. For adults also, we have it on paper. But whether a time has come to vaccinate the senior citizens and the adults, also the animals, to the extent that it will be a wide coverage, and how we could do that, whether we could give the responsibility to the non-governmental organizations also to undertake animal vaccinations, especially in a area like Mumbai, which has a high population density, is worth considering. Lastly, what do I ask for? There have been 5 lessons that we have learned while we treated COVID and we are facing climate change. As it has been said that we cannot delay it further, we need to create institutions which will have long-term policy goals, We should have the citizens on board. We have various sectors which have been brought together in this important conference. And I think such initiatives are going to be the future policies which will help us. India is going to be the host next year for G20. And that is where, if we give health as a major agenda, probably we'll be able to have some public health policies for the country, and that will help in future mitigation also for us. So I ask for a National Environmental Lung Health Institute for City of Mumbai, so that in a common platform, we could have an integrated approach where we could create awareness. Important to create public awareness, which is what we do at our Asthma Education Center, where we carry out patient education, identifying city-specific newer risk factors and changing risk factors, and finally, primary prevention and environment control measures will be our goal. Last slide, please. Thank you very much. This slide actually has an audio, which is a song, and it talks about what Hippocrates said many centuries ago, where it has to be air, water, and places which have to be looked into together. Thank you very much for a patient here. Thank you.
Thank you. Thank you, Dr. Chaudhary.
Thank you.
I think it is a very good experience of the pulmonary diseases which have been emerged out of the COVID infection and the post-COVID reactions which we have seen in the lungs, even the asymptomatic patients also. So I think we may go ahead with 1 or 2 questions, not more than that. Hello.
Yes, sir.
So we can request the participants to go for 1 or 2 questions if they want. Otherwise, we can close down.
Yes.
Good afternoon, madam and sir. I'm Dr. Shashi from Srinivas Srinivas Institute of Medical Sciences and Research Center. I really appreciate your presentation, and also Dr. Venkatesh, and also IIT Kharagpur, sir. Because we are from coastal Karnataka, so here the problem of all those things, whatever has you 3 people have discussed, are very prevalent. We have pigeons making nests in the buildings, and particularly in hostels and medical colleges. And so it's we would like to get guided by you, madam, please.
Yeah.
And also
So,
to the other sirs. Yeah.
Sure, sir. Sure, sir. So pigeons really breed multiple times. So they multiply very quickly. So there have been various initiatives taken by other countries also. We have also been trying to do that wherever we see the problem. So here, to identify whether they are infected with a fungus, so essentially they get coccidioidomycosis, aspergillus in them. And then if a human being is sensitive, because you know what is seen is, in a family, everybody is not affected. There would be 1 or 2 who would get it. So in fact, we have initiated a study also to identify the genetic risk in this. So what could one do? One could spread a bitter solution. They have a memory of 45 days that has been studied. And so they return to the place in a month's time, in 1 to 45 days. So if you have a bitter solution which will not be toxic to the birds, say neem, but will have a bitter taste so that they don't return for their food, then that is possible. Some countries have tried even birth control in the form of giving them food which would have substances which would have birth control. I'm not an expert. Maybe we could have the veterinarian's opinion regarding whether such practices could be tried. And ultimately, it is our social responsibility that whether we are going to do that, because we try to investigate it, that whether there are cultural practices in a particular community, and that is so. But if you really read through in detail, the temples which are supposed to be having the bird feeding, which is to be done, was mentioned in ancient times, where these temples were away from the human habitat. They were, I mean, probably it has been said that the topmost point of the temple's shadow Up to that level, you should not have a human habitat. So that's how that time probably it was all right to feed the birds then and there. But now if we are losing lives in the form of human beings getting affected, probably we need to think twice. And that's where our legislative and public health policies probably could play a role if we have definitive answers. It need not be a political issue. It need not be a cultural issue. We need to have a scientific aspect for this. And if we work together on this, I'm sure we'll succeed.
Thank you. Thank you very much. May I invite Dr.
Sir,
Okay,
very
Dr. Yeah.
General Venkatesh, sir. Dr.
Dr.
Amita, very well
Akash,
said, because it was beautifully said, what you recited. Because reason being that, what is happening nowadays is that, the habitat of the birds have been lost, and like a Trafalgar Square, we're feeding them in the open, in cities, in the midst of concrete jungles, Real jungles have vanished.
Absolutely.
Due to which, probably these diseases, which were rampant elsewhere, wherein they could perish there, going quietly, is, being contaminated, to the zoonotic human beings now,
True.
Like they say, like we lost our biodiversity, कि पेड़ काटने आए हैं कुछ लोग मेरे गांव में, धूप अधिक है कह के बैठे हैं उसकी छांव में. That is what happened practically.
Yes, sir. Yes, sir.
These pigeons were supposed to probably eat with you and go back, to their lifestyles, to their own habitat in trees, and other forest areas, probably hanging around in the habitation only.
True.
So we may go ahead with the Dr. Akash.
Yes, sir. Thank you very
Please
much.
do, sir. Please do.
Thank you. Thank you very much.
Thank you.
Go ahead.
Dr. Akash, sir, please continue.
Yes, sir.
Unmute yourself, doctor.
Hello.
Unmute कीजिए डॉक्टर साहब.
हाँ जी. Okay, I am audible now.
Yeah, you are audible.
Okay. Good afternoon, everyone. I've been hearing some presentation in this session today, and I think largely a lot of that was being talked about was about One Health and zoonotic diseases. As I come from National Center for Disease Control, I just before I go on to my presentation would say in 2 words that for the audience to know that there have been individual zoonotic disease programs that have existed, national programs, such as, for example, leptospirosis, which was touched by the former speaker. And the purpose of the program is to address leptospirosis across the country and the needs of its diagnosis and response of the government sector in regards to that. Also, there have been a program that was a program on intersectoral coordination for zoonotic diseases, which has existed for a while and which is now getting converted into a One Health program. While it existed as a program for intersectoral coordination, there were regional committees formed in the different parts of the country for different sector representatives to come together and work. We heard from previous speakers about the issues related to climate change, biodiversity, land degradation, soil health, and many other issues which probably are relevant, but there is very less that the health sector itself can do about these issues. They are largely related to mitigation problems from these departments, and all that if there is an intersectoral coordination meetings happen, they share their problems related to those, concerns related to those, and the respective organizations that deal with biodiversity, land degradation, soil health, etc., take into account what has been shared by the health sector representatives. So that's how we've been working all the time previously, and that's how area issue of One Health is being addressed. I work in altogether a different program, which is a program on climate change and human health, and my presentation largely touches on that. We are also a part of the One Health program that is being established by the government, and under that program, the foresight is that each ministry and each sector will have a One Health cell, which will specifically deal with issues related to One Health and also related to environmental concern. So when that comes up, that will be much more easier to coordinate with them and try to find solutions between ministries and between sectors on issues related to One Health and also on issues related to environment, even issues related to antimicrobial resistance, etc. Anyway, for the time being, I'm going to talk about this presentation that relates to my program. It came into being because there is a Prime Minister's Council of Climate Change in this country, which used to have 8 missions to address the climate change issues, but there was no mission on health. So it was introduced in 2015 as a new mission under the Prime Minister's Council on Climate Change, and a national action plan, which is actually the health mission document, was drafted and is being periodically updated. To implement this program at the central and at the state levels, a health program by the name of National Program on Climate Change and Human Health was approved under the NHM umbrella, which is the funding mechanism between the center and the states on the health-related issues, and was approved by the Mission Steering Group in the February 2019, and the program came into existence. The goal of the program is to reduce morbidity, mortality, injuries, and health vulnerability to climate variability and extreme weather. This slide was probably also shown by the previous speaker, but for my purpose to show this slide is to say that these are the various realms how climate change impacts human health, and the ambition of this program is to address all of these realms. So it is, be it air pollution, be it extreme heat, be it change in vector ecology and surge in vector-borne diseases, be it increase in allergens and allergic diseases, impacts on water quality and waterborne diseases, issues related to food insecurity, food security, and issues related to environmental degradation, migration, mental health. All of these issues are to be considered under this program, but in a phased manner. For each of the areas that we have mentioned in the previous slide, the program will try to address them through 5 main pillars. The first is by generating awareness about those areas, either to IC campaigns, sensitization workshops, or issuing advisories to the government officials. The second is capacity building of the healthcare professionals and issuing guidelines and manuals in the health sector. The third is strengthening the health sector preparedness, that is through preparedness of health adaptation plans. And since, as we learned in the previous slide, there are so many different climate sensitive conditions, so separate specific health adaptation plan for each of those conditions. Vulnerability assessment, enhanced surveillance on specific conditions for which there has been no surveillance previously, or if a surveillance already exists, then incorporation of climatic variables in those surveillance, early warning, alert and response systems, and developing green and climate resilient healthcare infrastructure. The next is collaborative partnership. As we discussed earlier, there is a strong need of various sectors and ministries to come together. So one of the work that this program has tried to do is to bring together different ministries. We have a very senior level steering committee, which is jointly chaired both by the Secretary Ministry of Health and the Secretary Ministry of Environment, and representatives to the level of Joint Secretary and above represent different ministries. We usually have once or twice a year meeting, and we put forward all the relevant issues that different ministries may need to undertake to address issues related to climate change and environmental health. In context of year-end development, ICMR is the main lead organization for the Ministry of Health. So there is a research committee with ICMR chairs in relation to climate change, air pollution, and other environmental health issues, and research proposals are invited, and then they are funded by ICMR. So the organizational framework of implementation of this program in the country at the national level is through the NCDC being the headquarter of the NPCCHH program. And we have 18 centers of excellence, which are premier institutions which have mandate to work on specific health related areas, and they provide us inputs into how climate change impact that particular health area and how when we move forward in strengthening the health sector in that particular component. At the state level, there is a state program officer, and he is supported by an environmental health cell at the state. There is a multi-sectoral task force wherein representatives of various sectors related to climate change are brought in a meeting which is held every quarter under the chairmanship of the principal secretary health of the given state. And then there is a governing body which actually is chaired by the Honorable Health Minister of the state and only deals when there is some specific policy related issues that have to be taken up, which needs to take the consensus of very senior level professionals from certain sectors. And down at the district, we have a district program officer, and then there is a district level task force, which is chaired by the district magistrate. These are the centers of excellence or the premier institutions which address specific health related issues on which we are working. As of now, the highlighted in yellow colors are the areas in which we are moving at a more focused speed compared to the others, though all institutions which have been listed as centers of excellence are drafting adaptation plans, developing training manuals, developing material for raising awareness in that context, designing surveillance systems, and monitoring and evaluation system for that particular aspect. So what do we do in awareness generation? We work on developing IECs, whether in videos, audios, posters, social media content. We also hold international days, which relates to our subject. This year, the subject on World Health Day was related to One Planet. Then we work on World Environment Day, on International Day of Clean Air for Blue Skies, International Day for Disaster Risk Reduction, etc., etc. And campaigns are held all across the country by all state health departments and the other institutions that partner with us. Then we hold sensitization workshop for policymakers and health officials, issue seasonal advisories, and we also have a newsletter that we circulate each quarterly. And the purpose of the newsletter is to bring in stories of the work that has been done by different states in different subjects. So there is a shared learning. In pursuit of capacity building, it's the training of the program officers and the master training, which is done at the central level by us and the centers of excellence that work with us. The states also train the hospital nodal officers who are involved in the network of sentinel surveillance. For example, in air pollution, we have a sentinel surveillance, while on heat, we have a general surveillance all across all healthcare facilities. Then we're developing training modules for program officials, medical officers, health workers, and also for population level modules, community level training modules. We have developed, for example, in air pollution for specific impacts on women, children, traffic policemen, municipality workers. We organize webinars on these subjects. We have knowledge exchange, field visits, and workshop. In the World Health Day in April, all program officers were invited to Kerala at Kozhikode, which have done wonderful work in developing flood resilient healthcare facilities development. So all program officers had opportunity to look at those facilities and learn and replicate them in their own state. And again, at the World Environment Day in June, we all met at Ahmedabad, where a lot of work has been done in regards to heat action plan and work done by Ahmedabad Municipal Corporation in making the taking activities that are makes the population heat resilient. And then we also have been working on inclusion of climate change and health impact in teaching curricula of medical council and allied disciplines. We had contacted six councils, and most of the councils have come back with efforts that they have done in putting up climate change and health issues in teaching curricula at both graduate and postgraduate level. In regards to health sector response to climate change, as I mentioned, they have subject-specific health adaptation plans. It's been developed by centers of excellence. National health adaptation plan has been developed for air pollution and heat when it was released last year by the Honorable HFM. And we are working on 2 specific surveillance as of now. One is air pollution related illness surveillance, which has been implemented at 60 hospitals from 18 states. In the Sentinel, identified Sentinel hospitals, data has been collected from emergency department on acute respiratory illnesses. And then the data has been correlated with air quality index for the given day. And the feedback is provided to hospitals as well as other stakeholders to take necessary action. And very soon we're going to digitalize it, and it will cover not only respiratory illness, but also cardiovascular and cerebrovascular incidents admitted in the hospital in the given Sentinel hospitals. The next surveillance that we have is heat-related illness and death surveillance, largely covers the heat stroke cases that are admitted to the hospitals, and also it also covers the deaths that happens on the given day, not only heat stroke death but also all cause death, because it's very difficult to identify other deaths that might happen on account of heat. So the idea is to see how all cause death vary with the temperature related and heat stroke days related information that is provided by meteorological department, and that analysis is done every summer after the data has been collected for March to July from all 23 heat prone states listed by NDMA. We also work on providing alerts on air pollution, heat waves, and disasters such as floods, which are actually being prepared by organizations such as IMD and Central Pollution Control Board. But we help to get these alerts, which we receive from these agencies, and been sent to all district officials from both our website and also through WhatsApp groups. And we've also worked with the NHM to upgrade the Indian public health standards to incorporate the principles of green and climate resilience in health sector infrastructure, and henceforth all new health centers developed in the NHM will be compliant to green and climate resilient principles. We've also been working on developing vulnerability assessment tools. The tools have been developed and was pilot tested in 4 states and will gradually be undertaken for the other states. Every year since last 3 years, we are meeting with all the state program officers for annual PIP meeting. That's when we discuss the plans for the next year in the activities listed under the program. And then we also have a national review meeting once in a year to hear and share with each others what the states have been able to do. And each state is required to prepare a state action plan on climate change and human health. The drafts have been prepared by over 29 states, but they are being in process of updating because they are providing feedback have been provided to them by centers of excellence, and they are now into preparing the next draft of it. We, as I said, we have this joint steering committee chaired by the Secretary of Health and Secretary of Environment with representation from all other ministries. We also work very closely with Ministry of Environment and various related organizations like IMD, CPCB, NDMA. We have 18 centers of excellence, work with other health and non-health related programs and other UN and other NGOs and professional body. In research, as I said earlier, there is a research committee under ICMR, which has been recently formed under chairmanship of the director in Delhi. And the purpose of this research committee is to identify research questions related to environment, health, climate change, and air pollution. And once the major areas are identified, research proposals will be called by ICMR and funded by them. We also support the Ministry of Environment in their environmental health profile study, which is being done in 20 cities. In year 2018, we had a workshop organized where more than 30 institutions presented the work done in India on air pollution and health work, and we compiled them and developed the compendium of that work. Some of the IEC posters that have been developed by us and by the states after translation. Again, another posters by states, videos, awareness activities of different type, whether traffic policeman or school children or interns or block health mailer, all type of awareness activities. Then training programs, online programs while during the COVID time, but otherwise we have physical training programs by the states. Then national workshop, the left one was from Kozhikode, the right one was from Ahmedabad, where all state program officers got together to review specific initiatives taken by the states to learn and implement in their own states. Manual developed by us, community level manuals, and strengthening of health sector, developing heat stroke wards, water corners in most of these places so that the affected 23 vote prone state are prepared to deal with certain patients. Developing the facilities to become heat resilient and climate resilient. For example, this is providing solar panels in heat health centers, cool and green roofs, rainwater harvesting, gardens in health centers, and community level actions like cool roof at slums and public places, etc. That's it. Thank you.
Thank you, Dr. Akash. But I want some clarification from you. Hello?
Yes, sir.
Actually, whether you are having any collaboration with the livestock departments or the ministries, because for achieving the goal of the One Health program, the contribution of or the collaboration between the livestock sector is very important.
Yes.
So whether do you have any collaboration or some type of steering committees collaboration between the Department of Animal Husbandry or Department of Agriculture Research Education?
Yeah.
Because these two institutions are having so many institutions which are very much recognized and having the research capabilities as well as some programs.
Yeah. So in the beginning of my talk, as I mentioned, that the purpose of this particular program is not to address One Health. There is another program which addresses One Health. It's called a One Health program. Previously, it was a program which was called Intersectoral Coordination Program on Zoonotic Diseases. But now it has been now coined as One Health program. And that program is primarily working on zoonotic disease, and therefore an important aspect for that program is to work with animal health sector, whether it is husbandry department or whether it is wildlife sector. So both wildlife sector and animal husbandry department are main partners of that program. They had previously also existed in separate zoonotic programs. They have there is a national program for leptospirosis, there is a national program for rabies. So there were some sort of coordination between these sectors for rabies and for leptospirosis. But then when we had this program of intersectoral coordination, then all zoonotic diseases were covered. Now that is being converted into a One Health program to have a larger mandate. And one of the work that is happening right now is that program as well, in the same fashion as I mentioned, we have joint committee being chaired by the health secretary and the environment secretary, and all other representatives of different ministries are there. There also there is a sort of a declaration between multiple ministries, and one of the major activities that they are planning to achieve is opening up a One Health cell in all the ministries. So each ministry will have a nodal representation who will address issues related to One Health, whether in animal husbandry department or in the wildlife department or in Ministry of Environment or any other ministry that may be relevant.
One question, myself, one question is there in climatic control, is there any intersectoral coordination? For example, sir, Akash Srivastava, sir, is there in climatic control, management, is there intersectorial coordination in climatic control? But climate is related to many things.
Yes. So
Many sectors.
Yes, sir.
Yes, sir.
First of all, the nodal ministry for climate change is the Ministry of Climate Change. That is MOEFCC, or you call it Ministry of Environment, Forest and Climate Change. That is the nodal ministry. The purpose of that ministry, the mandate is to address mitigation of climate change. Right, so all areas that relate to bringing down the carbon emission in this country or increasing forestation, all those activities are on the agenda of the Ministry of Environment, Forest and Climate Change. Now, we in the Ministry of Health do not have the responsibility to mitigate the climate change, but our work is to increase the adaptation of the health sector to the impacts of climate change. So that's what our role is. But by making this intersectoral committees in which both Ministry of Environment and Ministry of Health are co-chairs, as I said, in that way, when sit together as co-chairs, all other ministries as representatives, we bring on agenda what are the issues which climate change is impacting health, and how would the health department want the climate change ministry to address them. And then those areas are provided as minutes of the meeting, and they are being followed out by respective ministers.
Thank you, Dr. Akash. Could we go break here for lunch? Hello? Kindly unmute.
जो सब लोग बोलेंगे, if anybody wants to break for 10 minutes or we continue, and in between वो working lunch हो जाएगा.
No, if you want, then we can invite Dr. Jyoti Mishi. She is already there.
सर थोड़ा ब्रेक कर लीजिए आधे घंटे का सर, तो फिर कैसे होगा?
We will break for 10 minutes. Okay.
10 minutes.
Dr. Jyoti, please. You will.
No problem. No problem.
Can you finish in 10 minutes?
Yes,
2:45 we will start. That's at
Yeah, you please go ahead. Please go ahead.
2:35.
2:45 you start. Okay. Thank you for being with us. Now we can take lunch or next. It has been a very hectic.
Okay, Dr. Jyoti.
Thank you, sir. Namaskar.
Namaskar.
But I have one point before you go for lunch, that National Program on Climate Change and Human Health. I feel that this is a climate change also, then its impact on the human health also. But it would definitely have impact on the livestock and other sectors as well. So that is my take on that.
That's why I raised the issue with Dr. Akash. Because it is our livestock sector also relates to the climate also.
Okay,
because a lot of changes are being taking place in the reproduction and health in livestock sector.
Possible to have that. So I won't come in between lunch of Dr. Chaudhary and Dr. Uday. आप lunch कर लीजिए. So I will meet.
Yeah, you please start. You please start.
We'll come after 15 minutes, sir. What I am directed chairman, sir.
Okay.
ये नहीं डॉक्टर साहब 10 मिनट का लंच ले रहे हैं ना 2:45 तक.
Okay.
Let's.
Okay. We are breaking for lunch now.
Okay, sir.
Yes, we meet again at 2:45. आप start कर देगा.
Okay.
In that I have a couple of videos. Whoever is connected, he can see the videos.
Okay.
Okay.
डॉक्टर इसकी आवाज खोल रही है।
आवाज तो आ रही है। आवाज नहीं आ रही है क्या?
नहीं, वीडियो की आवाज नहीं आ रही।
तो तुम ये करो फिर, इस वीडियो की आवाज नहीं है, इसके बैकग्राउंड म्यूजिक है खाली।
ठीक है फिर, ठीक है, रहने दीजिए।
इस वीडियो की आवाज नहीं। इसकी आ रही है आवाज?
नहीं, इसकी
आवाज
भी
आ रही है?
नहीं, नहीं आ रही है इसकी भी।
तो इसमें मेरे को तो आ रही है, सुनाई नहीं।
नहीं नहीं आ नहीं रही है।
अनम्यूट करना, वो तो अनम्यूटेड ही है। अच्छा मैं देखता हूँ। मेरी आवाज तो अनम्यूटेड है जैस।
हाँ आपकी आवाज आ रही है।
तो इसकी नहीं आ रही है क्या?
नहीं
नहीं, वीडियो चलाइए दोबारा।
वीडियो दोबारा चला देता हूँ। अभी आवाज आ रही है अब?
नहीं, नहीं आ रही।
नो वीडियो।
इंजाज तुम नहीं चलाओ।
ऑडियो नहीं है।
मेरे को तो आवाज आ रही है।
इधर
ठीक
नहीं
है,
आ
आ
रही।
रही है, आ रही है, आ रही है।
सही है।
आवाज क्यों नहीं आ रही बेटा इसमें? आवाज क्यों नहीं आ रही?
अरे
सही
ऑडियो में ही प्रॉब्लम।
दो लक्ष जमा करें, 3 से बात करें। Start topic. So So I'm sure everyone must have enjoyed whosoever is with us at this time. So, Dr. Lal Krishna, are you there? Dr. Lal Krishna?
I am here only.
No, you are here. I can see. I'm just trying to find out. There is our chairman.
Oh, he must be having food.
Hey, food
Dr. Lal Krishna is here, but he's
yeah, he is back. So I give mic to you again, Doctor. Hopefully everybody is in, and kindly start with your session. Dr. Kembavi, have you come? Because he is noting down the proceeding for the whole day. Na?
Ravinder.
His presence is more important.
His presence.
Just a minute, I'll ask him.
Should we start?
सर नमस्कार।
Yes, sir. Yes, sir.
आपने खाना तो खाया नहीं होगा इतनी जल्दी।
नहीं, खाना तो अब सुबह ही हुआ। I'm just finding out Dr. Kembavi. He has gone for the lunch, I suppose.
Okay.
Give me a minute क्योंकि उनको ना he has to note down.
Dr. Kembavi, sir, kindly speak.
एक बार फोन कर दो। चलो नहीं तो मैं नोट डाउन कर लेता हूँ।
रिकॉर्डिंग पे डाल दीजिए।
डॉक्टर साहब कर लीजिए शुरुआत।
हाँ ठीक है डॉक्टर साहब। डॉक्टर ज्योति, हाँ स्टार्ट कर लीजिए अपना।
Introduce her and then she will start.
हाँ।
Yes, sir. Slide share. Yeah, sir. Sir, with permission from the chair, should I start?
Yeah, you please start.
Thank you, sir.
Yeah.
I welcome and I feel privileged to be here today. Am I audible also?
Yeah, you are audible.
Thank you, sir. I feel privileged to be here among all the expert dignitaries and before my mentor Lal Krishna sir, and I have seen other experts also. Dr. Uppal is also there, Dr. Ravinder is there, and at the outset, I would like to thank the organizers of this program as they are carrying out annually this program, and I have been a regular member for this program. I thank the Millennium India Education Foundation, Vardhaman Mahavir Medical College, GS Medical College, and KM Hospital, Mumbai, and GLA University, Mathura. I am seeing Dr. Shurveer is also there. So the topic assigned to me today is impact of climate change and environment on zoonotic disease emergence. So I feel that this is a topic which needs to be taken into a holistic approach, because as has been said by other speakers also, we cannot work on environment sector, climate sector, and the zoonotic diseases without involving all the stakeholders, because this is a multi-factorial problem, multifaceted problem, and it requires combination, and it requires the coordination of all the various stakeholders to address the problems which we are having due to climate change and its impact on the environment. Because I have taken those, I think, questions which were unaddressed by the previous speakers, and I feel that we all know that what is zoonotic diseases and infections which have been transmitted between vertebrate animals and man, and this was introduced by Rudolf Virchow. But besides this, more appropriate comparison is the anthropozoonosis, why we can say it is the transfer from the animals to the human, and zoanthroponosis from humans to animals, which are focused predominantly on the path of transmission between humans and other vertebrates. So that becomes important. So we know that zoonosis have been classified as it has various drivers, and it has been classified on the basis of the etiological agents also, be it viral, be it bacterial, fungal, parasitic, and metazoan also. In addition to the etiological agents, we have seen the agent's description considers the factors such as the pathogenicity, its invasivity, and the toxigenicity it has in affecting the impact on the human health. Because whether it is the animal component or it is the human component, it has to be taken into a coordinated approach into one health aspect only, because only then we can work, or whether it is the impact of environment and climate. So we need to address it from that angle. So this has been a normal zoonosis which has been caused by different etiological agents, and we have been seeing the agents, pathological agents, for example, chlamydia, then rickettsial diseases, then mycotic zoonosis, even parasitic zoonosis. So these there are many diseases which have been unaddressed till now in these etiological agents also. However, presently due to pandemic caused by COVID-19, we have seen that more importance and emphasis is being given on the viral zoonosis, and we have seen that. But however, there are some neglected zoonotic diseases which also needs to be addressed, because environment, be it rising temperature, be it urbanization, be it greenhouse emissions, or whether it is extreme conditions of environment, which leads to a number of the vector viral diseases. So all these factors, they congregate not to one aspect, but they has to be taken a holistic approach in dealing this problem. We have seen that in the recent years, that zoonotic diseases which have been transmitted by mosquitoes and other related vectors have increased. And the rise in the global temperatures has created a favorable conditions for breeding of the specific vectors, especially in the poorly developed countries. Additionally, what we have seen, the increased precipitation and flooding conditions in certain areas, they have perfected the ground for breeding grounds for vectors. However, the flooding conditions, they have also created a better environment for transmission of these diseases. Now we have seen that among the environment factors, we have seen that zoonotic viruses which were localized to areas with high temperature or tropics, they have now been observed in the subtropical climates also. And temperature changes have also affected the geographical regions, that we have seen that they didn't have previously those diseases, but we have seen rise in those diseases. And we have also observed that the people's general health may also deteriorate, making it easier for zoonotic infection to spread, as has been seen in the Zika viruses. In less developed countries, we have seen that increase.
Madam Jyoti ma'am, आपका slide move नहीं कर रहा. Kindly move your slide according to topic.
Oh, just a minute.
हाँ, slide एक ही जगह पर है.
Just a minute. It is moving now. Yeah.
No ma'am, until then. Kindly click second or third slide.
Moving now?
No, ma'am.
No. I was thinking that you are giving the introduction.
शेयर करो.
अब दिख रहा है सर?
Kindly click.
Is it moving now?
No, ma'am.
From here, it is not moving.
अब मैम इसको फिर दोबारा कर लीजिए.
आप देख लीजिए, मूविंग अब कर रहा है.
नहीं
नहीं,
मैम,
मैम।
दोबारा आप
दोबारा शेयर करिए दोबारा।
आप इसको बंद करके दोबारा करिए मैम।
अच्छा ठीक है, एक सेकंड।
बंद करके दोबारा शेयर करो।
यस मैम, आप मूव कर रहे हैं,
या
रहने दीजिए। ठीक है, रहने दीजिए। यस यस।
स्लाइड शेयर नहीं करो, ऐसे ही रखो।
नहीं, अगर आपको
ले लीजिए।
अगर किसी दूसरे स्लाइड पर जाना है तो पेज डाउन करके या एरो नीचे क्लिक करके आप कर सकते हैं। जी हाँ, अब आ गया। ये इम्पैक्ट ऑफ ग्लोबल वार्मिंग पर है अभी।
इम्पैक्ट ऑफ ग्लोबल वार्मिंग पे आपका है ये स्लाइड।
स्लाइड नंबर 9 है। ठीक है।
दोबारा कर दो, दोबारा।
ये ठीक रहेगा।
ठीक है मैम, प्लीज कंटिन्यू। यस, इट मूव।
चल रहा है मैम, चल रहा है। प्रेजेंटेशन मोड में ले लेते तो ज्यादा बेहतर है।
स्लाइड शेयर में देख लेना हो रहा है कि नहीं। पीछे है ना स्लाइड शेयर में प्रॉब्लम। इट इज मूविंग।
हाँ।
नहीं, कहाँ स्लाइड शेयर में कहाँ मूव कर रहा है?
स्लाइड शेयर में नहीं कर रहा है।
अच्छा।
मैडम, ये साइड में दिख रहा है स्लाइड शो, ऊपर कट कर दीजिए। ये रिज्यूम स्लाइड शो, उसको कट कीजिए।
अब ठीक है।
हाँ,
अब तो चल रहा है। ठीक।
जो स्लाइड पर आपको जाना है उस पर क्लिक कर दीजिए।
फिलहाल चलेगा इसी पे। ठीक है।
ठीक है मैम।
इसी पे कर लिए।
I think I was on this etiological agents of zoonosis. They have been classified as bacterial, viral, fungal, and we have been working on these. But besides these etiological agents, we also need to consider the factors such as pathogenicity of these etiological agents, then how much invasive they are, and also their toxigenic impact on the particular subject. So that is also important. So I want to emphasize that besides these etiological agents, not only bacterial and viral, but we need to address the problems which have been caused by parasitic zoonosis, mycotic zoonosis, then rickettsial zoonosis, and protozoal zoonosis also. So these, because am I audible?
Yeah.
Because in the current pandemic, we have seen that we have given much importance to the viral zoonosis. Even though this is important, because most of the emerging and re-emerging diseases we have seen have come up in the recent times, and since 2005, we have been seeing an increase in the ingression of these exotic and emerging diseases. And we have seen, and we now need to be well prepared for another outbreak, because we don't know, keeping under consideration the climatic changes and the impact of the environmental factors on these pathogens, on the human health, on the animal health, and also on the soil health. We need to address these problems also. So we have seen that in the impact of the climate, we have seen that the diseases which have been spread by mosquitoes and other related factors, they have increased in the recent years. And the rise in the global temperatures, they have also created favorable environment for breeding of the specific vectors. We have seen that these have in the animals, we have seen blue tongue disease and other arboviral diseases. They have increased incidence we have seen. So also we have seen the increased precipitation and parallel flooding conditions. They have given a congenial atmosphere for breeding of the mosquitoes and other vectors. And also we have seen the with these temperatures, whether it is due to flooding or extreme climatic conditions, we have seen the possibility of the waterborne infections also. Then because humans create ecologically simplified landscapes that favor some wild species but not the others. But there is an exploration about the possibility of those species that tolerate the changes which have been made by humans, that is the modified environment. And in that context, synanthropic infectious agents. So they move around they are restricted to the domestic animals. For example, we have seen that bovine tuberculosis, ringworm, and listeriosis. And transmission of these diseases, it occurs aerogenically or through conjunctiva or through percutaneously. Then we have seen that in exanthropic infectious agent cycle, they are within feral or animals which are living outside the domestic boundaries. For example, tick-borne or arboviral infections, and we have seen. And we have also seen the impact of the climate change on the hematophagous vector also. We have seen. So they have been instrumental in increase in the, for example, CCHF and such diseases, Japanese encephalitis. So these impact on environment and climatic conditions, they have given rise to these type of the vector-borne diseases also, and from one species to another species also, due to degradation or due to the capacity of the humans to create an environment of their own choice. So that is the reason for development of the many of the emerging diseases. Now we have seen that besides this, zoonotic viruses which have been localized to some areas with high temperatures such as tropics, they have been observed now to spread to the subtropical areas also, and even with high altitudes. Then temperature changes in various geographical regions means areas that were free from certain diseases now see a rise in the infection prevalence. So we have seen that in the recent past in the livestock sector, we have seen the ingression of the lumpy skin disease. We didn't had observed that lumpy skin disease earlier, but what we have seen, this is an possible and variation of the pox virus, or we in presently also we are vaccinating with the goat pox vaccine, even though candidate vaccine is in progress of development for lumpy skin diseases. And we have seen that it is almost endemic in 23 states now in India. So we need to work on those diseases and which has its origin from the climate, from the climatic changes, or what impact it has on the livestock sector vis-a-vis the public health also. Then even the human health may deteriorate, making it easier for the zoonotic infection to spread, as seen in the Zika and dengue, which are now global threats. Because it is also the idiosyncratic response of the individual animal and the innate immunity, what is present in the one person, one subject. So it also has its impact in development of the said diseases. Now, in less developed areas, we have seen that increase in droughts and flooding has reasons for cutting the fresh water availability, and it is causing the contaminated zoonotic waterborne diseases such as schistosomiasis. So we need to not work on infection prevention control, but also take measures for education, awareness, and see how we are able to provide clean and safe drinking water also, because that is also a major source for development of these such type of diseases. The changes in climatic conditions have also forced pathogens and vectors to develop adaptation mechanism, because if there are changes in the climate, or there have been forced mutations in the pathogens or the antimicrobials which we are giving to target a specific pathogen, there may be several channels developed by that pathogens to evade the antimicrobial or any drug which is supposed to act on that etiological agent. So it is not only the effects control mechanism or the cell wall or other drugs which have become, we are seeing the problem of the drug resistance also coming into such areas, and where we are seeing that the major and the high group of antimicrobials, they are not being effective. And even we have seen that how that problem needs also to be controlled, because in the COVID-19 region, we have seen that a lot many people have taken azithromycin continuously, and we have seen that how misuse of those antimicrobials have led to development of resistance, whether it is a UTI prone pathogen or other pathogens, which also this is also due to climate change, and we need to address collectively these problems also. And diseases have become resistant to conventional treatments, because we are working on antimicrobial resistance also. Then changes in the climate increases the resistance of the microbes such as bacteria and viruses that I have already discussed, making treatment more difficult and contributing to increase in disease spread. Because in the COVID-19, because our institutes were also carrying out human COVID-19 testing, our 5 institutions, about 6 lakh human samples have been tested in our labs, and we have observed that we could find COVID-19 positive samples from the canines also. So this is not a mere association, or whether it is a transmission from animals to humans or vice versa. Everything can be possible, and we need to work on the pre-warning, forewarning, and monitoring of and prediction of these diseases, such diseases. So we need to have such preparation of the system overall, so that we can have well in advance information about the outbreak of any such pandemic which may affect us anytime. So these preparations and such type of strategies needs to be taken into cognizance. This is the impact of the global warming and geoclimatic variations. So it can affect either due to, even we have seen overpopulation in the less developed countries. In India also we have. Yes, it is moving. Then we are seeing the greenhouse gas emissions. Maybe livestock sector is responsible for it. How feeding strategies and fodder strategies could be employed for reducing these greenhouse emissions, because with the economic strata going up, people are going in for the nutritional security also, and animal protein being a very important component of the diet. And even we have seen that how deforestation and urbanization have impacted the human health, not only livestock health. Shurveer Singh ji, you can mute. How it has impacted the health. We have seen that overpopulation and all these factors, they have a role for increasing the temperature gradient. Then they can also alter the wind speed and also increase the soil movements, and like dust is moving very harshly. And because I was just now talking to Dr. P.P. Gupta, he's saying that a lot of dust is because their home is getting renovated, and he's developing those respiratory symptoms. He is having flu type of symptoms. So even the alteration in the wind speed. So these are the most important environmental factors which needs to be taken cognizance of. Then this may also lead to the soil-borne diseases, which are very important, because soil health is equally important, as has been specified by Dr. Shurveer also earlier. Then in this increased temperature gradient, it can melt the solar and ice, polar ice glaciers, and it can increases the sea level, and it can lead to floods and increased precipitation of the diseases, flooding, and those diseases, they can be very harmful to the human and also to the livestock sector. Then we have seen that how this deforestation have impact on the wildlife. Then changes in their reservoir and in their vector distribution. So it has impact on all such because parameters and drivers, they have to be taken into cognizance, and how it can change the complete habitat, because we have seen there are a lot of problems, monkey menace is there and other problems are also there. They are due to the deforestation and urbanization, and then lack of boundary spaces between the wildlife and the human habitat. So how the ecological system is changing, and how the evolution of these pathogens is also having a drift towards the habitats, because those diseases which are not present in the humans, they have slowly ingressed into the human health component. So those factors we need, how there, if there is a change in the that land use pattern, so it has greater impact on the climate also, and vis-a-vis the vector-borne diseases and other diseases which are soil-borne and water-borne diseases also. So they play an important role. Then we can say, and it also creates additional breeding sites for the vectors to breed. And so we have seen that how this wastewater and how this the contaminated water going into the marine sector, into the aquaculture sector, and how though that can be a breeding ground for various diseases which may be ingressed into the human sector also. Just because of shortage of time, I am just limiting this thing. Then globalization, international trade, then land use changes is very important, because I was seeing the data for the last 20 years, how the land use changes pattern and how much there is reduction in the land use, and how it has impacted our ecological system, our ecosystem, and our biodiversity maintenance is very important. And hence the government of India has come into, we have seen that National Tribunal for Green, and they have come into picture, and we need to maintain that reservoir area for these wildlife and for other system also, because this is a complex system and everybody needs to grow equally. Then changing climatic conditions may also be associated with the spread of very dreaded hantavirus through impacts on hantavirus reservoir population. We have seen how, and it has been estimated that about 60,000 annual deaths are attributable to rabies and other zoonoses, avian flu, Ebola virus, or Rift Valley fever, which pose additional risk on the human health and also on the livestock health. Then just briefing some of the emerging viral infections in India and in which states they have been located. I thought this is important and I should come up with. You see this Nipah viral in where it is also emerged in the, not in the Kerala only, so how slowly into the other states also. Then hantavirus we have seen in Chennai, see how it is coming, and then chikungunya fever, it has a re-emergence in the Andhra Pradesh in 2005, and how human enterovirus it is hand, foot and mouth disease we have seen in Calicut and Kerala also. And similarly, we saw H1N1 pandemic influenza A in Hyderabad, and first laboratory confirmed the report in this from the human. Then Chandipura virus and CCHF, Dr. Kamlesh is working in this area from the Gujarat. He knows that he has discussed this. Now, I would definitely go into this aspect. New challenges to animal and human health. Increased incidence attributed to fluctuating temperatures, causing prolonged periods of vegetation growth, and thereby allowing zoonotic pathogens and related vectors to have more suitable living conditions that promote their survival and breeding also. Then climate change can alter the conditions for pathogens and vectors. And we have seen the signs of increasing spread of West Nile, CCHF, and other viruses, as well as the establishment of new vector species. So when we were working on blue tongue virus, Dr. Lal Krishnan knows. So we were working on the culicoides species. So we could see that there have been number of these culicoides species which were not identified, but we were able to identify those species also. So that means there has been changes in the vector species also, and we are able to get new vectors and new species, changing species in different parts of the world. And also we have faced that in the India also. Then effect, it definitely has the impact on the livelihood and economies. We have seen that these illnesses have impact on human and animal health, leading to reduced the quality and safety of milk and eggs get sampled. So we have been working on the outreach program on monitoring drug residues and environmental pollutants. And we have seen that how we were able to identify the heavy metals, pesticides, and other allergens from the livestock products and others also, soil samples also. Even though most of the samples were within the permissible levels, and but anytime this balance may be hampered, and we may see such diseases. And we have seen that 13 most widespread zoonoses had significant on poor livestock workers, because there is very less margin and distance between the animal and human. There is always a human and animal conflict. And our poor livestock farmers, they have very less land usage, and so we are seeing that almost 2.4 billion disease cases and 2.7 million deaths per annum in humans also. Diseases like rabies, leprosy, and leishmaniasis, they primarily affect the disadvantaged populations in low-income settings. So in such cases, we can give them safe water, clean water, so and also make them aware about the changes they can put in their daily routine, like hand washing and other things. So this is very important. Then what we can do, effective management and sound ecological understanding of zoonotic systems can prevent many infections from spreading from human beings, especially conditions involving vectors such as ticks, which also knows that management may be increasingly compelling when targeting at the root cause. So management is very important, and we need to go into the evolution of these pathogen transmission dynamics of these pathogens, and how these pathogens are evolving in different systems, because it is not that they may they may grow or they may show pathogenesis on one aspect in one animal, but in the other species they may show a different type of pathogenicity. So we need to have a full ecological understanding and evolution dynamics of these pathogens also. Then interventions targeting vectors and pathogen transmission, wildlife host, that may be very effective in the.
Dr. Jyoti, please.
Sir, I am moving. I will take, because yes,
I
will now.
Means conclude your talk.
I will conclude, sir. Just a minute. Give me 5 minutes. If you permit, sir, won't take much time for these publications. I was seeing, because this is not presented by others, I was seeing the publications for these changes, and which have been shown by other workers throughout the world. And in the 2020, we have seen that there are almost 76 publications on this aspect. Means that in 2000, there were 1 or 2 publications. There is a rise in the publications. So we have seen the peak of the publications coincided with the COVID-19 pandemic, whose first case was reported in the Wuhan, China. And then we also think that bats were believed to be reservoir for SARS-CoV-2. But still, the upward trend seems to be in line with the growing public health threat of zoonotic diseases. Then I also collected this bibliometric analysis of Scopus database through Bose River, and it has been seen that The primary sources are periodicals such as Parasites and Vectors Journal. Maybe anybody amongst you must be interested in veterinary parasitology and scientific technique and PLOS neglected tropical diseases. So there have been articles on in these journals. Then the top affiliation was from the USA and CDC. Then what are the lessons learned? The avian influenza of 2005 highlighted the interconnected animal environment and human health. Then early onset of winters, they increased wet condition and amplified the intensity of the pathogens. Then global climate crisis also can alter nature of zoonosis through its impact on temperature and precipitation. So infectious agents like H1N1 influenza and more recent pandemic 19. So such diseases, they can also reach the pandemic status. Then impact of factors on climate-driven projections like zoonotic diseases have originated and carried in wildlife, and then they started with series of spillover events and subsequent adaptation of the pathogens from human to human transmission. And we have also observed that external drivers produce suitable conditions for expansion of these zoonotic pathogens. And often these drivers are ecological, economical, social, and they are political forces functioning at various geographical and administrative territories, because whether it is deforestation or some site of developmental programs. So hotspot for zoonotic disease emergence, they are the most prevalent and densely aggregated, and therefore zoonotic disease dynamics cannot be solely projected by the models that consider only climate drivers. This is very important. And then we have seen that zoonotic disease dynamics, there is ample knowledge of the role of other global processes such as land use change, urbanization, international trade, and socio-economic drivers. So these global processes and interactions between them likely have a robust and immediate impact on future zoonosis burden. And we have also found that socio-economic and political instability in a region, so it can also have impact on the zoonotic disease dynamics. And these are the zoonoses we are carrying out under ICR, and we are working in disease surveillance, epidemiology, disease forewarning and informatics, outbreak investigation, then vector surveillance, then diagnostic services, because for any surveillance, we need to have point of care diagnostics effective so that we can carry out the surveillance. Then capacity building, we are working on these areas. And these are the major bacterial zoonotic diseases we are targeting. These are the, I won't read out just because of the shortage of time, and these are the parasitic. And there are been major institutions, IBRI, Nivedi, Nishad, and there are other CDDL and RBDL labs which are working in this area. And this is the Indian Council of Agriculture Research contributing to the zoonotic diseases. We started with since working in 2009 only, and before that, under now that has been upgraded to the One Health program. So we are working. We have been working on rabies, brucellosis, leptospirosis, Japanese encephalitis, CCHF, and including AMR also, and on the focuses on the exotic zoonotic diseases at Nishad. Then very important, we have annual pathogen repository collection at NCVTV, NRC Hisar, and our ICR is also having collaborations in the One Health area with other sister ministries. This is the One Health program. We are working with other stakeholders, and our program 2009, which was started at the time of Dr. Lal Krishna, it is 21. Now it has been upgraded to Indian Network Program on One Health approach to zoonotic diseases. That what is important is development of uniform data storage infrastructure, which needs to be established in collaboration with all stakeholders. That's very important. So we need few points. I would, this be probably my nice slide, what we need to do for development of, because zoonotic diseases can be addressed to one health approach and core competencies. need to be developed. Identification and prioritize zoonotic diseases based on the geographical zones or states. Development of strategies to tackle the newly prioritized zoonotic diseases, because that is very important. We cannot develop facilities for all the zoonotic diseases at one place. So impact analysis, risk assessment analysis, everything is important for prioritizing the zoonotic pathogens. One health approach for investigation, surveillance, and disease risk assessment is critical for effective control in the humans, because everything is correlated. Then rapid response teams to outbreaks should consist of experts. Then surveillance is very important. Surveillance is the backbone for getting the national database. Then epidemiology, informatics, forewarning of zoonotic diseases, communication, coordination, awareness, collaboration among animal, human, environment, wildlife, and other sectors is important. Then I would definitely stress and emphasize on infrastructure and capacity building, development of applications, ICTs, and awareness programs for One Health, and infrastructure, expertise, and information registries to be made. And none the least, most important is the evaluation of the data from all the stakeholders and its interpretation for formalization of the strategies for the future roadmap. So thank you, sir, for a patient hearing. Thank you all for giving me this opportunity. And I feel sorry for my error in sharing the screen for a time. So I have cut my presentation. Thank you, sir. Thank you, sir. Floor is with you.
Thank you, Dr. Jyoti. I think you have given a overall picture of your program which are already going on in your council, and the collaboration which you are going to develop or you have developed with the other organizations.
Only some of the programs, sir, I have given. Yeah.
Okay, this is good. At least whatever the programs were initiated during my tenure, it is going on very well. Because I have already reviewed some of the programs in different institutions. So I think that will help us in achieving the target of One Health program from the veterinary point of view. Hello. So now we are not going to give the concluding remarks, because all the four speakers have given a good contribution about the climatic change in the behavior in the animal as well as the human beings, and the diseases which are going to be appear or emerge in near future, and also the national program which are going at the national level by the government of India. So I think that that would enough for me to contribute here, and I must thank the organizers who have given me an opportunity to chair the session. Thank you very much.
Thank you, Dr. Lalkisha. Thank you, Dr. Jyoti. Thank you, everyone. Now we have the last session. We are already late by 30 minutes, and we are supposed to close by 4 o'clock, because Dr. Kembavi to sum up at 4 o'clock till 5-6 minutes. So immediately we have with us Dr. Neelima Shah. She is a professor of medicine, DJ Medical College and Civil Hospital, Ahmedabad. So welcome, Dr. Neelima. Of the two speakers, you are already introduced to Dr. Jugal Kishore and Dr. Shurveer Singh. He is our co-organizer. He is the professor of microbiology and biotechnology at GLA University. MIEF has a MOU with the GLA University for promotion and propagation of One Health concept. So I give mic to you, and you kindly request your speakers to sum up their things in 15 minutes each, so that we are at least not much more delayed than we are already. Over to you.
Thank you, sir. Thank you giving me the opportunity, sir. I request Dr. Shurveer Singh to start with, because you have already introduced him. He's a professor and head biotechnology department. Sir has done PhD in veterinary microbiology. He has so many awards. His career, CV is too long. If I speak everything, then 15 minutes will be over in that only, sir. So it itself suggests that we should not waste time in that. Over to you, sir. You have a responsibility to finish within 15 minutes, sir. Thank you, sir. Dr. Surveer Singh.
Thank you so much. At the outset, I would like to thank our organizer, Dr. Kakru, and I have been associated with him for a long time. And we have shared platform at many occasions, even in Mumbai, when this organization, or physically in Delhi, this Mahavir Medical College. And it has been a great experience working with him. But I will apologize for this time. I couldn't contribute much individually, also as with my group, because we had an international this colloquium on paratuberculosis in Dublin, and 3 of us, we went there because we would be hosting this colloquium, the 16th edition in India, and right in GLA University. We are 2 years late since due to COVID, 2020 was a 0 year. So otherwise, this year we would have organized this conference. So in October or November, last week of October or first week of this November, we'll be hosting that International Colloquium on Paratuberculosis. And it is the only organization or the association which speaks for where we can share our researches on paratuberculosis globally, and it is the location is headquarters is in USA. So it was from 12th to 16th of this month, and then I stayed there for 3-4 days. So I apologize, sir, to you, and it has been a great experience working with you. And the most important thing which I find with Dr. Kakru is he is never hesitant, and he himself is an NGO, and to bring in all the this government sector or the private sector or the NGOs on one platform. Because to the disease or the One Health which we are discussing at this level already needs such platforms where every, rather I say, even the stakeholders, our farmers or our cultivators or animal keepers, all are should be the part of this major challenge which threatens, and COVID has amply shown that the existence of the life is threatened, especially the human life. A single virus, what it can do, and I feel that sometimes that these are in blessing in disguise, because the veterinary science in India started with the controlling of one disease, that is cattle plague, and but slowly over the years, due to meet the productivity, our focus shifted towards more production, and we lost in between somewhere of the disease control or the disease health. Being as an animal health specialist in an institute or working in a species like goat, which is a major species or the future species, which is an upcoming industry, rather it has arrived to meet our this food needs. We have been attending these outbreaks, and you see, always I used to feel that during this stress, during summer, in this peak summer or peak winter, there used to be the viral infections. Like even PPR emerged during such season, and it was a new disease. So it is not only COVID, and it has similar effects on the goat keepers. Entire flock was washed out because it was first time. The animals were new, they were never exposed And you see, sir, one disease we could control, and we are celebrating that controlling of some of the 4 diseases, including the RP. So as RP infections were globally eliminated or eradicated, the another virus with the double this thing, I would say power. The RP was a enterotropic, and this was both pneumotropic as well as enterotropic. And 98% similarity, sister virus. Maybe this virus was, RP was somewhere keeping this disease quite in small remnants, because at that time, husbandry was one, it was never so diversified that there's a cattle farm or the goat farm or the sheep farm. They were kept together. So one virus is, once it diminishes, another reappears. Rather, it was there. I will not say that within this short period of 10 years that this new mutation has taken place and it has spread so widely. So it was already there, but it was quite. So we have to think and plan in that way. So this is where the convergence required. Because when health control came, so we were considering these livestock like sheep and goat, they don't have much value. So it's why to concentrate? It's only the goat or the cow or the buffaloes. So we can't leave any corner. So maybe this human being, maybe the animals, maybe the plants, maybe the soil. Because as I said it during my comments, we are embodiments of different elements which exist on this earth in a particular form, and we are working within that same system. So soil health, or even we are talking environment health, but we have to see the health of at the root or the small roots. What is the environment? Is there change over there? Is there any problem in the absorption or the functioning of these roots? So they all are contributing towards this problem. Like I see the iron metabolism has a role in many of the crops, even in some of the diseases. And we are speaking of COVIDly more frequently, but we are forgetting there are a number of diseases which are either slow diseases or they are not so visible, their impact, because they are slow by nature. Like we had this Zaxity-Meadi, which later on turned into this the mad cow disease. Then it was further translated to human being. Like other bacterial infections, I always talk about this tuberculosis. The kind of problems it is giving in terms of productivity, in terms of this the negative energy balance, protein losing enteropathy. So these are contributing and making platform for the more acute infections. So how long we will we have to rethink and our strategy. How long we will be running after one infection, then another coming to another infection, which becomes in endemic. So this gives us a thought that we have to relook at our the social practices, our the way we live. And what has changed over the years. Like we used to take boiling food in India, this after proper boiling and cooking, which was taking care of many pathogens. But that has slowly disappeared. And pathogens are becoming so resistant slowly that they are not killed during this normal heat or normal this climate change, which we are telling. Otherwise, this heat is very good to kill. It was taking care of the infection which are generated in the rest of the period of the year. So this hot summer period used to take care of this from the upper strata of the soil, if you're not taking care of them by ourselves. So this was a nature way. So this is becoming very dangerous. So we should relook in totality about our way of living, the way we used to take food, the way and the problem always lies with the when we are overpopulated. But once it comes to overpopulation, we try to blame on the plants and other things, insects and so on. But we forget what about the human being. On 4% of the world water resources and 2% of land resources, we are maintaining 17% almost population of the world population of animals and human beings. Is it sustainable? It cannot be sustainable. And we are also not able to see the microbes, friendly microbes, which are slowly disappearing due to this climate change, as well as our behavior or our need from the environment, like deforestation. And then now we see a lot of this extremes of the environment, like extreme heat, extreme cold, extreme rainfall, which is denuding our this upper soil, which is good for the cultivation. So these things are all in together. And when I was seeing this beautiful presentation by each one of them, they were beautiful individually, beyond my expectations. Some of the lectures, like Dr. Vijay Chaudhary, and more relevant, I found what Colonel Venkatesh told, or our Jyoti Mishri ma'am told. She told it's not only the we have to look at the host, or only on the pathogen, or on the environment. She spoke of the lifestyle, our lifestyle, or the changes which we have made in our lifestyle, which is creating all this problem. So we have to relook at our entire gamut of this, because if we have to sustain this population over the years in this and to meet their requirements. The another thing, sir, which I have experienced, that when it comes to working intersectorally, we have so many mind blocks. One, this veterinarian versus medical versus or agriculturist, and then within organization, then within institutes, there are departments that try to see that we are the focus. Production is the main. We have nothing to do with this health control and all. So these, till we don't think that any problem as one, we won't be able to come to the solution. We won't be able to work our, and these pathogens will continue to override us. And they are rather dictating our this how we should do, what we have to plan ahead. Like some of the outbreaks which came were very indicative that what is going to be coming, like bird flu, HIV. One by one, these infections were coming. But we were never proactive that something like COVID comes, what will happen? So unless we plan in that way, we think futuristically and together. It's not that when we were had some questions with Dr. Akash Srivastava, he said, no, this doesn't come in my ministry, this doesn't come. But when pandemic comes, every ministry, everything becomes one. Like we have seen how when we are fighting, and the main lesson which we got out of it is it's the personal hygiene, or it's the which we have forgotten long back, and the cleanliness, importance of cleanliness. So these two basic things emerge that even a pandemic like COVID can be sustained. And immunity, sir, is the best way. Either we boost it through vaccine or we boost it through our food. There are two ways. And this immunity, rather we should look at the person when we go for examination, suffering or something, how is the immune system or immune parameters, are they competent? There are talks of the failure of this COVID vaccine, but whether that person has the immune system was competent. But we start talking about this, that vaccine failure or the company failure or something, so many things. So that diverts our attention to the minor things which are non-significant. So it is ultimately our immune system. Like we have seen in the rural area, it was not much of the problem, COVID. Only some migrants, wherever they have gone, they created the problem because they have a very strong system. Ultimately, no medicine, nothing will help you. It is the immune system of the individual which will help you. So we should start looking whether we are healthy in true sense, healthy, our immune system is good or not. And this is a very circumstantial evidence when I say that mortality, why mortality was more in this Spain or US or other developed countries as compared to India. In India, in the metropolitan cities like Delhi, it was a problem. Bombay, it was a problem. Why not in rural India? Because there our food habits are comparatively better as compared to these places. This is why they were able to survive or sustain this kind of infection. So I will not take much time, sir. Everybody, all you know. But so what we have to do when our resources are less, and like running after each disease will never solve a problem. Then there is a priority of disease. We talk about, but that never happens. That which one is more important, which is more serious. Even sometimes some diseases are less, but they have more dangerous or they have more damaging effect on human health. So we have to consider all things are in that perspective. And these chronic infections, which are not visible, they are playing a major role. We have to accept. I have seen by controlling this para-TB through vaccine, I have seen the productivity has doubled, animal health has improved, but it is yet to take a shape or as a national control program. Yes, there are some talks now going on. So this is my, this is why I was always bidding for this conference in India. That once this conference comes in India, when people from developed countries, they speak on the prevalence, 72% of US cattle area are infected with unis. Every presenter will come with, they start with this line. So when they come to India, and when from 26 to 35 countries, and we have our own planners, our researchers together at one platform, maybe we will be able to help our farmers and our other this human population in controlling these infections. So with this, sir, I am very pleased to be part of it. And I look forward, and I know many of these speakers, they were more intelligent, they were more experienced, they were more knowledgeable. But this is what I have to share with my little experience and working in a very small, from a very small place, Central Institute for Research on Goats. I graduated, all my degrees are from Mathura Veterinary College, and now I'm in GLA. So, but I have some perspective which I try to share with you. Thank you so much, sir. Thank you so much. Thank you all, sir, for listening to me.
Thank you, sir. Thank you for completing within a given time period, sir. Thank you very much. Very true, sir. We have to always think of host, agent, and environment. And if we want to prevent the disease, this is really required, sir. And the second point you have very well say is the immunity. Really important, sir. Now I request second speaker to please go ahead with the talk, sir. Dr. Jugal Kishore. He is a director, professor, and head of the community medicine at Vardhaman Mahavir Medical College and Saptangarh Hospital, New Delhi. He has many things to say. He had done good research, 280 papers, 30 books. He has written. He is a co-author. He is an editor. So many conferences. So he is really from CV, I can say he's really a dynamic person. Please start, sir.
Okay, thank you very much. How to start? Yes. Can you see my slide?
Yes. Yes, sir.
And the second one also?
Voice is low, sir.
Yes, sir. Yes, sir.
Okay.
Voice is low.
Doctor, kindly loud your voice.
Okay.
आप अपने आवाज को तेज कर लीजिए.
अच्छा. अभी ठीक है? अभी ठीक
थोड़ा
है?
थोड़ा और करीब सर, माइक से थोड़ा और करीब.
अभी ठीक है चलिए.
Okay. So quickly, I have to talk about intersectorial cooperation, particularly on prevention and disease of public health importance. My topic is going to cover following, like what is disease prevention and health promotion, what are the level of prevention, and then what is public health approach to disease control, what is One Health. I think we are discussing since morning about.
Sir, still your voice is not clear, sir. Volume is low.
Okay.
Hello, sir.
Hello.
Sir, please come to closer to the mic, sir.
Hello.
Yes, sir. Yes, sir.
Now it is okay.
Yes, yes, sir.
Then I'll talk about intersectoral coordination, activity of health department providing scope for intersectoral coordination, life course approach and way forward. So all of you are aware that disease prevention is a kind of procedure. It's actually a procedure through which individuals, particularly those who are at risk for particular disease, are managed or treated in order to prevent the disease occurrence in them. It can be very specific, means population-based or individual-based intervention. So when it is a population-based, then it is more of a public health, intervention. Although it is actually covering the primary prevention, but sometimes the early detection in terms of the screening can also be part of, because all these are preventive steps or preventions only, according to community medicine or public health. But secondary prevention also part of this disease prevention, where you have to focus on early detection to minimize the burden of disease in the population and further transmission of disease. Health promotion is actually focusing on empowering people to increase control over their own health and determinants. There are so many determinants, so how you can, decrease that determinants in the life so that you can, control your own health. And where health literacy and multisectorial actions is required, because there is a need of behavior change or behavior modification. So health promotion and health or prevention are actually sharing most of the goals. The aim is to decrease the risk factors and increasing the health outcome. All of you are aware that there are actually 3 levels of prevention, but 2 are added. One is the primary, secondary, and tertiary prevention. But we have primordial prevention where the risk factor has not developed and we can prevent that risk factor. And where our focus has to be in the early life, like school or maybe early and that. And there is a quaternary prevention where the focus is to prevent the medical overuse, which is happening many a time. For example, like we are using a lot of antibiotic leading to resistance and then problems. So in this case, we are finding that we are facing a lot of the animal issues or animal diseases. The public health approach to control prevention and disease prevention and control is that it involves actually the problem identification and determining the causes and risk factors for that problem, and determining how prevention and how we can decrease or ameliorate the problem, and implementing the effective strategies on the large scale, and later on evaluating whatever program we have launched of its impact. So that is the public health approach for disease prevention. Now you are all aware of there are 4 levels, also 4 types of intervention that can be control, elimination, eradication, or extinction. And control is more of through the intervention to restrict the circulation of infectious disease beyond the level where it is no more a public health problem. Elimination is actually a geographical phenomena where from that geography, the reduction to 0 level of incidence, and eradication is total extermination of the infectious present in that area, or maybe full area. Particularly, it should apply to the whole globe. So that is what we again and again use for this kind of diseases which are there in our genetic related. Now, according to me, the health is actually more personal and rest is environmental and social concept in which the mind is the center surrounded by body, environment, family, society, institutions, nations, and international forces. So they aim to live in peace and harmony. And when we see to this definition, we see that health is actually dependent on so many factors. And that is why determinants are so many. It can be behavior, environment, health system, economic condition, or cultural factors, or maybe aging of the population, or maybe young population, or old feminization, or gender issues, or information, communication, social, science and technology, equity, or social justice, human rights. They are all affecting societies, families, and communities, which is ultimately affecting the individual health. So if we understand this, then we can definitely understand that there are, social factors. Now, more focus is on these social determinants of health, and where we can take an example of how Scotland has used this model, where the child has to be, child health has to be taken into consideration when they are going to the playground. So the playground should be available, the housing condition should be good, education, the social support when he's going older, than family income, the employment, the communities, and health services. So these are all part of the capitals which are there, the social capital or health capital, which are all around. So that is what social capital. So what I'm trying to say that actually, through that we are finding that there are many factors which are affecting our health. So in isolation, the health cannot be achieved. And that is why the concept of One Health has emerged, where the animal, human, and environment, is taken together. And when we talk about this, and sustainable development, food security, public health, they have to be taken into an account when we talk about the health of the people. So physical, socio-political environment is important, and then we can think of. So One Health is actually an example of the intersectoral coordination. And in One Health, we have the environmental health, animal health, and human health, which make the One Health. So it's a collaborative effort in multiple disciplines. So it's a very good example of intersectoral coordination or collaboration. So foundation of One Health is communication, coordination, and collaboration. Collaboration means the human, animal, environment, and all other relevant partners, which is helping to preserve the earth in which the human, environment, and animals all come. And it is already stated that these three big organizations come together. They are collaborating with each other and making this One Health to go. In intersectoral coordination, what is the definition and how it is working? We'll discuss a little bit. It is accepted as one of the guiding principles of health strategy for achieving health goals. And according to International Conference on Primary Health Care in 1978, when the concept of Health for All 2000 came, in Almata Declaration, where primary health care has taken is the method or strategy by which the health for all can be delivered, in which the intersectoral coordination was one of the principles and taken very important. So this intersectoral action for health is defined by WHO as a recognized relationship between health sector and other sectors or another sector to take action in an issue to achieve health outcome to be more effective, efficient, and sustainable. So intersectoral action for health actually emphasize collaboration and coordination. According to the WHO Health Promotion Glossary, the cooperation between different sectors of society, such as public sector, civil society, and private sectors, that is known as a intersectoral coordination. Now, in framework, the biggest framework, we can take an example of vector-borne disease control program. You can see that we have various sectors which play: education, environment, and we have community, workplace, clinic. Take an example of ADs. If you just keep working on community, then it's not going to work because many things is happening in our workplace. Similarly, in community, the social mobilization is very important. And whatever work you're doing, then monitoring and evaluation is part of it. So in government body, it's health, education, agriculture, military, immigration department, or maybe inter-countries relationship, or maybe finance, transportation. You can see that tourism, culture, youth, they are all very important when we talk about vector control. Without the help and integration of these all, it's not possible. And similarly, non-governmental organizations, where we have a private company, the research institution, the bilateral development partner, the multilateral development partners, donor agencies, they are all working together to help at the local level, national level, and international level. Then only the vector control is possible. So intersectoral coordination means the within or itself. Sector means different areas in which the organization is working, or maybe the country is having. Coordination means it's an administrative process which seeks to bring about unity of purpose in order to achieve the common objective or goal. Now, what are the needs? Needs is well understood now. If we want to achieve health of the people, then multi-sectoral coordination is must. Take an example that health is not possible if you don't have a good water supply, clean water, sanitation, environment is free of pollution, you have a good economy, food production is good, or housing condition is good. And each one is different. They have to work together to make the things, suitable for healthy. So that's what the intersectoral coordination means. So to improve nature of program, even for healthcare delivery system, you need to, focus on many things. So there are two types of coordination. One is intrasectoral and intersectoral. Intrasectoral, we can take an example of, like, we have a hospital like subdivision hospital. We have various departments within this subdivision hospital where we have doctors or maybe laundry or drug supply or water supply. They are a part of within the system. But when it comes to the health of the Delhi, then we have health sector is working or have to work with the education, agriculture, fishery, animal husbandry, transport, information, municipal corporation, and voluntary agency. has become the intersectoral. Intra and inter. That's what two types. Now, prerequisite or what are the requirements by which we can have a very good or effective intersectoral coordination? One is the leadership. If we have very good leadership, we found that we can have very good interaction between the different sectors. Another one is a health policy or priorities. If you make the intersectoral coordination as a priority, then it's possible. Or if policies are developed in such a way where coordination is important, then, if you share the common vision and perspective, if you have a feeling of sharing things, then the intersectoral coordination becomes easy. Then defining role and responsibility in a manner where the participation is important of different agencies together, then intersectoral coordination is easy. Then your decision has to be in participatory manner. It should not be in isolation, but every person should come together and take some decision. And developing informal contact with involved groups. So a kind of relationship you have to develop. Any kind of coordination is not possible without you have a relationship with each other, with different departments. There, the concept of family comes. So if the whole country has various sectors, but they are working as a family, then we can work successfully. Otherwise, it's not possible. And we found that the quality improved because you enjoy things, you can deliver good, you can spell out different strategies and procedure in a good manner, and you are more concerned about the quality. So the monitoring and evaluation become a joint venture, and you really strive for the best. That's what required for intersectoral coordination. So applying the life course approach here is actually, in the end, I can say the life course approach is vital because, one has to look into that infancy, childhood, youth, parenthood, adult, and old. This is the life. And each stage requires some different needs. Similarly, every place where we found that different sectors are there, which are supporting and then, coordinating with others. So their life cycle approach can help to grow much faster and better. What are the hindrances and limitations? Limitations are usually, I can say, just because of you believe that maybe I think things will not work, or maybe you don't know about the future. Where the planning is not good, then you can find the coordination is very poor, or the knowledge is not there, the lack of knowledge. And two things are very, very important. One is a negative attitude. ये हो ही नहीं सकता और ये नहीं possible. Another one is a high ego. You think that I am the boss and other people are useless. So when you have ego, then the interaction between others is not possible. So these two are very difficult areas, and maybe I think should be removed. Lack of experience is also, when you are more experienced, when you understand the importance of each other, when you go down and you be receptive of more, and that is a part of wisdom. If you have wisdom, you are more experienced, you are actually understand things, and you are more feeling like to be collaborating with others. And then good leader is the one who are actually removing those conflicts and confusions and making clear things. So lack of leadership, lack of experience, lack of wisdom, knowledge, these are all hindering factors of the coordination. And many a time it is the administrative skills are poor, or maybe techniques which they are using are not good, then we can have a problem of the coordination. And the human knowledge, and I think there are many variables and they need to be understood. So you can see that another hindrances are political parties. Different political parties have different goals, and they just see things from each other. Then size of the country is also a big one. which is also a problem. Complexity of the public administration in different states. We have a different kinds of political parties. The personalities are different. There are so many other factors, like even different types of leaders are there who believe in that, this is the method by which can be done better. Other people have democratic, and a few are having autocratic and leading to many issues and problems.
Hello, sir.
So,
sorry, sir, interrupting, but we are over sipping the time, sir.
Yeah, it's the last one, last slide.
Thank
so
you.
The way forward is, the strengthening of intersectoral coordination between medical, veterinary, and wild sectors and various relevant stakeholders for prevention and control of zoonotic disease. We require trained manpower, sensitization of professionals in all the areas like the medical, veterinary, forestry, or maybe engineering, CPWD or PWD. These people are very important to understand that how intersectoral coordination is important. IC is also very important, increasing the awareness. So that is what I wanted to say. Thank you very much. I think these are all which I have already said. Good political support and long-term and short-term political policy change, existence of a clear mandate, high-quality evidence is required, more research and more cooperation, media support, public support. Thank you very much. If any questions, then I'm there to.
Thank you, sir. Thank you very much. Sir, you have elaborated everything almost. What should be done, what is done, what is left, what we can do, dedication, commitment, everything is required, sir. Thank you. COVID pandemic has learned also, we have learned many things from that also, sir. Sir, any questions or anything, or we can go ahead with the final comments, sir. Uday, sir.
Hello, Dr. Kembavi is going to sum up day's work. He's already here started sharing his screen. Dr. Kembavi, kindly continue. Kindly unmute yourself. आपका unmute नहीं हो रहा है अभी.
हाँ, हो गया. I am very thankful to the Kakru sir for giving me telling me to give concluding wrap up. It is a heavy task of giving a concluding remark, summary, brief, overview, text.
आप फिर म्यूट हो गए. अनम्यूट कीजिए.
ओके, अभी हो गया बराबर.
हो गया.
स्लाइड नहीं हिल रहा है. In the concluding, I will give my observation, summary of action plan, recommendation, next steps, and our activation. Ours is the 12th National Conference of Health Initiative. We have been trying hard to bring a message of One Health approach. It has to some extent, some forwarding is there. See, One Health is nothing but healthy people, healthy environment, healthy animals. So we should strive for this so that each animal or human beings in the environment survives and be fit to live, so that it is a survival of the fittest. Now, there are many strategies which have been tried out: teamwork, strategies, standards, compliance, communications, solutions, and all that. We are trying too hard that matter. Now, today's session was the role of antibodies in diagnosis and treatment of diseases. See, the appropriate technology is very important in handling many diseases, because COVID came when there was no treatment and all that. Then antibodies, the serums of patients who are affected were good, the ready-made antibodies. These antibodies was a good presentation, and it was highlighting many things of antibodies: management of rabies, management of COVID, diagnostic kits where of antibodies are used for HIV diagnosis, pregnancy kit, anti-cancer treatment, and diagnostic for any diagnosis like Western blot, ELISA, etc. So antibodies, we have to encourage appropriate technology so that early diagnosis use biotechnology in such a way that it help in management of cases and all that, and reducing the load of the disease. Second is pox is a vaccine. It was nicely covered by madam, and she was our KM student, and this is excellently presented, and she had handled Nika virus very much in Kerala and in also in Assam. So now covered. It is 12 countries it is was present, but now 50 countries are affected with. We should see that it does not reach India, and our colleague is trying very much. You have to need early diagnosis, prevention and control. So awareness and is very important, and madam has nicely covered this topic of this pox virus. I think so this will not come in India, because already more than 40 people, adult population is more, and they are vaccinated with smallpox to some extent, and this may not come in India. But another this awareness is very important. Then impact of climatic change environment. Everybody is aware that urbanization, internalization, we should not play with the nature. We are destroying our environment. COVID has taught us many things. For example, the air pollution which was in Delhi, after COVID, there was no air pollution. The transportation, everything was nice. But COVID came because of our neglect. We are playing with the nature, manipulating lab diagnosis leakage or anything is there, that we have to change, that we should not destroy the climate and the environment. Otherwise, global warming will affect, and will affect us, and any more diseases, zoonotic diseases will merge, which will have no control. And zoonotic COVID is one which was shuttered or shocked. So similar cases will come. Therefore, the One Health approach is need of the hour, main important. Then is overcoming constraints in intersectoral coordination. Usually there are many intersectoral coordination. Doctors, veterinarians, and climatic or other persons are there. There's the innovative support, uptake of policy. Everybody feels that I am great, I'm there. Nobody is great. We have to work together to achieve our goal, that is One Health. We have to have, if there is goals are not shared, we should share our vision so that we can come together in one platform. There are insufficient personal lack of time or capacity is there, insufficient funding, poor trust in collaboration. Usually when you are collaborating, there is poor trust among the partners. To achieve intersectoral coordination, there should be uniform vision, uniform coordination will be there, sufficient funding should be there, and trust should be there. Then secondly, last, to conclude, there is need of working together to achieve our goal, that each of the every sector should come together and work for humanity. See, to achieve our objective, there should coordinate effect should be there, and each and every partner should come and support it. See, we have got to control zoonotic disease. There are two approaches which are there. Disease-centric approach, which were earlier fought by clinicians. They are only taking a clinic. We should have a public health approach so that public is protected. Disease-centric approach will not go along. Another is health-centric approach. Public health, community medicine, family physician, and clinical medicine. These together should come together, diagnose early detection, and now the last approach is all sectorial management. All the sectors should come together and reduce the disease in this planet and make this planet livable. Happy monsoon. I thank each and all the speakers for for contributing to this, and I thank the organizers and other persons and those who are participants for making this program a great success. Thank you very much. So in brief, I did.
Only before we leave for our respective, one thing I wanted to add to both Dr. Jugal Kishore and veterinarians as well as Dr. Kemboi, because you are from the community field. One area you have missed that is to be included if we actually want to have a better disease surveillance as well as the disease follow-up. That and identification as well. That is our people. Rural people who are keeping animals, people who are in the West agriculture fields, and people who are going to the local physicians. Because they have such, you will come across, you will generate such a data that will add to your research and disease diagnosis approach also. And that will be the actual One Health. Because what is happening, as my fellow veterinarians will also agree to it, in rural areas, wherever you go, first they test by themselves. Because they have age-old, you can say, myths surrounding them, that this animal is suffering from this or this person has got this disease, irrespective whether that is being diagnosed or not. So that data has to be collected. And if you are able to collect, make a pilot project, take one village in your study, and you will find, you will come up with surprising results. And your disease diagnosis as well as prevention will go miles, and you will save a lot of time also. So that is what I wanted to add to it.
Sir, you have to conclude the. Hello.
Yes, please.
So we have to conclude the conferences, the 12th conference very simply. We want feedback from the participants so that we can send a message to the government about what are the measures to be taken.
Right. Because at the end of each conference, we come up with some resolutions also. These are, because today's conference was totally diverse. We have people from the environment, from veterinary, from research as well. So rather, I will request either you and Dr. Jugal Kishore to come forward with your and assign this task to some of your students so they can easily conclude with some resolutions which are pertinent to this conference, because that will be more useful also. And obviously, this like every year, it goes to the different departments at the central level, state level also. So hopefully, I don't know, I don't follow up with them to whether they are adopt anything in their policies or not, but at least we communicate what we have discussed and resolved. So with this, I conclude the day. Thank you everyone who has been patiently with us throughout the day. And I'm sure we are organizing these conferences twice in a year. We'll continue with it as far as we are able to do it. And there are others from every sector. We have people with us. So with this, I thank you once again, everyone, and we close the show.
Thank you, sir. Thank you very much. Bye.
किसी का कोई feedback है तो हम kindly email पे भेज दीजिए, so that we can include in our this. Thank you, Dr. Upadhyay.
बारिश का मौसम है, सब गुजरात में आइए. We have two Jyotirlings are there, so I invite all of you to come and next physical conference at Gujarat.
Okay.
Sure. Kamlesh
जी.
Namaskar.
Jyoti ma'am, namaskar. जी.
Namaskar.
How are you?
Bus fine.
Nirima is my wife too. She's second. You both are professor here in the medicine department.
Too good.
Yeah, toileting at home and in the office also. Kakru sir has witnessed this thing.
Obviously.
Combination. Thank you. Definitely come.
Sir, anybody who is visiting Gujarat, he must give me a ring. I'm staying nearby airport, and I invite everyone for home hospitality.
Thank you very much.
Sir.
Thank you so much.
Live band karo.
Thanks to all.